We have great pleasure in inviting you, especially to this workshop, because this entire conference, under the guidance of Professor Kato and other members of the executive board of the is focused on education. And along with Professor Balamurugan and the team that we have worked with, we decided that we should have a lot of focus on education, and therefore Dr. Bala thought that the pre-conference workshop would ideally should be teaching young neurosurgeons on bread and butter surgeries, and that's how this concept came up. So thank you, Professor Bala, for this wonderful initiative. We have 3 days packed with academics, and I hope that in the virtual space, we don't know how it's going to pan out. The lectures are very exciting. There are people from all over the world who are in the faculty, in the delegates, both in the neurosurgical side as well as the nursing side. So with this, I welcome all of you and wish you a very happy academic weekend, and hope to see you right through. And I hope that we have a wonderful weekend and an academic feast. Thank you very much, Bala, for this initiative, and over to you.
Good morning. Good morning, everybody. And good morning, Professor Kato, Dr. Azmi, and Dr. Sridhar. I think it's a privilege to be here. And Professor Kato, it was tough when the pandemic struck and the Kazan conference had to be postponed to a later date. And when Professor Kato initiated the took the lead, and she said, why not organize a virtual conference? And Dr. Azmi requested Dr. Sridhar, and Dr. Sridhar had no hesitation to say, yes, we will go ahead and do this. I was skeptical initially, and I didn't know how we were going to proceed. But then I think Dr. Sridhar's confidence really helped. And it is a humongous task in this kind of situation to put together a fantastic array of speakers from across the world and put up a virtual conference for the first time. I think this is going to be the landmark in the Asian Congress of Neurological Surgeons. So I think most of the national associations may take this up and start holding their virtual conferences soon based on this conference which Professor Sridhar has organized. So when Professor Kato said that let's get things moving and let's do something for the young neurosurgeons, we thought that we all talk about a lot of cerebrovascular surgery, skull-based surgery, anterior clinoidectomy, cavernous sinus, brainstem. But then most young neurosurgeons or neurosurgeons entering practice are not going to see that day in and day out. They're going to be seeing more things with which they're going to earn their bread and butter. So we thought, why not have something for the young neurosurgeons to do whatever they are doing even better. So we requested about 15 speakers to tell them how to do the basic surgeries very well and give good results by which their practice can improve. And then the more important cases of cerebrovascular, skull base, and brainstem lesions can be tackled with more confidence. So with that concept in mind, we started to put together this small bread and butter session, as we decided to name it, as Professor Sridhar named it. And in the first session, we'll have the spine. And because I think spine is slowly slipping away from the neurosurgeon's perspective and moving on to the orthopedic perspective, I thought neurosurgeons are the best suited to handle this. So we have 5 speakers in the first session. We have Dr. Vijay Shankaran, we have Dr. Krishna Prabhu, we have Dr. Murli Krishna, we have Dr. Ramesh Chandra, and Dr. S.K. Rajan. All of them have done exceptional work in spine surgery. Dr. S.K. Rajan from Delhi has done fantastic work on minimally invasive surgery. Dr. Ramesh Chandra from Tirupati, probably with the largest series of OLIF and he'll be talking to us on OLIF. Murali Krishna will be talking about TLIF, and Dr. Krishna Prabhu on ACDF, and Dr. Vijay Shankaran on microlumbar discectomy. So that is the concept in which we have started this. And after a few words from Professor Kato, we will kickstart the first session. Professor Kato, to you, please.
Mute.
Professor Kato, please unmute yourself.
I can hear. Once again, I thank you very much for Dr. Sridhar and the entire your team. So make such a wonderful the pure web conference as Asian Congress, because this idea is come from me and Dr. Azmi, and Azmi is also very enthusiastic to have such kind of the Congress during this COVID period. But this next 2-3 days, we will have such a dream. So it comes true now. Thank you so much. And as for the education for the young doctors, I think several points. I think already Dr. Bala that he said. Bala is the current the secretary of the Asian Congress, and I think some indication and planning and indication. And also the discussion with senior doctors, some young doctors who will have to do the surgery with the senior doctors. I think it's very important. And also how we should avoid complications. Of course, you should learn the many things from the textbook and also the videos. Repeat the video or study is another very, very important. So many tips and tricks in the video shows us, tell us many important things. And also, I think maybe the video conference, the video discussion after the surgery. I think that those with surgeon. In Japan also we have getting the more and more spine surgery because all time is Japan is very orthopedics is very strong than neurosurgery, but now it's about 50-50. Not still like India or some the Korea. Korea is almost over 90% done by neurosurgeon now. So the any surgery, I think at the very basic thing to the of course very high super techniques the surgery. There are so many steps, and if you have a chance, maybe you should visit the good surgeon and to see sometimes from the beginning until the end. And those attitude is to learn the more and more very skillful neurosurgeon in the future. I admire. I thank you very much once again, the Dr. Sridhar and the Dr. Balamurugan make such a. Thank you very much. ありがとうございます。
Arigato, Professor Kato. Arigato, Professor Kato.
ありがとう。
With that, we will start with the first talk by Dr. Vijay Shankaran. The entire session will be moderated by the speakers. So the first talk will be played out by Mr. Saravanan now. Dr. Vijay Shankaran.
しばらくまだお休み。
Teachers and my dear students, first of all, I would like to thank the organizers, Dr. Sridhar and Dr. Balamurugan, for giving me this excellent opportunity to present in the first virtual ACNS Congress. My topic today is how I do microlumbar discectomy. As you know, this is the bread and butter surgery for many neurosurgeons. To start with, some history. The first reported case of lumbar disc prolapse was described by Dandy in the year 1929. In 1934, Mixter and Bohr first described the removal of extruded disc. They did it by extensive removal of bone and through an intradural approach. In 1977, after the invention of microscope, Yassergill and Casper independently described their first case of microscopic discectomy. In 1978, Williams described his conservative removal of extruded disc, leading to early return of his patients to work. We all follow his technique with some modifications. What are the indications for surgery? Acute leg pain corresponding to the prolapsed disc. The pain should be excruciating in nature and aggravated by coughing and sneezing. Then it is an indication for LMD. But usually we offer them conservative management to start with. If the pain is not subsiding in 2 to 3 weeks, or if there is any worsening of neurological deficit, there are indications for lumbar microdiscectomy. But whenever there is chronic sciatica, it usually warrants surgical management. How to choose the correct patient? For this, proper history and clinical findings are at most important. Distribution of the pain, motor, sensory, and reflex deficit will point out to the root involved. We correlate them with the MRI findings. If both of them correspond, then we offer them LMD. But before offering surgery, we should rule out any associated instability by doing X-ray lumbar spine flexion and extension views. If there is instability, it's an indication for stabilization, not for LMD. We can also identify associated facet pathology, which will explain any postoperative back pain if that is present. Before surgery, it is very much important to exclude pain of malignancy or infection, which usually presents as night pain disturbing the patient's sleep. We should also exclude diabetic neuropathy and peripheral vascular disease. What do we aim at surgery? How will I counsel my patient? I tell my patient that relief of sciatica occurs in majority of the patients, and also relief of neurological deficit also occurs in many patients, but there won't be any improvement of the lower back pain, and the surgery will not guarantee any prevention of recurrence. Prevention of recurrence is purely the patient's responsibility. Good results are obtained by selecting the right patient for surgery and following good postoperative back care program. What is not achieved? This should also be explained to the patient. Surgery does not address the pathology. The pathology is degenerative lumbar disease. The surgery aims only at root decompression and relief of sciatica. So the lower back ache may persist or recur. Recurrent herniation occurs in 4 to 12% of the patient. That's because the annular defect remains open at the end of surgery for several months before healing. Even after aggressive discectomy, some amount of disc remains, and which may reherniate with increase in intradiscal pressure. How to do LMD? During LMD, fragment extraction is the most important step. We always do general anesthesia, very rarely spinal anesthesia when the patient is not fit for general anesthesia. We do this operation always in prone position, and the prone position is achieved by placing bolsters, one at the chest and the other one at the hip level, and there is mild lumbar flexion is achieved by placing a couple of towels on either side at the anterior superior iliac spine. The same position can be achieved with Wilson's frame also, which is shown in the figure on the right side. We can also achieve it with a jackknife position. Preoperative localization of the level is usually achieved with C-arm, but we should have some anatomical knowledge. The uppermost point of iliac crest corresponds to L4 spine, and also the posterior superior iliac spine corresponds to S2 spine. From there, when we run our fingers, the first dip would be L5 S1 interspace, which is usually larger than L4-5 interspace. And also, we will appreciate that L4 spine is larger than L5 spine. While infiltrating the incision site, we can tap the sacrum with the LP needle, which will produce a typical sound with which we can identify the sacrum. These are some of the anatomical landmarks. But we always use C-arm both preoperatively and also just after the exposure of the interlaminar space. During surgery, once we have reached the interlaminar space, we remove bone, all the red shade, bone is removed, but be careful of not removing the pus, which will make the spine unstable. This is a video. The operation is done on the right side. The left of the patient is superior and the right of the video is inferior. The lamina is just separated with from the ligamentum flavum, and then the retractor is applied. With the magnification, the elbow ligament, the ligamentum flavum is incised, and then the probe is passed, the dissector is passed to split the layers of ligamentum flavum. The epidural space is reached. Annulotomy is done with a linear incision, and it's an extruded disc which just prolapses out. This disc is being removed from the axilla of the nerve root in two separate pieces. If the disc comes out like this, it is really good. The nerve root is straight away decompressed. You can also see by this technique the annular defect is kept to minimum size. Once this is achieved, we have certain steps what we follow. We define the annular defect with size, type, location in relation to nerve root, and we also decide whether we are going for aggressive or conservative removal of the disc. And there are other steps to follow, which I will explain in the next slides. The annular defect is assessed by gentle graded passage of blunt instruments. In sequestrated disc, the defect may not be discernible. The large defect is usually defined as 5 mm or more, and small defect is less than 5 mm. We also define the shape of the annular defect and also its type in relation to the nerve root. We correlate it with the patient's clinical symptoms. Regarding aggressive or conservative discectomy, the incidence of recurrent herniation is, of course, it is brought down by aggressive discectomy from 10 to 15% to 4 to 8% by aggressive discectomy. But incidence of discitis, foraminal narrowing, facet arthropathy, and visceral injury are more with aggressive discectomy. So we follow only conservative discectomy for our disc extruded patients. Next step is checking the adequacy of nuclear debulking. This is achieved by passing a blunt angled instrument just medial anterior to the thecal sac and giving a thrust anteriorly over the annulus, which may dislodge some fragments which are present loosely within the disc space. By giving a thrust and passing a disc rongeur at the same time, we take out the remaining disc. We believe that this technique prevents recurrence. Then next step is selective annulectomy. Annular defect is intentionally extended lateral to the traversing root by 5 to 8 mm so that if there is any recurrent herniation, it will be away from the root, thus avoiding symptomatic radiculopathy. In this video, this is the video of another patient. This operation is done on the left side. Once the discectomy is done, there is an annular defect. But when there's an annular defect, but when the retraction is released, the nerve root covers the annular defect. This is the typical case where we do selective annulectomy lateral to the nerve root by 5 to 8 mm. By doing that, what we achieve is any recurrent disc prolapse will prolapse away from the nerve root. Yeah, the upper right image is the nerve root retracted with the annular defect, but then we do selective annulectomy so that the anelectomy defect is away from the nerve root. So any recurrence happens away from the nerve root, preventing any relapse of symptoms. Next is checking the nerve root decompression. This is achieved by Watson chain or nerve root probe, which is passed along the nerve root. If there is any residual compression, then we have to look for any further fragments, osteophyte, or foraminal narrowing, which should be dealt with appropriately. The final steps: we use Valsalva to exclude CSF leak and look for venous bleed. Epidural steroid is instilled in case where there is inflammation of the nerve root. We always lay a fat patch over the interlaminar space and close the fascia with 3O picral and skin with subcutaneous 3O monocryl. We always quantify the disc removed, which is usually 2 ml, 2 to 3 ml. We do certain modifications in grossly migrated discs to additionally removing the lamina above and below. Patients with cardiac vena syndrome and severe canal stenosis, we may have to remove the spine and laminae bilaterally. For lateral disc extrusion, lateral foraminotomy is needed, and for redo procedures, CM has to be used from the beginning, and we use curette to define the laminectomy edge. Postoperatively, patients should have immediate pain relief with no added deficit. We follow antibiotic prophylaxis for further 24 hours. Patients are ambulated in 6 hours time and discharged next day. There is no need for any suture removal, but the patient should follow back care program. The patient should avoid increased intradiscal pressure till the annulus heals, which is usually a few months, by not bending forward or not lifting weights more than 5 kilos. Patient is advised to use lumbosacral belt, limited ambulation for the first 3 weeks. He is advised to use commode rather than squatting for defecation, and the patient should do non-weight bearing spinal flexion exercises from the 3rd week onwards. If the patient is obese, he should control obesity. Complications may happen like intraoperative dural tear with CSF leak, root injury, broken pars, abdominal organ injury. Postoperatively, there may be persistent sciatica, recurrent sciatica, instability, discitis, and wound complications. Management of intraoperative CSF leak is a very good technique to learn. It is usually, if the defect is small, it is sutured with 3 or 4O suture. Muscle or fat plug is used to within the dural defect. Tissue glue is used if available. If the defect is large, we use facial cover. If the CSF leak persists, we do laminectomy and repair. If still we are not convinced, we use a catheter above the level of surgery. Postoperatively, we may use acetazolamide, and patient is preferred to be treated in prone position in postoperative period. Nowadays, with the introduction of endoscopic discectomy, we have to tell you that still we prefer LMD over endoscopic discectomy, because LMD can be done in any type of disc collapse, in any location, any size of disc. It can be done unilaterally or bilaterally with associated facet or ligamentum flavum hypertrophy or lateral recess stenosis. Remember, microdiscectomy does not end with fragment extraction. We attempt to understand the patient's specific pathology. Take-home messages are: selection of patient is very crucial. Post-operative back care program should be taught and should be followed up in the post-operative period. Pre-op correlation with MRI should be thorough. Surgical techniques should be mastered and tailored to the operation findings. This is our team. I thank Dr. Suresh Babu for helping me out in preparing this presentation, and thank you one and all for patient listening.
Thank you, Dr. Vijay. I think, as I told, the speakers themselves will be the moderators for this session. And if you want, the speakers can decide that all the topics can be addressed towards the end, or if you want to start now, you can do that as well. Dr. Vajan, Dr. Krishna Prabhu, what would you suggest? Please unmute yourself, Dr. Krishna Prabhu and Dr. Rajan. Unmute, please.
Saying in case we don't have questions coming in right now from delegates, then we can wait till the end. Do we have any questions?
I can't see any questions having come up. So maybe we can jump everything together.
Hello?
Yeah, we can hear you, Dr.
Yeah, okay, hi. Just one suggestion or whatever. He mentioned that for a case of dural tear he would close out 30 or 40. I would rather prefer a 5 or a 7 because the smaller the needle, then the less the chance. Probably needle is a little bit larger size. The case will leak through that itself. So I would rather prefer a 50 or even a 70 to detect
yes, sir. Agreed. Yeah. We are also switching over to 60 or 70.
That's better. Thank you.
If there are any more questions coming in, then we'll take it towards the end. And I think we'll move forward with Dr. Krishna Prabhu's talk.
At the outset, I would like to thank ACNS for giving me this opportunity to talk on anterior cervical discectomy with fusion. Special regards to Dr. Sridhar for his hard work and teamwork to make this happen amidst a burning pandemic. The indication for ACDF include symptomatic disc prolapse causing radiculopathy with or without myelopathy. ACDF is also indicated in patients with traumatic cervical listhesis. ACDF is usually indicated for a single level or a two-level disc prolapse, disc osteophyte complex, or in a single level ossified posterior longitudinal ligament with myelopathy. Care should be taken while performing ACDF for a patient with traumatic cervical listhesis with disc prolapse. A careful reduction of the listhesis should be done before proceeding with ACDF. Similarly, when we see extensive cervical cord edema in patients with cervical disc prolapse, a special attention to be made to the disc fragments which are adherent to the dura, as inadvertent pulling of the disc fragments may cause CSF leak. In patients with a large disc fragment behind the vertebral body, a corpectomy may be of a better choice. We can also attempt to do a trumpet or wedge osteotomy instead of a corpectomy, but this needs a learning curve. All patients requiring ACDF needs a lateral and the AP X-ray cervical spine to look for the cervical alignment, kyphosis or fractures. Dynamic X-rays in flexion and extension must be done to rule out inherent instability. Patient will need MR cervical spine to look for the level of compression, cord changes and cord edema. A CT cervical spine is advised if there is suspicion of disc osteophyte complex or ossified posterior longitudinal ligament. Patient and his family needs to be counseled on expected rates of recovery like immediate recovery from radicular pain and gradual improvement in his myelopathy. Complications related to surgery needs to be explained in detail before proceeding with surgery. Treatment options include a standalone cage or iliac bone graft, a chiclet, zero profile cage with screws, or a cage augmented with an anterior cervical plate. I prefer a standalone cage without an anterior cervical plate construct. This is an MRI cervical spine of a 62-year-old male who presented with spastic quadriparesis for 6 months. He was Nurix 4 at presentation. His MR showed a C5-6 disc osteophyte complex with cord compression and associated T2 changes, extending from C5 to C7. A CT cervical spine showed a C5-6 osteophyte complex as depicted by the yellow arrow. The patient is positioned in supine with neck extension and chin lift. A neck roll is placed underneath the neck. The chin is strapped to the table and endotracheal cuff pressure is monitored. We prefer to keep it at 20 centimeter water. The level is confirmed with an II and a horizontal skin incision is marked. We prefer a horizontal skin incision as it gives a better scar. The skin incision is made with a knife and soft tissue is dissected off the platysma in a craniocaudal direction using skin hooks and scissors. The platysma is cut vertically and dissection is carried out in a supero-inferior direction. Meticulous hemostasis is done while performing this step. The sternocleidomastoid muscle is defined and dissection is continued.
いいと思いますよ。ね、大丈夫でしたよ。はい、よかったですね。はい。でまた元気で、ね、はい、まずご飯食べられることが一番だからね。はい。
The superior belly of Omaha is identified and divided. This will create a surgical plane to the disc space. Carotid is retracted laterally and trachea along with esophagus is retracted medially. Prevertebral soft tissue and fascia is divided using a scissor and cottonoids. The disc space and the vertebral bodies are identified and confirmed with an image intensifier. The longus colli muscle is identified bilaterally. The muscle attachment is coagulated and soft dissection is done on both sides to facilitate placement of trimline retractors. Retractor blades are placed in the grooves created and retraction is achieved. After identifying the midline, Casper pins are placed in the above and below vertebra. Note, utmost care is taken to place the Casper pins. Pin distractor is placed and distraction is applied. The annulus is incised using a sharp knife. Using a disc forceps and curettes, the disc material is gently curetted. The entire disc space is emptied and the end plates are prepared. Using the combination of straight and curved curettes, the posterior osteophytes are gently curetted. The small bony pieces are carefully preserved. These are used to fill the peak spacer. The PLL is divided using the sharp hook and Carlin knife. There is a large extruded disc fragment seen within the layers of the posterior longitudinal ligament that is removed. The PLL is further divided and removed using a 1 mm kerrison punch. The thecal sac is lax and free of compression now. The disc space is now prepared using rasps of different sizes. A peak cage filled with autologous bone graft is fit into the disc space, confirmed by an intraop image intensifier. The fit seems very good. The Casper pins are removed and the bone wax is applied. Meticulous hemostasis is achieved and the wound is closed in layers. The postoperative X-ray cervical spine done 24 hours after the surgery showed satisfactory placement of the peak cage and the prevertebral soft tissue is normal. The surgeon should be aware of complications. Although anterior cervical discectomy with fusion has extremely low morbidity. Here below are the list of complications seen with anterior cervical discectomy and fusion. The postoperative care includes doing a lateral X-ray cervical spine 24 hours after the surgery to look for prevertebral soft tissue swelling, implant position, and spine alignment. A soft cervical collar is advised for 6 weeks to facilitate bone diffusion. Patients are advised to avoid lifting heavy objects and travel by two-wheelers for 6 to 8 weeks. The follow-up of patients who have undergone ACDF can be done annually with a cervical spine X-ray in neutral and dynamic X-rays to look for bone effusion. In those patients with myelopathy, an MRI of the cervical spine to look for resolution of the T2 weighted changes. Patients need to be educated about adjacent segment disease.
So, Dr. Krishna,
Hello? Hello?
can you hear?
Yeah, there is a hello? Can you hear me? Hello?
So, review the of the
Hello?
どうもお疲れ様でした。皆さん。
Hello?
皆さん、採血の結果は今のところ合格です。はい、よかったです。で今度ね、頭を分析をしてるでしょう。これを見てくれる先生がね、22日の日に来てくださるからね、皆さんが説明しますので、1時に来てくださいね。十分あります。動脈硬化だね。動脈硬化ひどいけど。
Hello? Hello?
Dr. Krishna Prabhu, can
Yeah, I can hear you. Hello? 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 Bala, can you hear me? Hello?
who's this thing. We'll move on to the third topic.
Good day to all. Thanks to the organizing committee for giving me opportunity to discuss on transforaminal lumbar interbody fusion, which is one of the bread and butter surgeries for the neurosurgeons. Lumbar spine fusion is an effective treatment option to stabilize the painful motion segment. Interbody fusion is preferable to posterolateral only fusion techniques because of higher rates of fusion. Lumbar interbody fusion involves the placement of implant, either cage or spacer, within the intervertebral disc space after discectomy and end plate preparation. So it restores the disc space height, foraminal height, restores the lordosis, correct the deformity, and direct or indirect decompression of the neural elements. The options of interbody fusion are posterior, transforaminal, oblique, lateral, and anterior. Each procedure has its own advantages and disadvantages. These operations can also be performed either using open or minimally invasive approaches. In PLIF, which is a midline approach where we have to retract the nerve root to reach the disc space, so there are potential chances of nerve injury, dural tear, and epidural fibrosis. TLIF is a paramedian approach where we use more lateral trajectory to reach the intervertebral foramen without damaging the posterior midline structures. Discectomy and bone graft insertion is done through one side. As there is no retraction or very minimal retraction, so there are reduced chances of damage to the nerve roots, dura, and ligamentum. TLIF can be performed by an open technique or MIS with smaller incision and use of microscope, which can reduce the muscle injury, minimize the bleeding, and improve postoperative recovery. Degenerative disc disease, spondylolisthesis, failed back syndrome, segmental instability, multiple recurrent disc herniations, foraminal stenosis, degenerative scoliosis. Patients with disabling back pain from any of the above conditions with or without radiculopathy for more than 3 months and failed conservative line of management. Investigations are MRI lumbar spine for confirming the diagnosis and the whole spine screening to check the cervical anomalies. Dynamic X-rays of lumbar spine in standing posture to check for instability. X-ray of whole spine to measure the pelvic parameters like sagittal vertical axis, pelvic incidence, pelvic tilt, sacral slope, and lumbar lordosis to assess the whole spine sagittal alignment. Surgical options are open and minimal access. In our center, we prefer minimal access. Case discussion: she is 56 years old female, presented with progressively increasing low back pain, radiating to left lower limb pain and numbness in left lower limb. On examination, she had sensory motor deficit. This is the MRI of the patient. It shows pars deficit and grade 2 to grade 3 listhesis with collapsed disc spate and collapsed foraminal height with compression over the exiting nerve roots left more than the right. X-ray shows instability at L4-5 level, which is getting worse in flexion. Whole spine with bilateral hip joint to measure the pelvic parameters, it shows exaggerated lumbar lordosis. Patient is positioned prone after giving general anesthesia on radiolucid frame in neutral position. A skin incision of size 2.5 centimeters in length was made at the facet joint level, 3.5 centimeters lateral to the midline spinous process. The site of skin incision and facetectomy was chosen according to the patient's symptoms. This patient had left-sided pain, so left side skin incision and facetectomy was planned. A deeper layer of fascia was incised with stab incision, and the smallest dilator was introduced between the multifidus muscle and the longissimus muscle up to the facet joint. Serial dilatation was done using dilators, and the quadrant retractor system was introduced medially and is fixed to the operating table with the help of flexible arm. The retractor is exposed craniocaudally and mediolaterally adequately to expose the facet joint and the surrounding area. Microscopic visualization gives excellent magnification and illumination. This is the facial exposure. Along with the facet, you can see the pars and the lamina. These are the three bony cuts which we use to expose the foramen superiorly at the level of facet, medially at the junction of the lamina and the facet joint, and inferiorly over the superior articular process at the level of superior border of the pedicle. This is the cranial, this is the caudal, this is the medial and the lateral. Because there is a pars defect, no need to give that superior bony cut. Cut was made using the bony chisel through the lamina just medial to the facet joint, following which now the inferior articular process has become freely floating and which was removed. The superior articular process is resected from its tip down to the superior border of the pedicle using the chisel. The superior border of the pedicle was felt with the hook and the rest of the articular process was drilled. The medial border of the pedicle was felt with the hook and the lamina medial to it was drilled. So the bony decompression was basically from pedicle to pedicle. Once the bony decompression is done, you can remove the ligamentum flavum. In cases where we require contralateral side decompression, the quadrant was angulated medially with the help of drill and upcuts. We can remove the contralateral ligamentum to decompress the opposite nerve root. In this case, which was not required. So the ligamentum flavum was removed from medially to laterally. The ligamentum flavum extends laterally as intertransverse ligamentum is also removed. So now the neural foramen was completely unroofed. These are the longitudinal epidural vessels which are connected to ascending lumbar veins through the emissary veins. These emissary veins are there in the Campbell's triangle. We have to coagulate these vessels to make the Campbell's triangle avascular. This is the coagulation of emissary veins to make the Campbell's triangle avascular. Campbell's triangle is a triangle bounded medially by traversing nerve root, inferiorly by the pedicle, and superolaterally by the exiting nerve root. Anelotomy was done, and because of the collapsed disc space, it was very difficult to open. So we used this special instrument to open the disc space, and discectomy was done. Later, anelotomy was extended laterally, and with the help of reverse foot plate, the lateral part of the disc was completely removed. And then the anelotomy was extended medially to remove the medial and contralateral part of the disc. And with the help of specialized instruments, the entire disc was completely removed until the anterior annulus was identified. When the discectomy was completely done, the end plates were prepared with the help of interbody preparation instruments, and slowly the disc space was gradually distracted. This is for the superior end plate. Once the disc space was gradually distracted, let's start placing interbody trial spaces. Initially, we try the lowest one, which is 18 to 22, where 8 was height and 22 was the length of the implant, and then the 10 into 22. and then finally the 12 into 22, which was optimal for this patient for that disc level. At this level, the contralateral side, that means right side, percutaneous pedicle screws were placed, and with the help of rocking technique, the listhesis was reduced. And once the listhesis was reduced, we had to put the bone graft into the disc space area. So we have to pack the bone graft mainly in the contralateral side and the anterior portion of the prepared disc space with the autologous bone, and then the peak cage, which was filled with bone fragments, was put into the disc space, gently tap. Initially we have to insert it at vertically, and once it enters into the disc space, we have to angulate it medially so that it goes and stays in the center of the disc space as anteriorly as possible, which is confirmed under CM guidance. Once the hemostasis is secured, we have to do fixation by percutaneous pedicle screw method using sextant system. So selection of proper cage. We use peak material cage of bullet shape, and selecting an interbody cage with appropriate height is also key steps in lumbar interbody fusion. An oversized cage will lead to over distraction and adjacent segment degeneration, and undersized cage will fail to restore the intervertebral height and lordosis and can result in cage migration and cage fusion failure. Optimal position should be the cage should be as anteriorly as possible and should be in midline. Pedicle screw fixation can be done by open and percutaneous method. We need true AP and lateral CM pictures for proper pedicle screw fixation. This is the postoperative X-ray with the complete reduction listhesis with increase in disc space height. Cage is center in the AP view and is as anteriorly as possible in lateral view. Additional gadgets like 2-dimensional and 3-dimensional navigation and robot can be used for pedicle screw fixation and intraoperative nerve monitoring for long segment deformity corrections. Special situations like accidental durotomies, which can happen in revision surgeries because of scarring and modification of anatomy in the primary surgery, overweight patients where there is a longer approach to the spinal canal and more difficult dissection with longer instruments. Other reasons could be older age, ossified ligamental phlegm, thinning of dura due to chronic compression, and surgeon inexperience. Accidental durotomies, where the small defect you can close it primarily, large and irregular defect you can do duroplasty with lumbar fascia synthetic patch reinforced with fibrin glue. If it's very small defect with herniating nerve root, extend the durotomy and push the nerve root inside and suture the defect. If it's anterior defect, open the dura posteriorly, inspect the anterior defect, cover the defect with inlay graft and close the posterior durotomy primarily. With the help of MIS, we can minimize the durotomy associated complications like CSF leakage or pseudomeningocele because of limited dead spaces of tissue. These patients can be mobilized within 24 hours. Screw malposition and pedicle breach. There are so many different grades of grading this screw malposition. One of this grading system is this, where 1A is normal screw, 2A, 3A and 1B are completely laterally positioned screws, 2B and 3B are medially positioned screws. A new neurological deficit or postoperative pain requires CT evaluation, and if a screw is medially malpositioned, it has to be repositioned. A laterally malpositioned screw can cause life and limb threatening complications which requires repair of vascular lesions and screw repositioning. Osteoporosis, where there are chances of end plate fractures while doing discectomy and end plate preparation, so do not over distract the disc space. Instrumentation is challenging, so we can do instrumentation with help of bone cement augmented fenestrated pedicle screws. One of the complications in osteoporosis is placed pedicle screw coming out So in such cases, increase the diameter of the screw, place and inject the bone cement, or if the bigger screw is not available, use the same screw and inject the bone cement. If fenestrated screws are not available, inject the bone cement in the hole and then place the screw. All patients are mobilized within 24 hours from the time of surgery. There are a lot of described postoperative complications. Follow-up are usually at the end of 2 weeks, 1 month, 3 months, 6 months and 1 year after the surgery. You can be you can do clinical assessment or radiological assessment at the end of 1 year for evaluation of interbody fusion at the final follow-up. So to conclude, TLIF is routinely performed surgery. It is a very safe technique and can even be a procedure of choice for a wide variety of indications with favorable results. With sufficient experience and modest learning curves, MIS technique is associated with few complications than the open procedure. Thank you.
Thank you, Dr. Murali. It was a very nice, detailed talk. There's one question which often comes to me from the students, and I think it would be wise to ask you: how do you choose to go for a banana cage or a bullet cage for your TLIF cases?
So we standardly prefer bullet cages only, sir. For all cases, we prefer bullet cages. We don't use banana cages in our setup.
Right. Any particular takeaways in terms of why you choose that? What are the disadvantages of banana cages? We're talking about MIS or open? We're talking about TLIF, right? Open
Yeah,
or
TLIF,
MIS
both. Yeah. So we're comfortable with the banana cages. I mean, bullet cages. So we're preferably using bullet cages only for banana cages for all open and minimal access cases.
Right. Thank you so much. Ramesh, you want to ask any questions?
Elaborate on.
We have a couple of minutes before the next talk starts.
If there are no further questions, we'll move on to Dr. Ramesh Chandra from SWIMS.
Good morning. I thank the organizers for giving me this opportunity to present in the first Asian Congress. My video presentation is about OLIF, oblique lumbar interbody fusion. We have both anterior and posterior options available for lumbar interbody fusion. Posteriorly we have P-leaf and T-leaf, whereas anteriorly we have A-leaf, T-leaf and O-leaf. Anterior approaches have many advantages like torsional stability, height restoration, no need for dural retraction. Now biochemical studies have proved that using wider cages makes the construct more stiffer. Now coming to the anterior approaches, D-leaf uses a trajectory through the psoas muscle, A-leaf is a transperitoneal approach, O-leaf utilizes a small corridor between the psoas muscle and greater vessels. Cadaveric and imaging studies have identified this corridor and measures ranging from 10 to 15 millimeter. And this exposure can be further doubled by slight elevation of the anterior margin of the psoas. After the skin incision, the muscles of anterior abdominal wall are split sequentially to reach the retroperitoneum. The retroperitoneum is swept away with finger dissection from the undersurface of the anterior abdominal wall, the quadratus lumborum and the psoas muscle to reach the disc space. As you can see in this MRI taken in the right lateral position, the peritoneum with its contents fall away from the corridor due to gravity, giving a direct approach to the disc. OLIF is a left-sided approach, and the prerequisite for OLIF procedure is presence of the corridor between the psoas muscle and the great vessels. Here we can see the corridor is good in the first two images, but the corridor is covered by the overhanging psoas muscle in the third image, and the corridor is obliterated in the last image. The normal structures encountered during this procedure are the genitofemoral nerve, which lies on the psoas muscle, the lumbar sympathetic chain and the ureter. Lumbar sympathetic chain and the ureter can be swept with the retroperitoneum. The dissection should be performed under direct vision to prevent injury to these structures. Occasionally, the ureter may be encountered during the approach, and it should be swept along with the retroperitoneum. The main indications of OLIF are 1. Spondylolisthesis with significant foraminal stenosis and degenerative scoliosis, wherein osteotomies are avoided by using OLIF. Now, OLIF causes indirect decompression by restoring the disc height and foraminal height. You can appreciate the straightening of the buccal ligamentum flavum and widened diameter of the thecal sac without requiring any posterior procedure. For a beginner, case selection is very vital and should choose a case of simple spondylolisthesis in a thin or moderately built patient with good bone quality and good OLIF corridor. Once he or she is comfortable with instability and foraminal stenosis, then they should explore more complex cases like instability with central canal stenosis, multiple level listhesis, and degenerative scoliosis. Now, the OR setup and the infrastructure needed for OLIF are a good microscope, a C-arm, and OLIF retractor system. Intraoperative nerve monitoring is not required. The cage used is a peak cage with a wide footprint. Demineralized bone matrix is used as the graft material. This is the workflow in a case of OLIF. The skin incision is planned under fluoroscopy. The retractor is docked and fixed with a cranial pin. A thorough discectomy is done. The opposite annulus is released with the corpse dissector. Trial is introduced and the cage placed. Finally, posterior fixation is done with either pedicle screws or cortical bone trajectory screws. Tube-based OLIF was introduced in 2012 and various complications have been reported. Overall, the incidence of complications are less than ALIF and DLIF. Coming to the surgical steps and nuances. The patient is positioned in a lateral position with left side up. Table break is not needed. The C-arm is brought in and the table is adjusted to get a good AP and lateral view. Skin incision is marked using fluoroscopy. The midpoint of the index disc is identified and the incision is placed around 5 to 10 centimeters from the midpoint of the disc. The incision can be oriented either vertically or horizontally depending upon the build of the patient. Now, vertical incision is in a bulky patient helps in reaching the psoas easily. The orientation of the disc is marked on the skin and the opening of the retractor should be aligned along the disc space to allow movement of instruments during the orthogonal maneuver through the gap in the retractor as shown. One step unique to OLIF is the orthogonal maneuver. This is the step where the cage enters the disc in an oblique trajectory but is finally placed perpendicular to it. All instruments are used in an orthogonal manner in OLIF. Now, docking of retractor is very crucial, and according to Dr. Richard Hines, who introduced this tube-based OLIF, anterior 2/5 of the disc is ideal place to dock the retractor. Docking point also varies depending upon the indication of surgery. The pin placement is planned carefully and care should be taken to avoid putting a pin in L5 vertebra as there is a risk of injuring the aberrant iliolumbar vein. Discectomy is done using various shavers and rongers and is very crucial for proper placement of cage. Before starting the discectomy, adequate exposure of disc is obtained. During discectomy, the disc forceps is always aligned perpendicular to the disc and anterior alignment should be avoided to prevent an injury to the thecal sac. After proper discectomy, the opposite annulus is released using the corpse dissector. This is done without using a hammer to retain the haptic feedback and prevent injury to the opposite side by plunging the dissector. After adequate discectomy and annular release, the trial cage is placed and confirmed. The final cage placement depends upon the initial docking point, adequate disc clearance, opposite annular release, and most importantly, a good orthogonal maneuver. As you can see in the lower panel, the trial cage initially enters posteriorly, but with the orthogonal maneuver, it is placed in the middle of the disc. The skin and subcutaneous tissue is incised. The fascia or the external oblique is cut. The external oblique is split, followed by the internal oblique and the transverse abdominis. These muscles are sequentially to expose the retroperitoneum. Now the retroperitoneum is dissected using the finger and the Kittner to expose the psoas muscle. Once the psoas muscle is exposed, the meticulous dissection is done on the anterior aspect of the psoas muscle to expose the disc. The anterior border of the psoas muscle is elevated to gain adequate exposure of the disc. In this process, the normal structures like genitofemoral nerve and lumbar sympathetic change are preserved. Now the serial dilators are placed and the olive retractor is placed on the serial dilators. The olive retractor is held in place by a cranial pin. The dilators are removed. The retractor is opened to give adequate exposure of the disc space. Discectomy is done using various shavers and disc rongers. Adequate discectomy is done to improve the placement of cage. The contralateral annulus is released using the Cobb's dissector. A sizing trial is used to know the size of the cage, and this is followed by placement of the olive cage. Once the olive cage is placed, the retractor is removed and you can see the normal structures falling back in layers. This is the retroperitoneum, followed by the transverse abdominis, the internal oblique and the external oblique. The post-operative imaging shows adequate reduction of the listhesis, adequate decompression and minimal post-operative scarring. Thank you.
Thank you, Dr. Ramesh. If we have the time, can I ask a question? What is your lower or the bone quality? How do you determine at what bone quality you want the olive?
We generally avoid.
We're not audible. I think let's proceed to the next talk because this is some disturbance. Hello, everyone, and a very good morning or a good evening, as the case may be, to my fellow faculty and to all the delegates who joined us from around the world on the first day of this virtual Congress of Asian Logical Surgeons. I would like to thank the organizers, especially Dr. Balamurugan, for this invitation to speak on minimally invasive reduction of lumbar spondylolisthesis. Now, over the next 12 to 15 odd minutes, we are going to be going through a review of the rationale, the indications, and the techniques, as well as limitations of reducing spondylolisthesis through a keyhole incision by minimally invasive means. Now, we are all aware of what spondylolisthesis is. It is a slippage of one vertebral body over the other, and it is graded in blocks of 25 percentage points calculated on the AP dimensions of the vertebral end plate. We are also aware of the various types of spondylolisthesis in terms of its etiology. However, a lot of something that a lot of junior delegates may not be aware of is that many aspects of the management of spondylolisthesis continue to be controversial. Now, the spinal decompression or the neural decompression continues to be the primary goal, in the sense that without that, you're not able to get a very good outcomes, clinical outcomes, irrespective of whether you instrumented the patient or you reduced the slip. Even though fusion has gradually gained ground and traction, it is still controversial in the sense that a lot of patients in whom we don't reduce spondylolisthesis continue to do well as the ones in which the fusion is being done. And even more controversial is the need to reduce in such patients. Now, what has happened is that because of graining instrumentation, the indications for fusion have got blurred, because everybody is now considering an entire family of degenerative spondylolisthesis as one common or one, you can say, uniform entity. And you must have a look at this interesting paper from Kulkarni et al., which has been published recently, wherein they analyzed 131 patients retrospectively to determine the indications for fusion, and then applied these indications to 52 of their prospective patients and able to get a good more than 90% success in such patients depending upon their scoring system. So basically looked at the points which indicated the patient may progress in terms of spondylolisthesis or may have poor outcomes with just decompression alone. So these are divided into clinical factors, radiological factors, as well as operative factors. So the factors such as mechanical back pain, a significant amount of it, or a younger age group, or a high demand activity, all indicated that these patients will require fusion depending upon their scoring from the other parameters. In terms of the logical factors, segments, the factors such as segmental kyphosis, dynamic spondylolisthesis, disc height more than 50%, bilateral fascial fusion, or sagittal facets. Now, all these indicated again that the chances for slip progression were high, or the chances of relief of pain were low in patients in which only decompression was done. They also gave 1.5 points to the feasibility to decompress. So if you felt that you could not decompress the canal adequately without sacrificing the midline, then you would be more in favor of fusion. So as per their scoring, they felt that a score of more than 5.5% would be considered as a good enough indication for fusion. So once we are aware that, or we have taken a decision whether we need to fuse or not, the second most important the difficult decision is whether to reduce or not to reduce. Now, there are pros and cons of both in situ fusion as well as in terms of reduction. The in situ fixation is definitely easier. There's lesser blood loss, there's less incidence of implant failure, and also there are lower chances of traction injury to the nerves as we go ahead and reduce it. But of course, there are also increased chances of pseudoarthrosis, progression of the slip, spinal imbalance, and instability. The group that favors reduction obviously looks at the fact that there's a good contact area for fusion once you've reduced the spondylolisthesis. The back pain is overall decreased in such cases. There's improved quality of life, and there's also an opportunity to correct the spinal pelvic parameters, considering that the elevated PI will increase the risk of spondylosis and also the slip progression. However, it is more time consuming, there are higher blood losses, and of course, there's a higher failure rate of implant screw interfaces in patients whom there's a forced reduction in spondylolisthesis. Now, even though better fusion and better clinical outcomes have been graded as the more, you can say, universal reasons for as a rationale for reduction, what has increasingly gained attention and interest of the spine community is the role of spinal balance and how the reduction impacts the spinal balance. So There are various parameters that one needs to look into. But in general, what needs to be taken into consideration is that an unbalanced pelvis will result in slip progression, and also there are higher chances of adjacent segment degeneration as a result of unbalanced pelvis. The patients who've got a higher pelvic incidence do have a higher tendency for both slip progression as well as development of adjacent segment disease because of higher load on the adjacent facets. So once we are aware that yes, the patients who have got a higher chances of slip progression will require fusion or will require reduction. So the principles of spondyloid reduction remain the same, whether it's for MIS or to the open. One must ensure that there is a favorable positioning, take the help of posters and cushions for the same, ensure that there is adequate decompression with the help of fastectomy, annular release, or osteotomies. Make sure that there is a good amount of interbody distraction to reduce. That will help to release the adhesions as well as reduce with help of pukas, shavers, and trials as well as levers. And also to ensure that there's a good screw purchase for those cases which don't reduce even after a good positioning, a good decompression, and a good distraction. So for these, you need translational reduction, and you need to have a very good screw purchase or good bone quality for such cases. So in terms of posterior reduction, we have observed how patients' use of bolsters and pelvis allow for reduction of the spondylolisthesis. Also, it's important to keep the knees straight, which again allow for a more curved spine over there and allow for reduction, as you can see in such cases. So sometimes it's not just a reduction of the grade, it's also the improvement in the angulation where it makes our surgery a lot easier. Apart from the second part, which is decompression, we're talking about distraction reduction, where you put in the shavers, trials, and every time you do that, you leave it in for about 2 minutes, allow the ligaments to relax, and then you put in the next size. And one can easily get up to 2 grades of reduction, just with the help of distraction reduction. As you can see here, there is both a better alignment as well as better angulation of the vertebral end plates. Then we come to this translational reduction, which means that you are reducing with the help of pulling the body to the screw or pulling the screw to the rod or rod to the screw. Now, this is what the earlier thought process used to be, that you need a temporary screw in the adjacent pedicle, which allows for pulling of the screw on top. However, with the concept of cantilever forces has made reduction of screw onto the rod a lot easier. So as you can see here, the rod is now tied onto this end. The screw has been tightened, and this continues to remain the same position, whereas the screw is gradually brought up to the level of the rod with help of these better instrumentation. Also, another method of spondyloid reduction in patients who've got weak bones is a fulcrum lever reduction, where you use some sort of a osteotome to lever the anterior edge of the upper vertebral body against the posterior edge of the lower vertebral body, acting as a fulcrum, allowing it to not only distract but also translate posteriorly. This can be done through a minimally invasive means by using the port onto the one side and the screw instrumentation on the other. Now, what we also observed is that instrumentation has kept pace and allowed for spondyloid reduction in MIS cases. Let's take a few examples. This is a case instrumentation described by Medtronic, and which you have extender reduction screw extender, which allows for more space compared to a normal screw at L5, S1. So an S1 screw would be having a longer sleeve to allow for more space, and these can be adjusted here, as you can see, depending upon the level of reduction that you need. This is example of how you can reduce the rod onto the screw gradually with help of such instrumentation. This is another illustration of the same, where the screw is pulled up onto the rod. This is an example of another system where the cantilever maneuver is being used. Let me just play this. Yeah, so you can see here the lower screw has been tightened. The rod is in this position. A reduction sleeve has been added to this set, and here the instrumentation or the tightening is taking place on the top. And as you can see here, the rod is gradually being pulled down onto the screw, and the overall balance works more in favor of rod going down rather than the screw being pulled up with force. Similarly, one could use a rod reducer, as you can see here. Here, this is typical to what you do in an open surgery, except these are more, you can say, smaller profile instruments which cause more force compared to the one we saw previously, and again helps to pull down the rod onto the screw, or the screw onto the rod. But this of course causes more force and more chances of screw pull out compared to the previous one. In terms of the maneuvers, there have been a couple of publications, a number of publications which have described this. Dr. Deshpande described a rocking technique where he used this after putting the instrumentation and after putting your spacer. This smooth surface is then used to gradually rock and pull the the upper vertebral body upwards, as you can see here. I'm not able to move that. Let me just check if I can. Yeah, so as you can see here, now this maneuver is allowing the upper vertebral body to be pulled upwards. And this can allow for a spondylolisthesis reduction of this degree in such patients. As you can see here, there's a couple of more examples of the same. Another maneuver that's been described by Park et al. Is called the swing maneuver, where you put in the rod. They normally like to put the cage first, and also then maneuver it craniocaudally to allow for. As you can see here, the swinging is taking place in craniocaudal direction, and that allows for reduction of the last grade of spondylolisthesis, which may be left after you have positioned the patient properly, after you have done your distractions. And final tightening is taking place at the reduction angle. This is the kind of reduction that we can achieve with the swing technique, again grading it from grade 2 to grade 0. Let us take a case example of a patient with a grade 2 to grade 3 reduction. As you can see here, MRI is showing grade 2. However, on dynamic X-rays, it showed that this was probably a grade 3, grade 2 junctional reduction, which is then reduced on positioning to grade 2. This is after the MIS decompression and fixation and distraction. Let's take another case example. This is a grade 3 spondylolisthesis, which is causing a lot changes in the angulation of the end plates at L5S1. Again, this is a grade 3 slip. Let's look at the steps that we use in such patients. In this case, this is the first step after positioning. This is the maximum reduction we could get. This is insertion of the guide wires, followed by placement of a distraction device. As you can see here, we're distracting the end plate, also at the same time instrumentating from the opposite side. And as you instrument it, you place a rod. And once you have tightened the rod onto the lower screw, the next maneuver is to put in the trial and then reduce onto the screw or the upper vertebral body onto the by this help of system. And as you can see here, so we are able to get a good reduction of this spondylolisthesis from grade 3 to grade 0. So the key learnings are that the incision should be slightly lateral so that you allow a medial angulation of screws. Go for bicortical purchase wherever possible. Also distraction, use it optimally to allow for translational reduction, and also use trials for translation of a smooth surface. So if you're using trials, there are more chances of allowing a good reduction compared to placing a cage. So the examples of bicortical purchase, lateral entry of the skin incisions, and also of medially directed screws. So the pitfall limitations include screw pullout, dysplastic pedicles, osteoporotic bone, and spondyloliptosis, wherein we can take help of long, large convergent screws, augmentation with bone cement, dual thread pattern screws again, which help to improve the fixation. Sacral door osteotomy in patient with spondylolisthesis, and of course bilateral release should be used in patients who've got a high grade spondylolisthesis, bilateral osteotomies, and neuromonitoring can be used to minimize our complications. So to conclude, primary goal of surgery for the symptomatic spondylolisthesis remains decompression. The stabilization and reduction help to improve the balance, but may also potentially improve the outcomes. Basic understanding of the principle continues to remain critical in executing even the MIS reductions. Technology and the instrumentation designs have improved to allow this to happen for MIS. And newer tools such as navigation, neuromonitoring help us in minimizing the errors and complications. And well executed reduction, though not indicated in all cases, is desirable and gratifying. Thank you so much.
Thank you, Dr. Rajan. Thank you very much. We are fairly on schedule. We have 10:27 now. The next session starts by 10:45. So we have about 10-15 minutes of discussion. Request Dr. Krishna Prabhu, Dr. Murli Krishna, Dr. Vijay Shankaran to have a, can self-moderate the session and see what else can come out and how the youngsters can benefit out of this. Please unmute yourself and please join the discussion.
Dr. Ramesh, I would like to start a question for you. How much of a correction of degenerative scoliosis we are able to get? And the same question in what observed is that most of the patients with degenerative scoliosis have a poor bone quality, and they are ones who will actually require the maximum forces to correct the deformity. So then, how do you decide at what scoring level for the bone quality you are going to stop and not do a OLF?
Score of -2. Am I audible?
Yes, Faye,
Yeah,
you can come closer.
Score of -2.5, we don't consider OLIF. And most importantly, the substance in OLIF is related to the disease as well as the BMI of the patient. Patient of BMI more than, there is increased chance of end plate preparation also very well. You should not be very aggressive while preparing the end plates. So what we have noticed when we do shavers and when we prepare the end,
The video recording. Because otherwise it will be
that we our
Good. Dr. Vijay wants to make a comment. I think his mic is on.
Dr. Vijay, can you hear? You have to unmute.
Hello. Can you hear? Ramesh?
I can hear Krishna Prabhu.
Yes, you're audible.
Vijay, I am not able to hear.
I think let everyone mute their mics and only the person who wants to make a comment can switch on their mic. Dr. Vijay, your mic is off. For the interest of the delegates, I'd like to just make a comment regarding the types of cages that we decide upon. How do we choose in our center? So if you notice the profile of a banana cage is curved, right? So it is something which can be entered from the side and then can direct itself medially. So in an open surgery where the entry is more medial rather than oblique entry in MIS TLIF, we use banana cages as the cage can then gradually be turned onto the opposite side. Whereas in a MIS TLIF, we use bullet cages for two reasons. One is that you are going across the disc space, you are going across the vertebral body, so you're going to be covering that to left anyway of the disc space. And second is that there's not much space in the tube to allow for a banana cage to.
I think Dr. Rajan is again off. Yeah, we lost you, Dr. Rajan.
I was not audible?
You were audible, then you just went off.
Yeah, because I was letting the other people make comments on how they choose. Basically, for the favor in the discussion in favor of the delegates, how they choose their cages.
Dr. Krishna Prabhu, any
Ramesh, a question to Ramesh actually. My only concern in OLIP is how good your decompression. Your primary procedure is discectomy and height restoration. Most of the patients have thickened ligament flavum, foramen stenosis. How good is your decompression? That is my concern always. So the case selection has to be actually, I think, perfect. Otherwise, your neurological improvement may not be good. You may get a good reduction, you may get a perfect vertebral body alignment, but your neural decompression will it be adequate? Are you happy with it?
I think Dr. Ramesh is in the OR. Probably they don't have a very good network there. He's, he's unmuted, but we still can't hear him.
Dr. Vijay, we can't hear you.
Okay, if I may ask Dr. Krishna Prabhu, in how many of your patients do you actually need to go laterally and remove the uncinate processes? Do you often find the need to trace the nerve roots, cervical nerve roots, as you are decompressing the space? Or do you mostly centered on just canal decompression and use the larger size cages for getting an indirect decompression of the foramina?
I don't like to go laterally and remove the unspent process. I just need a lateral traveling, an unspent process. I don't want to see the root direct region. I'm sure if you are seeing it, then you're going to cause definitely some damage to it. I would like to restore the height by increasing by 1 millimeter. So maybe a 6 is most of the time 6 millimeter cage what routinely we use, but they have used 7 and in one occasion even 8 they have used. You don't need to go and see the root directly and expose the root completely. That may not be a good idea.
Thank you, Dr. Krishna. Dr. Is he here?
Dr. Murli?
Yeah, yes, sir. I'm here. Tell me. Able to hear me, sir?
Yeah. Any further tips? Anything else you want to share? You heard Dr. Krishna Prabhu and Dr. Rajan. Anything else you want to add?
Yeah, I think it's adequately covered. I think so.
Okay.
I basically wanted to ask Vijay and also the other faculty, because we are gradually doing more and more T-lifts, we often tend to make a square window in the annulus when we are doing our disc preparation. And do they do the same for their discectomy cases, or do they continue to use a cruciate incision? And have they seen any difference in the incidence of reoccurrence depending upon the type of the cut they make on their annulus in cases with microdiscectomy, whether it's a box or whether it's a cruciate incision?
I haven't found any difference between these two. I usually prefer a box.
You usually do either cruciate or box enlotomy.
No, I have not found any difference in between these two. I personally prefer a box shape.
Even for normal discectomies?
Small box shape, I mean.
Right. Anybody else wants to comment? Dr. Ramesh?
I have only one. I personally do not like the. I don't like the banana cake very much. I still prefer the bullet cake. Somehow I feel very comfortable with the bullet cake, which I can achieve a good placement and everything. Also, banana cases are very expensive, so I don't find much of an advantage using the banana cake.
Right. I don't know whether Dr. Ramesh will be able to answer us whether his mic is working. But how much of your work is now standard procedure TLIF and how much of it is now OLIF in terms of the percentages? Can you remove the mic? Maybe, the headphones that you're using, the mic doesn't work there. Yeah, use a laptop or your phone mic.
Yeah, is it audible now?
Yeah, much
perfect.
Yeah. Sir, regarding that first question, sir, has asked Krishna Babu, sir. So we select cases with ligamentum flavum buckling. And with indirect decompression, the buckling gets straightened off. But in hypertrophy, that doesn't happen. So, but there is no imaging modality to definitely say which is ligamentum flavum buckling and hypertrophy. But we have to go and see around what are the associated findings, like very big facets, hypertrophy faces, and lot of deformity changes and all are there. We definitely avoid OLIF. Very simple cases with lateral canal stenosis, lateral recess stenosis and listhesis are ideal for OLIF. So, and depending upon the case selection also, if we select in Indian patients, those are very minority. Like simple listhesis with just lateral canal stenosis are minority, and only them we do OLIF. So generally we do TLIF and PLIF as regular.
But does that also mean that probably your indications for fusion are actually more liberal than they should be? A lot of these patients don't require fusion. If you're going to have just a little lateral recess stenosis,
instability,
just a little bit of
instability.
Pardon me?
With instability with lateral stenosis, I think we should go. Instability is the main key there. Lateral. And one more very useful in future is degenerative scoliosis. Degenerative scoliosis is a very good where OLIF will avoid all osteotomies. So we have done three level of for a fractional curve. We can put three level OLIF with a big construct where the completely can reduce without any need of osteotomies or any posterior procedure. That is one indication which I mean. Okay, but again, we have to do an open procedure for putting all the screws on behind.
I think another point that delegates can use is that for the OLIFs that we do, we always make sure that the patient's SLR is negative. If the SR is positive, it means there's a traction sign on the pull on the nerve root, and these patients often require a release of the nerve root from behind. Then they may not do that well with simple OLIF, because in OLIF you're only decompressing the nerve root, you're not releasing it from the adhesions, and those adhesions can bother you without a posterior release and manipulation of the nerve root adequate.
Yeah. Now studies from Korea and Japan have added an endoscopy with OLIF, so that they can take care of even the disc segments. So in normal OLIF, a central disc is relatively contraindicated. We can't approach the disc in OLIF procedure. But now what they are doing, they are adding an endoscope either through the OLIF portal or posterior one to address even the posterior and disc components.
Dr. Ramesh, am I audible now?
Yes, sir.
Yeah. Have you have to do OLIF and then go in again posteriorly for inadequate decompression after your case selection for OLIF?
No, sir. No, I haven't come across anything, because everything depends upon the case selection. You should be very crucial and very you filter your cases such that you get a simple instability, with the lateral stenosis. That is your basic indication. And as you go further, degenerative scoliosis. That is one place where I think OLIF will be very crucial.
All your patients have back pain, no leg pain.
Sir, lateral, yeah, they have leg
pain, no leg pain.
Lateral canal stenosis, they have some amount of pain.
The symptoms of lateral stenosis.
Oh, yeah, but they have done well.
Okay, good. Dr. Krishna Prabhu, so you cut the omohyoid, Dr. Krishna Prabhu?
No, only
for all the patients.
Required to cut only for 3, 6, 7 levels. Usually required, because it will make your exposure and protecting easier. 3, 5, 6 not necessary in most of some patients maybe, but most of them not required. Only for 3, 6, 7 is required. I thought to show this procedure of how to get for this patient.
Do you always
higher levels?
Sorry, sir.
Sorry, for higher levels you don't need.
Okay. Do you always operate from the right side, sir? Or
yeah, I always do right side. I am comfortable with right side. I have no problem with that.
Okay, for lower levels, you do not change your side.
No.
Okay.
We don't do from this side. We always do right side. I have no issue with it.
I think we can come to the end of this session. It's 10:44. I would like to thank all the faculty for excellent talks, and also hand over the proceedings to the next session.
Thank you, Dr. Rajan. Thank you, Dr. Thank you, Chandra, and Dr. Krishna Prabhu and Murali Krishna. Thank you so much for taking your time morning, and have a great day. And please keep joining us for during the conference, wherever your interests lie. Please do, and please encourage your students to join in. Thank you so much.
Thank you. Thank you.
Thank you so much.
So we move on to the next session, which will be on endoscopy and also on intraspinal tumors. We have very senior surgeons here with us who are here to share their experience with us. We have first speaker will be Dr. Shankar Ganesh, who will be speaking on endoscopic third ventriculostomy. The next speaker will be Dr. Anand Balasubramaniam from Hyderabad. He'll be speaking on endoscopic surgery for pituitary. And the third speaker will be Dr. Sukumar Sura, who will be doing the endoscopy for spine. And then the fourth speaker will be Dr. Manas Panigrahi for intradural extramedullary lesions. And finally, we have the giant in neurosurgery from this part of the country, Dr. Ramakrishna Ishwaran, for the intramedullary tumors. So we have a fantastic collection of surgeons who are here to share their experiences. And may I request Saravanan, can we have the first speaker, Dr. Shankar Ganesh's video, please?
Good morning, everyone. I would like to thank Dr. Balamurugan and the other organizers of this ACNS conference for giving me this opportunity. Endoscopic third ventriculostomy is a procedure where an opening is created in the floor of the third ventricle to divert the flow of CSF. CSF circulation occurs through the cisterns and hydrocephalus resolves. Obstructive hydrocephalus due to acute stenosis or posterior fossa tumors causing fourth ventricular outlet obstruction or indications for ATV. Since there are no implants used in this procedure, the complications due to obstruction, malfunction or implant rejection are avoided. The procedure is more physiological. Preoperative MRI is mandatory for all cases. The mid-sagittal T2 weighted image is the most suited one to plan surgery. The placement of burr, the trajectory, the prepontine index, the space available anterior to the basilar are all assessed for planning a surgery. A thorough knowledge of the endoscopic anatomy of the ventricle is a prerequisite for the procedure. This is the endoscopic view of the lateral ventricle showing the foramen of Monro, the choroid plexus or the thalamostriate vein. This is the image of the floor of the third ventricle. The bright spot anteriorly is the infundibular recess. These are mammillary bodies, basilar artery and the tuberous cinerarium. For the benefit of residents, I will go through the basics of the procedure. The patient is positioned supine with neck flexed. The site of the burr is decided based on the preoperative imaging. It is approximately around the Kocher's point. The incision is marked infiltrated. Either a curvilinear incision or a linear incision can be used. Burr is placed, and as far as possible dura should be opened so that it can be closed after surgery. Or if the dura is thin, it can be coagulated as we do in case of VP shunt. The frontal horn of the right lateral ventricle is tapped using standard technique, and through the same trajectory the outer sheath of the endoscope is introduced with the obturator. Once the entry into the ventricle is confirmed, the endoscope is introduced through the outer sheath. If you look at this image carefully, the assistant is holding the outer sheath. The left hand is placed securely on the patient's head, and the sheath is held with the thumb and index finger, and with the right hand the endoscope is held. So this creates a firm hold on the endoscope, and the surgeon can perform the procedure safely. Ideally, the endoscope monitor should be placed at the foot end of the table so that the surgeon, the assistant and the nurse gets a good view of the monitor. I would prefer to stand on to the right of the assistant and perform the procedure. Other option is to use an endoscope holder. So this is a view, endoscopic view through the lateral ventricle. My septum is dehiscent. There is a choroid plexus and thalamostriate vein. As we enter the foramen of Monro, we will see the mammillary bodies. The red basilar artery is seen there, and this is the infundibular recess. The penetration is made in the floor of the third ventricle using a blunt instrument like a grasper or a monopolar electrode without the use of current. Once the floor is open, the liqueous membrane should also be fenestrated, and the adequacy of the opening should be confirmed by advancing the scope, and you should see the vessels clearly without the covering membrane. The floor of the floor ventricle is floppy or lax. It is difficult to dilate the stoma with a blunt instrument. In such cases, a Fogarty balloon is used to dilate the stoma. The Fogarty catheter is gently inserted through the fenestration and it has to be passed through the umbilicus membrane, and the bulb is gently inflated. By sequential dilatation, the stoma can be enlarged. At the end of the procedure, the ventricles are irrigated with warm Ringer's lactate and inspection must be done to make sure there is no bleeding before withdrawing the scope. The endoscope tract should be plugged with Surgicel and gel foam to prevent egress of CSF. This is to prevent the formation of subdural hygroma. And if the dura is open, it can be sutured, and the burrow is covered with bone dust and the wound should be closed in layers. The site of burrow and the trajectory should be planned based on the preoperative MRI. The endoscope should be gently advanced through the foramen of Monro without injuring the fornix, choroid plexus or the thalamostriate vein. And the floor of the third ventricle should be fenestrated with a blunt instrument, and gentle dilatation of the stoma should be done to avoid injury to the hypothalamus or other neurovascular structures. And as I mentioned earlier, the endoscope tract should be plugged with Surgicel and gel foam. Some surgeons even use fibrin glue to seal the tract. This is to avoid egress of the CSF through the ostomy. If there is CSF flow through the endoscope tract, it can lead to subdural hygroma formation and the chance of failure of ETV is high. How do we assess the success of ETV? The significant and the simplest way of assessment is postoperative clinical improvement of the patient. So when the preoperative low conscious state or eye movement disorders or headache and other features of raised ICP resolves postoperatively, that is the best indicator to say that the ETV is a success. So unlike a VP shunt where there is significant reduction in the size of the ventricle, post ETV the ventricular size may not decrease significantly. So some of the latest sequences like the 3D space sequence are used to assess the patency of the stoma. The cardiac gated cine MRI will show us the flow of CSF through the ostomy. So clinical improvement of the patient is a more reliable indicator than a good radiological image which shows reduction in the size of the ventricles. So when the patient remains free of his features of raised ICP, and if it does not require a shunt, that is a good indicator that the ETV is a success. How to predict the success of ETV in a given patient? The patient's age, etiology and whether the previous shunt has been done or not are taken into consideration, and points are given for each criteria. If the overall score is over 80, then the success of ETV is high, and the chance of failure is high if the score is less than 40. The failure rate of ETV is high if it is done in children less than 6 months of age, or if the etiology of hydrocephalus is either infectious or post-hemorrhagic, or the cortical mantle is very thin or communicating hydrocephalus. With advances in surgical techniques and technology, many studies have shown that even in these conditions, the success of ETV is good. So, choroid plexus cauterization, when it is combined with endoscopic third ventriculostomy, improves the success rate. When the choroid plexus is coagulated, the production of CSF comes down, thereby increasing the success rate of ETV. A standard endoscopic third ventriculostomy is performed as the floor of third ventricle is fenestrated and the iliacus membrane is fenestrated. Then the choroid plexus in the lateral ventricle is cauterized with a bipolar diathermy. The lateral posterior choroidal artery is coagulated, and the same procedure is done on the contralateral side. If the septum pellucidum is intact, a fenestration is made and the contralateral choroid plexus is coagulated. This is a scoring system to predict the success of endoscopic third ventriculostomy when it is combined with choroid plexus cauterization. The success of the procedure is directly proportional to the volume of choroid plexus that is coagulated. So using a rigid endoscope, the choroid plexus can be coagulated from the foramen of Monroe up to the atrium. If the septum is intact, the septostomy can be performed to do the procedure on the contralateral side. With the help of a flexible endoscope, the choroid plexus in the temporal horn, third ventricle and fourth ventricle can be done. Fenestrating the floor of third ventricle becomes difficult when it is too narrow or if it is opaque. When an opaque floor of the third ventricle is encountered during surgery, it is not a bad idea to stop the procedure and do a VP shunt. With experience, surgery can be performed safely with the help of endoscopic Doppler or a neuronavigation to locate the position of the basilar artery and to make a fenestration anterior to it. Walter Grant has described a technique, it's called a cookie cut technique, where a blunt instrument is used in a twisting motion repeatedly on the floor of the third ventricle to create a opening gently, and once the fenestration is done, it can be dilated with Fogarty balloon. If the floor of the third ventricle is too narrow to perform even gentle dilatation with the Fogarty balloon, it is wiser to stop the procedure and do a VP shunt. When the anatomy is not favorable to perform endoscopic third ventriculostomy at the tuber cinereum, fenestration of the lamina terminalis can be considered. A flexible endoscope is used to create an opening in the anterior third ventricle to fenestrate the lamina terminalis, or an opening can be made through the septum to create an opening through the rostrum to divert the flow of CSF. Good case selection and thorough preoperative assessment is required to perform a safe procedure and to have a good success rate. Beginners should take up straightforward cases, and with experience, more complex cases should be attempted. Thank you.
Yeah, thank you. I think we'll move on to the next topic and then have all the discussion at the end of the session by the moderators themselves. So the next topic will be by Dr. Anand Balasubramaniam.
After good nasal decongestion, the middle turbinate is being resected. This is an optional step, but it's being described here to show how the middle turbinate resection is being done. It provides good roominess in the nasal cavity, especially if you are using a forehand approach. This can be done easily. Once the turbinate is resected, then we'll be able to access the ostia of the sphenoid much easily, and the nose becomes much roomier. You can see the turbinate is being resected. If the decongestion is adequate, bleeding is usually not a problem, and that can be easily controlled with packing. The resected turbinate can be used later for reconstruction of the cellar floor if required. Once you lateralize the remnant of the middle turbinate, within a centimeter of the posterior end of the middle turbinate, one can identify the sphenoid ostia very clearly. And the same step can be done on the opposite side too, to make it nice and roomy single cavity to enable a good forehand approach. This is the opposite side. The turbinate has been resected and you can see the sphenoid ostia very clearly. Once this step has been achieved, next one can go ahead to harvest the Hadad flap if that is in the plan. So it starts from the middle turbinate, posterior end at the sphenoid ostia. Using a blade, the cut is taken superiorly and anteriorly, going parallel to the bridge of the nose, coming as far anteriorly as possible. The knife is extended right up to the ala of the nostril, the mucocutaneous junction. It becomes difficult to use the 15 blade, and it's good to use a circular knife and stop short of a few millimeters from the mucocutaneous junction in the midline. The cut is taken parallel to the mucocutaneous junction and stops at the floor of the nose cavity, and this area can be extended more laterally as required. If one needs a larger flap, the floor incision anteriorly can go more laterally to involve the inferior turbinate, that is the modified extended Hadad flap. Otherwise we stop short at the base and start developing the plane between the mucosa and the septum, thereby elevating the flap. We often wait to give the lateral incision back towards the ostia at a later time, so that if the Hadad flap is not required, we can put back the flap on the septum, so it makes it a rescue flap. Now the flap is being dissected off the septum. It can be done easily if one needs by injecting submucosally some decongestant material or saline. And once the flap is dissected off the septum, the flap is bunched downwards and kept away from the path of the moving endoscope and instruments towards the sphenoid sinus. The same thing is done on the opposite side, and the cut is taken right down to the ostia, going a little laterally, preserving the pedicle, and now the area is ready for sphenoidotomy. You can see that while the mucosa was being dissected, already the posterior part of the septum has been broken, and one can see the gauze bulging through the defect. Now all one has to do is a posterior septotomy, so that there is enough room distally. So anteriorly the septum is preserved, posteriorly the septum is removed, and once we take away the perpendicular plate of ethmoid and the vomer and the rostrum is drilled down, we'll have a huge cavity of the sphenoid sinus and the posterior part of the nose, devoid of both the middle turbinates and the posterior aspect of septum, giving us a nice and large cavity to have free movement of instruments. Now there is a septum in the sphenoid sinus which is being nibbled out, and once this is done, the sphenoid area is squared completely so that you have maximum exposure of the sphenoid sinus to look into the sella. It should not be just peeping into the sella. All the margins of the cellar floor and the roof should be clearly accessible with a straight instrument. So as much cellar widening is done is better, and sometimes one even has to do a posterior ethmoidectomy so that you have good access to the roof and superior aspect of the anterior wall of sella. A drill is a good way to take down the rostrum because the bone is very thick there, and this kind of straight reach to the clival impression is very essential to have maneuverability of the instruments. Now, sphenoid mucosa is a matter of preference. You can strip the sphenoid mucosa, or one could cauterize it with monopolar. The only problem with stripping of the mucosa is small minute bleeding, which can easily be controlled with flushing with saline as shown here. Once the bleeding is well controlled and one is happy with the reach inferiorly towards the clival impression, superiorly towards the tuberculum sella, and laterally the two OCRs and the carotid, one can start drilling the floor of the sella. The bone is usually thinned out. At times it is small and thick and needs to be drilled out patiently, and it will be thicker to where the septum has reached. As you can see here, the septum has reached towards the right side, and that's being drilled, and usually the septum reaches out towards the carotid, so one needs to be sure whether we are exposing the carotid. It was customary initially to expose aggressively both sides carotid, but one can stop short of the medial margins of carotid on either side if you have a decent exposure of the sella. This is verified to the extent of lateral resection with navigation as shown here using electro-EM navigation. So we can resect a little more of the bone on the right side laterally till we reach the part that's being demonstrated as the lateral border of the carotid and the OCR, and that area is being nibbled out. Once this is done, then the dura is cauterized. One could use bipolar or monopolar at a very low setting so that there is no bleeding, and the opening of the dura is done using the traditional spring knife, and the dura can be opened in a head-shaped manner or a crisscross manner or a U-shaped manner as preferred by the surgeon. We prefer to do it in a crisscross manner, so we have 4 flaps, 2 superior and inferior and 2 laterally. So the corners of the flap can bleed if there is extended right up to the intracavernous sinus, and that should be easy to control with Surgicel or bipolar cautery if available. Once the flaps are elevated, you can see the tumor bulging out clearly. The pulsations are pushing the tumor out, and then the decompression of the tumor begins. So initially we start from the floor. It's safe to remove some tissue for biopsy, lest most of the tissue goes away in suction. Once a tumor is removed from the base, you have extra place to put in a curette. The resection starts from below, going laterally towards the base, right lateral, then to the left lateral. Once the base, then right lateral and left lateral towards the base is curetted, then the superior angles on both sides are curetted, leaving the superior aspect posterior and anterior for final decompression. Now a different curette is used. This is a malleable curette. If you notice, all the curettes are blunt tipped. The malleable side angle curette is used along the plane from lateral to try and dissect and remove the superior part. If you are in the right plane, the tumor tends to dissect off from the arachnoid, which tends to push the tumor down, and whatever tumor is dislodged is caught outside the cella and delivered into the sphenoid sinus and into the nostril. One should be careful not to pull on anything from intracellular without being under direct vision. The curette helps to do more blunt dissection and release of any tumor that is stuck to arachnoid. If the arachnoid is bulging, it's good to have a lumbar drain to drain out CSF so that the arachnoid will recede and it will be difficult to injure a receding arachnoid. So as you can see here, the arachnoid is receded and we can peel off the tumor remnants from the normal gland seen towards the right side. Once the entire tumor is removed, there could be some areas of bleed seen at the apex. It's all pinkish, there is no grayish parts left, and these small areas of bleeding can be easily controlled with Surgicel blood jets and cotton pressure. If you have intraop imaging, that can be used to identify nukes and corners, something like this at the base, and this is curetted out again in the cavernous part on the right side. And if there is a bleed, as you can see here, there is a gush of fluid coming as the tumor is removed from the cavernous. Just mere head and elevation and packing with cottonoid is enough to control a cavernous bleed or ooze. Now the cavity is inspected well and ready for packing, and packing is done with fat and fibrillar. And once the packing is done, we do an onlay graft either with fasciolata or as shown here with a Duragen patch, which is your artificial collagen matrix. Once the overlay graft is placed snugly, then the Haddad flap can be mobilized on top of this to complete the repair. This ensures good control of CSF leak. One could use a layer of glue too to finally keep all these structures glued up together. So this is the Haddad flap being positioned on top of the Duragen patch, and it's covering the entire defect, and one has to look at the pedicle and make sure that there is no kinking of the pedicle. Once this flap is nice and snugly covering the defect, the nose is ready for packing. The pack is usually kept for 3 days under lumbar drain in position if there has been a CSF leak, and usually removed by 3rd or 5th day as preferred by the surgeon. Thank you.
Thank you, Professor Anand Balasubramaniam. I think we'll move ahead with the next topic. Saravanan, can you play Dr. Sukumar Surag's video, please?
Communist disc. Good morning. Any spine surgery for a spine surgeon is challenging. Lumbar discectomy is one of the commonest disc surgery performed by any spine surgeon. Today we'll see full endoscopic spine surgery advantages over other procedures for spine surgery. Endoscopic procedures can be done for all problems of spine, especially discectomy, brachiolar stenosis, lateral recess stenosis, and central canal stenosis. Nowadays, we use this technique for even endoscopic T-leaf. Coming to transforaminal technique, it's a posterolateral technique where we enter from around 10 to 14 centimeter from the midline, depending upon the pathology, whether it is medial, lateral, foraminal or extraforaminal. The concept of full endoscopic spine surgery is it's a percutaneous technique where we use a single port which has working channel, irrigation, outflow channel, the illumination, and the camera, all in one sleeve. Because of this irrigation, we have excellent magnification and visibility, and angle scope gives better visibility and less tissue damage. It can be done under local, epidural, or general anesthesia. Positioning is as any other spine surgery patient where patient is positioned and we want less lordosis here, and this transforaminal technique where we use done in either local anesthesia with some sedation or epidural. I do it under epidural analgesia most of the times. So just to show the technique, patient prone with epidural analgesia, in this case midline is marked and AP is marked. You can see the pedicles are equidistant, the lateral is marked. So once AP lateral are marked, so around 13 centimeters from the lateral marking, a small stab is given and a 18 gauge needle is passed and stillet removed and measured, and the guide wire is passed into the needle and the needle is removed. Once the needle is removed, this incision is extended few millimeter, around 6 to 7 millimeter. Both any transfers or a vertical incision can be taken. So dilator is passed over the guide wire, and this dilator, you can see how I am twisting motion in line with the guide wire and passing inside, and we feel a resistance, and once we feel the resistance, it is further pushed inside with the counter pressure and checked on CM. Once it is under the facet, this facet angle guides us inside into the disc space. I do it inside out technique where we enter the disc space first and then come out little bit and do surgery. So I have entered the disc here. So once I have entered the disc, I pass a sheath bevel facing to superiorly where it does not injure the traversing and exiting route. So once a sheath is inside, I tap it further so that it can enter the disc space. So if the disc surface is calcified or ossified, sometimes this might be difficult. So once a sheath is in situ, I pass the endoscope, and once the endoscope passes inside, so you see an endoscopic view, endoscopic image, 12 o'clock being the posterior or dorsum, 3 o'clock is superior, 9 o'clock is inferior. I use various instruments. This is a articulated curette where I try to mobilize the fragment. This is an articulated burr where I burr the superior facet, the non-articular part of the superior facet. So which overhangs into the foramen and forms a curtain to reach the lateral recess. So once this curtain is drilled at 3 to 4 millimeter, you can nicely see the pathology and you can just extract the pathology. So this is the way transforaminal surgery is done. It should be planned and the fragment should be planned and needle should be placed accordingly. So we see a case here, a L4, L5 disc, extruded disc on the left side, left radiculopathy, the lateral recess stenosis, and the ligament hypertrophy there. So needle is placed in the midline, and you can see the lateral view, the posterior 1/3. Once endoscope is placed, you can see here this highly inflamed disc material which was causing symptoms. So fragments or loose fragments are removed. Once the loose fragments are removed, we see the anatomy should not be missed. 12 o'clock is the posterior, that is the thecal sac and root area. 9 o'clock is inferior end plate, 3 o'clock is superior end plate. So once we retract the cannula a little bit, you can see the torn annulus there. You can see a nice torn annulus there. So, and the thinned out annular fibers. I just cut the fibers a little bit. I'm just cutting the fibers because it's a 30-degree angle scope. You can see the roof very nicely in here. You can see the epidural fat, it's a thecal sac area and the root area, and there's some epidural loose which I coagulate with RF, high frequency RF. Once loose fragments are removed, I use punches to remove the fragments which are of interest. So you can see a big fragment is coming out, which is just under the root. Once the fragment is out, we should not be very happy because there might be partial fragment might have come out and the still fragments might be there. The edges of the area is just cleaned with the RF. Then you can see at the 12 o'clock, still some fragments are lying loose. So try to catch those fragments and remove the fragments. You can see the fragments have been removed. The second fragment has come out. And now you can see a nice rent in the annulus and the PLL. So the third fragment is out. Still we are not able to see the thecal sac or the root. So I just use a hook, which is articulating hook. Try to hook out any loose fragments. And I can see a fragment there. So it's one more big fragment. I'm just trying to extract the fragment. Now you can see a good floating thing there, and you can see a thecal sac or a root there with thin streaks of blood vessels. Once that is done, now we need to decompress the root all around. So just remove some annular fibers, and you can see transversely lying lumbar artery and lumbar vein, which need to be removed to decompress the lateral recess. I cut the lumbar artery. Now I'm coagulating the lumbar vein, and once it is coagulated, I just cut them. Then I remove the loose tissue over the nerve. You can see the now well pulsating. So all have to ensure that end plate to end plate clearance and the lateral recess need to be decompressed. I removed the ligament also. Now you can see the root is well decompressed all 360 degrees. That is posterior, anterior and lateral. All three surfaces have been decompressed and root is well pulsating. So immediate post-op, see MRI shows the complete fragment removal and the lateral recess is well decompressed. The second case again you can see L4, L5 inferiorly migrated extruded fragment with right side just medial to pedicle. Again patient prone on epidural analgesia, epilateral mark, 13 centimeter. We have put a needle. You can see the guide wire in place and the dilator in place. The endoscopic image you can see here at 12 o'clock, highly inflamed material, and 9 o'clock you can see the inferior end plate because we have tilted our scope little bit inferior because of the pathology which is lying inferiorly. All the loose fragments are removed. Once the loose fragments are removed, cannula is withdrawn little bit so that we can see the facet junction. The facet and the end plate, that angle is the one which need to be cleared. That's the lateral recess there. So we need to clear open up the lateral recess. The area to be drilled is the inferior part of the facet. That is the facet pedicle junction. So that is the area where we need to drill and open up this whole thing is the facet we are seeing now. So once I drill the facet, you can see I use a articulating burr to drill the facet. Once we use an articular burr, so we can easily drill this area. We use a non-articulating burr. It is difficult, so because we cannot reach that area because of the angled scope. So articulated burr is better. I am drilling the non-articulating part of the facet, that's the free surface of the superior facet. I removed some, you can see the angle now, the end plate and the facet angle. The lateral recess has been opened up a little bit, but still you are not able to see the fragment. So I need to drill it further. That's the facet pedicle junction. You can see here the facet pedicle junction. That's the facet pedicle junction. I need to just little bit drill either 1 to 2 millimeter to open up the space so that therapeutically you are doing a lateral recess decompression. At the same time, you are removing the fragment also, the remaining fragment which has gone inferiorly. You can see that's the lateral recess has been opened up, but fragment is seen there, which has been removed. Fragment has been removed nicely. Once a fragment is removed, patient walks home on the same day or in the evening. You can see here the completely decompressed fragment is removed. Lateral recess is well decompressed. Coming to interlaminar full endoscopy surgery, the concept is same, except here we have more advantage of mobility. The patient is positioned under GA, and the case you can see how it is done. A 29-year female with low backache radiating to right side, the L4, L5S1 extruded disc. So we did a right full endoscopic discectomy. AP is marked just medial to just lateral to midline. A small nick is placed, dilator is passed, and again confirmed on CM, which is just medial to just lateral to midline and at the level of L5S1 disc space, just landing at the facet. So once it is done confirmed, then you put a scope inside. Once you can see this is a irrigation channel, this is a outflow channel, then this is a camera connection, and this is the light source. Once this is done, we enter with irrigation around 30 to 40 millimeter of mercury. I use a little finger and the ring finger to support the cannula and the thumb finger for supporting the scope. And you can see the steering effect of the interlaminar approach. Endoscopic view, you can see the muscle fibers just coagulate and few muscle fibers has to be removed. Once you remove the muscle fibers, you see the yellow ligament. You can see the yellow ligament there nicely with small ooze from the muscle which can be coagulated. That's the beauty of this irrigation and the magnification of this endoscope. So you can see fine bleeders on the muscle edge. They just coagulate it and you can see the yellow ligament now. So once you are sure that done adequately, then yellow ligament is cut to create a small rent in the yellow ligament. You can see the rent is created. Just extend the rent and just with the tilting the cutter and going further closer so that we can see what we are cutting. So the cut is extended laterally as possible so that we can see the lateral edge of the root. A small bit of fat is removed so that we can identify the lateral edge of the root. Here, identifying the lateral edge of the root is the key. In view of our small instruments, it is very easy in the interlaminar space, and with our angled scope, it is very easy. If you are not able to identify, come out a little bit and drill the facet. So you can see the lateral edge of the root here. Once it is seen, with the dissector, you can just release the root from the disc bulge and using the cannula bevel, just pushing it all around to retract the root. So my bevel of the cannula is retracting the root. Once it is retracted, I just coagulate the surface of the annular bulge and I put a small nick over the annular bulge, which is the area of the prolapse. A small nick is given, annulotomy is done here and annulus is cut, which is very thinned out here. Once you cut, you can see the extruded fragment is already there. So it is very easy and very clean. You can see the visibility. There is no blood. Nothing is there. The disc material is removed, and you can see the edges. There is some osteophytes or tough tissues there, which is also removed. Now, superiorly and inferiorly, the osteophytes have been removed. The disc material has been removed, and you can see the root area, which is very, very clean. You can see the root area, the vessels over the root, so nicely visible, and the fat droplets are very fine. Globules of the fat are seen very nicely, and you can see the fragment has been removed, completely decompressed root, and the cannula is removed. Once you are removing the cannula, you can see the size of the rent. It's a very small rent made in the yellow ligament. The second case you can see it's a small L5S1 inferiorly migrated fragment with severe left radiculopathy, especially on the left side. Again, the dilator and cannula in situ, and you can see the advantage of interlaminar where you can steer superiorly and inferiorly the same opening. And once your scope is inside, you can see the muscle fibers. As we saw in the previous video, just remove some small muscle fibers. Once you remove the muscle fibers, you are there. You can see the yellow ligament already. So once your yellow ligament is removed, you can just cut the yellow ligament, make a rent in the yellow ligament. Once the yellow ligament rent is made, go closer and then start cutting laterally. Start cutting laterally as lateral as possible. And once you cut laterally and see the lateral edge of the root, so you can see the root, and I remove the ligament as lateral as till the bone. You can see at 6 o'clock, you can see a bone. So just retract the root and push the cannula inside and gently rotate. So gently rotate so the whole root gets retracted. You can see the bulge. I am putting a small nick in the bulge and again use a cutter to just open up the space. Here you can see once you remove the disc bulge, because it's an inferiorly migrated fragment, so and a chronic disease, so there will be some osteophytes here. I can see a superior end plate osteophyte here which I am cutting. And also once this osteophyte is removed, you can see the inferior osteophyte has been cut and removed, and you can see the body of S1 where you are seeing the bleeding now. That's the body of S1. The osteophyte has been completely removed, flush to the bone, and this is a small spicule just underneath the root. You can see here the small spike is there that need to be flattened further. I use a hand mill to flatten it further. I just coagulate the bleeders with using a high frequency RF. So completely the bone is flattened there so that there is no spike or no bulge beneath the root. You can see now the disc has been removed, the osteophytes on the upper and lower end plates have been removed. Inferiorly, whole fragment has gone. You can see the fat there, and the root is completely decompressed. You can see the root nicely decompressed, and you can see the red vessels over it, and root is well decompressed. No fat has been removed, so fat is still there, which covers the root, and also the rent made in the yellow ligament is very small, so there is no loss of yellow ligament, which will avoid further additions. So you can see the small rent there, and post-op you see the complete removal of the fragment. The inferior migrated fragment is also completely removed. We can see the root nicely, and the patient goes home on the same day or the next day. So this is the advantage of full endoscopic spine surgery, where the irrigation and the visibility helps us seeing the things very clearly, and the angle of the scope we can reach superiorly, inferiorly, and medially with ease. So the scope of endoscopic spine surgery has increased over years, where we can do almost all procedures with a simple endoscope. Thank you.
Thank you, Dr. Sukumar. Excellent talk. We'll have the discussion at the end of the session. So we move on to Dr. Manas Panigrahi, Senior Consultant in Hyderabad KIMS, and also he's the Education Coordinator for the Neurological Society of India. So can we have Dr. Manas's talk, please? Saravanan?
Good morning. I'd like to thank Dr. Balamurgan for giving an opportunity to show a video on surgery for intradural extramedullary tumors. As we know, intradural extramedullary tumors are part of the spinal cord tumors. 55% of them of spinal cord tumors are extradural and 45% are intradural, and 5% are only 5% are intramedullary, which Dr. Ramakrishna will be showing the video. 40% are extramedullary, which out of that, 40% of them are meningiomas, 40% of them nerve sheath tumors. I saw a video of one or two videos of meningiomas and one or two videos of schwannoma in this presentation. Nerve sheath tumors can be of two types, schwannomas and neurofibromas. Neurofibromas are usually associated with neurofibromatosis. What are the basic steps in surgery? In a schwannoma, one can either resect the nerve root with the tumor or preserve the root and resect the tumor. One also has to be careful of the vascular supply, as most of them have neural foramen extension, and these radicular arteries are part of the spinal cord blood supply. Now, in a neurofibroma, the fibers are entangled with the tumor. So it is one has to, when it's a neurofibroma, has no choice but to excise the tumor along with the nerve root. Whereas unlike schwannomas, where the tumors are eccentrically placed, the fibers are displaced. So here one can attempt to make a preserve the nerve root, and fortunately schwannomas are more common than neurofibromas. Now, many times we think that excising the nerve root does not cause deficit, but then we have papers where they have published the risk of deficit or resection of the nerve root long ago in 1989. We had another paper in 2002 where they discussed on whether it's worth preserving or worth removing when the nerve roots in a nerve tumor are removed. In addition, this paper also analyzed and told that what is the risk of removing the single nerve root in spinal schwannomas. If you what the papers concluded that whenever these tumors are intralaterally located or tumor is going into the neural foramen, then they are probably from the nerve root, and here root preservation is required. Whereas if a tumor is in the dorsolateral position, then they are from the sensory root, then it is not mandatory but desirable to preserve the nerve root. So tumors which are ventral to denticular ligament are probably from the motor root. Tumors, when doing surgery, if you find the tumors dorsal to the denticular ligament, then you have a choice of excising or preserving the nerve root. Blood supply along with the nerve root, one has to preserve all the radicular artery, because the radicular artery reinforces the anterospinal and the posterior artery. So if one does any coagulates this, then they can have weakness because of the affection of the blood supply. And that is more important, especially in the lower thoracic region where the Adamqui's artery, one of the arteries is Adamqui's artery. Tumors can be divided into 4 types depending on the origin of the tumor. They can be into 4 types depending on the origin. The type 4 is totally extradural. Type 1, 2 are the intradural part, and type 3 is the dumbbell type. Today I'll be showing only a type 2 tumor. Now, in the thoracic or cervical region, one can tell it's enterolateral or dorsolateral situated. But a cauda equina is difficult to tell whether it's arising from a sensory or motor root unless one has a intra-op monitoring. Hence, in a cauda equina, it's important to preserve the nerve root all the time. This is the same case where the tumor, after dural opening, one can see the tumor. Then the tumor is delivered out from the cauda equina, and then one has to identify the proximal and the distal end of the nerve root from the nerve root, the entry and the exit point of the nerve root from the tumor, and then incise parallel to the expected nerve root from the proximal to distal end, and then dissect the plane, the tumor out from the nerve roots. Here, these are the nerve root and the tumor from cranial to caudal and caudal to cranial, and finally the tumor is removed, delivered out, and this is the preserved nerve root. We saw a video of the same steps which I saw, and so now this is the video as I was explaining you. The dura is always open after one can do a laminectomy or a laminoplasty. This was just a 2-level laminectomy, so we had done a laminectomy. The dura is always open from cranial to caudal. Once it's open, the dura are hitched, and then tumor is identified and delivered out delivered out with a hook. Identified the route, the entry and the exit point of the route. You can see here the entry and the exit point of the route. Then incision is done parallel to the entry and exit point. You can see here there's a thin layer of the nerve root like we do in a CP angle. And then the tumor is delivered out the nerve sheath, and there's a plane between the nerve sheath and the tumor. Continuous irrigation. In some ways, injecting fluorescent helps in having a good contrast between the tumor and the nerve root. The tumor is dissected from cranial to caudal and then caudal to cranial. You can see here the nerve root of the tumor. Then we remove and finally you have the preserved nerve root there. Let me show an example of a spinal meningioma. Unlike schwannomas, meningiomas have they're not attached to the root. Not only they're attached to the root sleeve, they're attached to the ventral and the dorsolateral dura also. So they are a little difficult than the schwannomas. Unfortunately, unlike neurofibroma, which are more dorsolaterally situated, in meningiomas they are ventrally situated. 70% of them are ventral to the dentate ligament. In addition to the broad attachment, they are very vascular, they are firm, they are ventrally located, and hence total removal is many times difficult and does not excise the dura when the recurrence rate is higher. One also has to remember that like neurofibroma comes out from the root, meningiomas comes out from the root sleeve. So while operating, one has to be careful that preserve the nerve root like you preserve in the neurofibroma. Otherwise, you'll have post-op deficit not only from the damage in the cord but also from the manipulation of the root sleeve. Hence, if one reviews the literature, the incidence of morbidity with spinal meningiomas has ranged from 2 to 21%. Similarly, the incidence of recurrence also has ranged from 1.3 to 14%. So it's important to practice the appropriate surgical technique in treating spinal meningiomas. But there are many techniques described to reduce complications and increase the extent of excision. This was published in 1989. There's two T-shaped dural incision with cutting of the dentate ligament helps in mobilizing the cord and removing the tumor. Later, in addition to the resection of the T-shaped dural incision, people said that 30 to 40% of the time one needs to resect the facet. Some of them went, in addition to resecting the facet, they removed the pedicle also, and then in turn needing instrumentation depending on the extent of the attachment of the tumor. In addition to removing the bone, this is from author from Japan, he said positioning the patient in a lateral position also helps in having a better visualization and reducing the morbidity. Because one can access or visualize the tumor properly. People also have done minimally invasive, where they've done a unilateral hemilaminectomy, but then in turn they have removed facet, they have removed pedicle. In turn, they have caused more bone. Though they preserved the lamina, but then they did more of destruction on the stabilizing part, like removing the facet and removing the pedicle. Because of all this confusion, there was a paper in 2017. They proposed radiological classification and to decide on the surgical treatment. They divided tumors into 4 types depending on the type of attachment, whether they are ventrally located or dorsally located or laterally located. And depending on that, they suggested either pure laminectomy, laminoplasty to facetectomy with pedicle removal or extra cavitary approach. But then what do? We try to preserve the facetal pedicle. We try not to do a lot of bone destruction. We do a laminoplasty, but do a contralateral approach. What I mean by contralateral approach, that we stand on the opposite side. Surgeon stands on the opposite side to the side of tumor. Instead of standing on the side of the tumor and operating, one stands on the opposite side and rotate the table to have a better visualization of the corners of the tumor. Like this, if instead of the standing on the side of the tumor, we do a standard laminectomy, stand on the opposite side, so one can see the dentate ligament and see the ventrolateral part of the dura and the attachment without destroying the facet on the pedicle. Like this case, which is this tumor is on the right side. This was a recurrent tumor which was earlier operated 14 years ago. So we stand on the left side of the patient and operate. So once you stand on the left side, one can see the corners of the tip of the dentate ligament easily, the attachment of the tumor easily, without causing any manipulation of the cord. This is an example of a tumor, and so an example of a thoracic tumor meningioma and a cervical meningioma. One which is situated dorsal to the dentate ligament, and one which is situated ventral to the dentate ligament. Now this is a tumor dorsal lateral situated tumor. Probably it is dorsal to the dentate ligament, where the tumor is arising from the root sleeve. As I already explained, this principle is of opening the dura from cranial to caudal. Identify the upper and lower pole, including the attachment of the tumor. Then devascularize the tumor either using a bipolar or laser. Here we are using laser from caudal to cranial. The last part to be done is the cranial part, as the root sleeve and the nerve roots will be adherent at that point. And then again, tumor decompression is done from the caudal to cranial, unlike the dural opening, which is done from cranial to caudal. And then finally, the involved dura is removed to reduce the recurrence rate. All this is done by standing on the opposite side to the side of tumor. So this is a standard laminectomy, and this is at the end of tumor resection. This one can see the dentate ligament preserved, which is ventrally post. And here at the end, one sees the intra-cisternal part, the root sleeve intradurally and the root sleeve extradurally, which is preserved. And this is the involved dura, which has to be excised. And after excising the infiltrated dura with a laser or a bipolar, we use laser, and then the duroplasty is done with an artificial dura. Now this is the video of the same case. The dura is open from the cranial to caudal. And then the tumor is devascularized from the caudal to the cranial, decompressed. Then dissection of the tumor from caudal to cranial. And finally, the involved dura being excised. The upper pole of the tumor is delivered. And this is identifying the root sleeve, both the intradural part and the extradural part at the end of tumor excision, and the leftover involved dura again being removed. The laser is easier because it occupies less space, unlike the bipolar. And finally, duroplasty is done. This is another case. This is a case in the cervical region, ventrolaterally located. This is a case which is ventral to the dentate ligament, unlike the previous case. So here, laminoplasty was done. So you use the same cutter of what you use for craniotomy, and stand on the opposite side to the side of tumor, and then dentate ligament is identified. Here the tumor is ventral to the dentate ligament. You can see the margin of the dentate ligament is incised so that the cord can be mobilized easily, and the tumor is attachment of the tumor is to the ventrolateral part of the dura, and that is devascularized using laser. And after that is devascularized, the tumor is decompressed and excised. This is the same laminectomy without doing any additional bone work. This is another case of a cervical, which I had shown the previous then. It's a recurrence one where it stands on the opposite side and operate. Same technique. I don't have to show the whole video. I shown the steps. There's just an example that again this is the dentate ligament was the tumor is ventral to the dentate ligament, which has to be first incised. All is done by standing on the opposite side. So no facet resection, no pedicle resection. Only at the end of the resection, one has to come to the ipsilateral side of tumor to see, to take out the tumor from the midline. And the table is turned either to your side or the opposite side to have an access to the tumor. And it's a tumor which is extending from one nerve root to the other nerve root, the tumor. So preserving the nerve root, detaching. So this is from one nerve root to the other nerve root. Laser is quite handy because most of the time the tumor is very hard, doesn't come in juicer. So laser helps in removing the tumor along with the dural attachment. As explained all the time, removal is from the caudal to the cranial. This is a small video of laminoplasty, and just to highlight that laminoplasty is done on is to make a small drill holes to identify the normal yellow ligament at the upper and the lower, and then engage the foot plate to do the laminoplasty, and it is done from the caudal to the cranial, and then the bone, the laminoplasty bone is retracted laterally. And it is, and this is just a tumor. This already has shown the technique of removing the tumor. And reapproximation is done to like physiological, so the muscle and the bone is replaced back. In conclusion, concomitant approach reduces bone work. Laminoplasty is preferred. Root preservation is required both in schwannomas and meningiomas, and dura need to be excised for meningioma. Thank you for your attention.
Thank you, Dr. Manas, and we'll move on to the next talk by Professor Ramakrishna Ishwaran on intramedullary tumors. Saravanan, can you please load Dr. Ramakrishna Ishwaran's?
Chairpersons and organizers, thank you very much for asking me to talk about intramedullary spinal cord tumor excision surgery with intraoperative neuromonitoring. That's my hospital. This talk is based on my experience with 56 patients operated for tumors in the spinal cord, an average of about 2.6 cases per annum over the last 21 years. Majority of them have been ependymomas or astrocytomas with a sprinkling of all other lesions. And in the last 6 years, we have done 17 cases with intraoperative neuromonitoring. My foremost indication for surgery is a patient who has progressing neurological symptoms and the MRI shows a definite tumor. Like for example, in this lady who has 6 months history of weakness and numbness in the upper limbs, there are pyramidal tract signs in the lower limbs with wasting of the upper limbs. And this is her MRI. It shows a tumor that has got a cystic portion above and a solid portion below that is enhancing and that is well defined, which can be excised with safety under the modern neuromonitoring conditions. Sometimes we have patients with very minimal symptoms who have a definite mass which is resectable, and in those patients we elect to do surgery because if they are left alone over time, they'll just keep getting worse. Sometimes the serial MRIs may show growth necessitating surgery. And this is one such example of a patient who was very minimally symptomatic, a very discrete tumor, easily excisable, though it is in the middle of the spinal cord. Sometimes we are asked to do a biopsy for patients who are suspected to have myelitis or tuberculoma, like in this lady. This turned out to be myelitis and the patient improved on plasmapheresis. We face some special situations at times, for example, a holocord tumor. Sometimes it's not the tumor, it's just the cyst that is spreading all over the cord, and the tumor itself is very localized to one region of the cord, like in this patient or in this patient. All we need to do is to excise the solid portion here, and all the cyst will naturally dissolve on its own. But sometimes we also have patients like this in whom the astrocytoma spreads all over the cord, and all we can do is, these are hardly accessible lesions, and so we can just biopsy this lesion for further adjuvant therapies. Another condition called infantile cellular ependymoma, which is not resectable, lesion with a poor prognosis, which I've got from the literature. The only investigation that you would ever need is a multiplanar whole neuroaxis MRI, especially a contrast image, which will tell you the resectable borders of the tumor. In the preoperative counseling, we have a checklist. We video record this conversation with the patient and also get a written consent. And the patients do get time to get their doubts cleared about issues which concern them, like whether they can work again, whether they can walk, etc. Preoperative preparation is with steroids and with antibiotics. Anesthesia is a very important part of the surgery because you cannot use any halogenated anesthetics in this surgery. They interfere with ACPs, so it's done as a total intravenous anesthesia procedure. Muscle relaxants are not used except initially for intubation. By the time you get to the spinal cord tumor, the effect of the relaxant, short-acting relaxant would have worn off. And then it's important to maintain the blood pressure to prevent ischemic cord damage during the dissection. And during closure, a routine anesthesia is used. We position the patients prone, both for cervical as well as for thoracolumbar lesions. Should have enough room for the C-arm to move in and out, and then we place the electrodes for intraoperative neuromonitoring. This is done basically to prevent further iatrogenic neurological worsening of the patient due to the surgery, primum non nocere. But we have also found that having the monitoring and showing that there is no dip in the potentials, we know that we are safe in going ahead with greater and greater amounts of resection. And therefore, compared to the era when we were not doing the monitoring, we find that we are able to maximize the resection with intraoperative neuromonitoring. The MEPs test the motor pathways which are there in the anterior portions of the cord supplied by the anterior spinal artery, whereas the SCPs test the posterior portion, that is the route of entry for us, and they are the areas supplied by the posterior spinal arteries. This is the whole setup that we have. The most important part of the whole thing is, of course, the technician who's there all the time, the electrophysiologist, who keeps warning us of any dip in the potentials or an increase in the latencies. ACP is usually monitored from the median nerve and the tibial nerve. We use upper limb monitoring even for thoracic spine cases because that acts as a good control. And these are the stimulation parameters. We need to stop the surgery for about 2 to 4 minutes to get the averaging done to know whether your ACP is intact or not. And we look at the amplitude as well as the latency. It's useful for monitoring the incision. And then we should get back the SCPs which become lost after the pile stitches are put. They should come back at the end of the surgery, and they poorly predict the presence of motor deficit in the patient. With MEP, there are two ways of doing it. One is the D wave recording directly over the spinal cord, and also the EMG, which comes after a little latency because of the synaptic delay that occurs in the at the anterior horn cell level. So those are the stimulation sites, and this is the recording site. And we have to have a good idea about which muscle is less involved, because a very weak muscle is not likely to give you a good EMG response. So a good clinical examination is necessary prior to the surgery. We have criteria for abnormality, and these are all known to our neurophysiologists, and they warn us in time so that we don't continue to damage the cord in that particular area. We'll go back to our surgical videos. This is a patient whom I showed you earlier, the one with the right hand weakness in the spastic legs and ependymoma in the spinal cord. The level is marked, the midline incision is made, bilateral muscle dissection. For short tumors like this, we do up to 3 levels, we just do a spinal laminectomy. Whereas if it's a longer level tumor, especially in children, it's very quite easy to cut the lamina on both sides, reflect the whole all the laminate together as a flap, and put it back at the end of surgery and fix it with titanium plates. So looking at the video of this patient, we have already done the opening of the dura, tacked the dura. Now that's the arachnoid that's being opened here. We go to the cranial end of the tumor where there's a cyst, drain the cyst, and after draining the cyst, the cord becomes lax. And you can also get the upper end of the dissection. We come back to the middle of the tumor, make the midline myelotomy. The midline is identified as being between the two posterior columns. There is actually a small pia that inserts itself between the two, and you can see it under high magnification. You can also identify it electrophysiologically by dorsal column mapping. As soon as the myelotomy is made, you can see that the tumor is visible. The myelotomy should be extended to as much length as you want, and these pile stitches have been placed already, and the biopsy of the tumor is done for squash. Having done that, we have to decompress this tumor because the tumor is too large to be moved as a whole, and that is done with the ultrasonic surgical aspirator. You can see that the tumor is converted into an empty shell, much like what you do with any other extraaxial tumor. No bipolar is used, just pieces of gelatin sponge over which cottonoids are placed. And then once the tumor is sufficiently thinned out, you can dissect it in the plane between the normal cord. There is a small ependymal layer all around this tumor, which you can see, and that is a plane in which the dissection is done. Alternatingly, we have to decompress the tumor wherever it's bulky, again using the ultrasonic surgical aspirator. Having done that, we can identify the plane better, lift it up by the pole, do the side dissections. Once you've released it sufficiently at the sides, you can also lift it up at the pole. Let's see what happens to the neurophysiology at this time. There is a drop in the SCP as soon as the pile stitches are put, but then these will come back after some time. The MEPs remained robust throughout the dissection. Now, having debulked the tumor sufficiently, we can roll the tumor off the surface of the spinal cord, the inner surface of the spinal cord, like this. You can see how it strips off beautifully from the spinal cord, the whole remaining bulk of the tumor. And towards the end, you will find that there are a few ependymal strands that are still holding it, which need to be dissected and taken out. Sharply divided. And that's the last strand that's being cut to deliver the rest of the whole tumor. We have to check the hemostasis and then close the pia. And finally close the arachnoid also. It's arachnoid that's being sutured. And in this patient, there was a return of the SCP amplitude to 70% of the baseline as after the closure. The MEPs remained robust throughout the tumor removal. And she did not have any neurological deterioration. In fact, she started improving in her neurological deficits, an ependymoma histologically, and that is a specimen that's been removed. The next patient is the one who had very minimal symptoms, just a little bit of fatigue in the arm while using a computer mouse, no neurological deficits. You've got to be all the more careful because it is in the respiratory control region of the spinal cord. Again, same atraumatic dissection, debulking, removal of the tumor. The script runs the same in this patient also. And what really happens over here is that the baseline ACPs which are intact, MEPs are only slightly impaired in the left leg. And during surgery, there is a drop in the MEPs over here. You can see that there is a definite drop from the left leg. There's also a drop in the ACP, but then at the end of the surgery, this thing comes back. There's no neurological deficit in this patient. Even though there was a drop in the MEP, there is no neurological deficit in this patient. And there is a total excision of the tumor. This is pre-op and this is post-op. And you can see the total excision of the tumor on the next day. The next patient is a different ball game altogether because this is in the conus and in the chorda. The patient has got a lot of neurological deficits to begin with. And this is a tumor which is extending right up to the surface. You can see the tumor on the surface. There's no need to make a formal myelotomy in the midline. You can simply open the tumor right on top over here. And once you open the tumor, you can debulk it. After having debulked the tumor, you can strip it off from the roots of the chorda equina. The tumor is taken out of the hole over here until it enters into the spinal cord. This is the conus part, the chorda part of the tumor. Once you get into the conus, it becomes like a regular intramedullary tumor surgery, debulking with the ultrasonic surgical dissection and removing tumor. This is more vascular, so a little bit of bipolar coagulation is needed along the way. Why is it more vascular? Because this is a more malignant tumor. And in this patient also we had a drop in the ACP, but there was no change in the ACP from the opposite side or in the MEP in both legs. And this is the patient walking up on the 4th day after surgery. It was a glioblastoma. There is a total excision. The patient has been followed up for 2 years now, and he's been doing well till now after adjuvant therapy. The next patient again has got a tumor which is attached to the conus and chorda, and in this patient we chose to do sphincteric monitoring. You can see a lot of spontaneous activity in the sphincters, sphincteric muscles here. And in this patient we employed fluorescein enhancement. So you see that there is a lot of fluorescein enhancement. And once you go to the tumor dissection, this can be done under fluorescein. Partly you can open the cystic portion that is there near the chorda equina and remove the tumor from within this region. That's a tumor taken out. Tumor in the conus part is also dealt with in a similar manner. You can see that there's a drop in the ACP amplitude during the dissection, especially from the left leg. And when you go into the part that is there inside the conus, there is a drop in the MEP amplitude also in this patient. And that's after total excision. You can see that there's a clean cord with no bleeding. That is the final MEP. There is a return of MEP. In this patient, there was a little bit of neurological deterioration, but not very bad deterioration. The patient did make a recovery over the next 7 days. My last patient is a girl who had had a biopsy for a lesion, not an excision, about 1.5 years back. The tumor was small and it was located in the lower cervical cord. Because she had worsening of the tumor, we decided to excise this. And this is the D-wave monitoring electrode. You can see the tumor is on one side. That is the removal of the tumor that's being done over here. The D-wave is being continuously monitored in this patient. And you can see this D-wave is remaining intact. This is the baseline. As we keep dissecting the tumor, you can see that it remains intact. That is during the excision, there's a drop in the MEP, but the D-wave remains intact. And that's what gives us the confidence to go ahead and excise this tumor fully. You can see that it's extending up to the anterior pia. We have to be careful not to damage the anterior spinal artery here. And that's a final MEP return of the MEP after the excision of the cell. And when the EPs become abnormal, what do? The anesthetist has a checklist of things to do. The electrophysiologist has got a list of things to do. And the surgeon also has to stop the dissection, wash the area, and wait for some time before he goes. This is the flow chart from Sala and others from the European Spine Journal. This is a result in my personal series. I found that when D-wave monitoring was done, when the D-wave is intact, there's no neurological deterioration. In one patient, it was lost and it reappeared. The neurological system was intact in that patient. So we find that neuromonitoring helps us excise these tumors well. Thank you very much.
Thank you, sir. Thanks for the excellent talk and fantastic videos. Dr. Manas and Dr. Anand, could you please take over and do the moderation, please?
Hi, good afternoon, everybody. Dr. Manas. Yeah. So I think, yes, Manas, please go ahead.
Hello, you're asking Anand? I cannot hear you, Anand.
Yeah. You cannot hear me?
Yeah.
Okay, when you
please unmute and
hear me now? Yeah, I'm unmuted. Can you hear me now?
Yeah, Anand, we can hear you. Manas, we could hear you. Sir,
yeah, I'm also in.
Yes, sir.
Yeah.
Shankar is here with me.
Okay, I have a question to Manas.
Yes.
Manas.
Can I set the ball rolling by asking a question to Manas?
Sir, please go ahead.
Yeah. Do you find the need to excise the dura through and through in all cases of meningioma? Because what I do is there is a good, unlike in the cranial dura, in the spinal dura, there are always two layers. Can you hear me?
Yeah, I can hear you.
We can just strip off the inner layer and keep the outer layer intact. So the chance of CSF leak and everything else is much less. Even when I use a duroplasty, I find that there is a good chance of getting a pseudo meningocele, and though there may not be a manifest leak. And that's why I feel that just a stripping of the inner layer of the dura would be sufficient, rather than a through and through excision of both layers of the dura. What is your opinion on that?
Earlier, I used to do like that. Through and means just a strip of the dura is to leave in fear of CSF leak. But then I had two patients who came back with a recurrence after almost 10 to 12 years. But that time Duragen was, after we have got the Duragen available, I tried to remove the total dura and just place a Duragen on that, and it has been effective in preventing CSF leak. Earlier I used to do that, but I had recurrence.
And piecemeal excision and piece by piece or total excision, what do you prefer? I saw you doing the piecemeal excision for all meningiomas. Is it really necessary? Because you really detach the tumor like you do with a cranial, like a convex meningioma. You would be able to take out the tumor as a whole. And that comes out quite easily.
The size of the tumor. If it's a small size, then you take it as a whole. But if it's a bigger tumor extending, and many of them actually engulf the nerve roots because they go into the neural foramen. Because the origin of the tumor is from the dural nerve sheath around the dura. So usually I leave part of it there and take out the tumor and then do meticulous dissection near the nerve roots.
I have always been fascinated. I've always been fascinated with this use of the laser. Anybody else with experience on laser in the spine?
Yeah, because the laser is like 0.5 or 0.7 mm their thickness. So means it's far easy to manipulate that, because bipolar is a bigger instrument. Laser, you can go inside and cut excising the dura and taking and surgery becomes very fast also. It is faster than using bipolar, and because it's coagulate and cut simultaneously. So unlike bipolar, you have to coagulate and then use a scissor to cut. You don't have to do that. So surgeries are faster and more convenient. Especially stand on the opposite side and do with a laser. Means it's very comfortable. Once you use, you'll never leave it.
Okay, question to Anand.
Yes, sir.
This Duragen that you use, do you think it's necessary when there is no CSF leak on the table? Because we just put fat and then put the hadad on top.
If there is no CSF leak on table, I don't use fat. I don't even use hadad. We just leave the thing open into the sphenoid sinus and then we close. We just pack a few.
I've done that
Surgicel
sometimes,
or,
but
yeah.
See, one problem I have faced is that the arachnoid tends to come out through the, it just tends to bulge out through this.
You just pack with fibrillar and gel form, that's more than enough. So it settles in very well.
My experience is not that. I think we need to use fat just to prevent prolapse of the arachnoid, downward prolapse of the arachnoid. Fat is necessary in every case, even there is no CSF leak.
Yeah, but you will see that it epithelializes quite fast. So you can use local mucosal cover or you can use the turbinate. You need not necessarily harvest a graft. And the fat we put in never stays there. It usually gets extruded out over a period of time. Hadad, just to prevent a CSF prolapse, I think is too much of overkill because Hadad has its own problems with nasal issues, crusting and other issues for the patient. It's unnecessary morbidity for the patient when there is no CSF leak for you to do a Hadad. So I think there are ways in which you can manage the arachnoid prolapse without a Hadad. So if you want, you can just pack fat if you don't believe in leaving it empty. But I think Hadad is overkill when there is no CSF leak.
But it depends on the size of cella also. No? If the tumor is very big, then it is always better to fill up the cavity because I'm sure you will have problems who came after 15 years with chiasm prolapse and all those. So if the size
Probably,
of the cella
yeah.
is
If
big,
it is a large tumor, and the cavity is very big, then it may be easier to just pack it with fat and leave. Yeah. I always use arachnoid. Always use a lumbar drain. Yeah, lumbar drain for all the patients. So the lumbar drain usage has reduced the incidence of on-table CSF leak drastically. So I think that is an important point which I have learned over a period of time. We have gone from no lumbar drain to again no lumbar drain, back to lumbar drain now. So from using lumbar drain to treat a CSF leak, we are using now lumbar drain to prevent a CSF leak, and it's, I think, very, very valuable.
One thing is, if you're going to put a lumbar drain, it has to be put before the surgery, because after the surgery,
100%. So
you
all our
cannot,
patients,
you cannot even put it in.
Exactly. No, if you want to prevent a CSF leak, you have to put it before. So all our patients, as a protocol, have a lumbar drain in position, and we keep it blocked. And by the time when we are decompressing the tumor, if there is an arachnoid prolapse, we immediately open the lumbar drain, let out 5 or 10 cc of CSF.
Before the surgery.
The arachnoid beautifully goes back, and you can peel off the tumor, and the arachnoid can never get injured. A receding arachnoid is very difficult to injure. A bulging arachnoid just bursts like a bloated balloon very easily.
Run out of time.
No, we have another 10 minutes.
Okay, good.
I have a question for you, Dr. Ramkrishna.
Yeah, tell me.
Intramedullary tumors, what is your protocol for using steroids?
I always give
spinal cord injury. So do you
I
use?
I always load the
What
patient
is the
with
steroid
on
you
the table.
use? What is the dose?
We use
Even
35
before?
milligram per kg. I'd shown that on the slides. One dose.
Yeah, so
to
you
surgery.
do. I wanted to highlight that point. Yeah. So when you use it for all patients, or you use it only when your MEP goes down, or post-operatively?
No, use it for all patients. At the time of induction, it's given. Except if there is a big contraindication.
Do you continue for the first 24 hours?
Yes, I do.
Do you continue it for 24
until I
hours?
make a good neurological assessment, make
So
sure
you
that
do
the
like
patient. Pardon? I do continue it for 24 hours, and that is till the next day when you can make sure that the patient has got no neurological deficit and you got the MRI done and confirm that everything is fine.
Okay, so you believe in steroid usage for all intramedullary cases?
I don't know whether it helps or not, but I'm afraid of not using
Yeah.
it.
Yeah, even in spinal cord trauma, now steroids is being distributed.
I'm not using.
And it has
I'm not
come
using
to
it
be
at all for trauma.
guideline. Yeah, trauma. Yeah.
Because that is given after the trauma. Here we are giving it before the trauma. That I think that makes the difference.
Before the trauma.
So Anand, do you use steroids for all cases? Intramedullary?
Steroid for intramedullary? No. I use only if there has been a drop in MEP, or if post-operatively I find a deficit, then we use steroid. but the same dose. We'll use it like spinal cord injury. But if there has been no drop in MEPs or no deficit in the patient post-op, same as pre-op, we don't use steroids.
Balamurugan, did you use?
I always use, I think pretty much similar to views of Dr. Ramakrishna Ishwaran. I use it because I firmly believe that steroids should be given before the insult. There's no point in giving it after the insult. And I think it has helped me. I feel that sometimes maybe I would have got into a problem. I possibly escaped because of the steroids.
Is Dr. Sukumar there or?
Sorry?
Dr. Sukumar present on spine endoscopy. He's online or he has left?
Dr. Sukumar must be there. Dr. Sukumar, can you please unmute?
Yeah, I'm there.
Yeah. I have a question.
Yes.
Which case of disc you will not prefer do an endoscopy?
Nowadays, almost all
cases are good for
with the combined techniques like interlaminar and with the combined techniques, both interlaminar and transforaminal, nowadays almost all discs can be operated by endoscopy. Previously, we were practicing only transforaminal. During that time, especially the central disc and calcified disc with large osteophytes, it was not possible to do transforaminally. Now the interlaminar approach, we can almost do like same as micro lumbar discectomy. So we can do all cases, and with the good drill system, so we can drill out all the osteophytes. Do same thing as tubular or micro lumbar discectomy. So we can do with interlaminar technique with the advantage of irrigation and the clarity of the vision. So we can do almost all cases. And
Manas, do you use steroids for your intramedullary cases, Manas?
No, I don't use.
I have a question to Manas.
Huh?
Manas, what about the cases which have a large extent outside the foramen? How much are you able to take out? I mean, what is the distance to which you'll be able to follow the tumor into the thorax and get it out through just the posterior midline approach?
No, if it's beyond the foramen level, till 1 centimeter I can do that till beyond, but otherwise then you have to do an extended approach, do an costotranseptomy or something. What I'm telling is tumors which are confined till the foramen, one need not do a facetectomy if one works from the contralateral side. If it's beyond the facets, the lateral margin of the facet, then one has to do a facetectomy.
And in such cases, do you stabilize?
If I remove facet, then I stabilize. Unilateral stabilization I do.
Unilateral. Okay.
Unilateral.
I don't stabilize because the other side is perfectly intact. And most of these patients do not have any symptoms due to instability. So because there is no muscle exposure done on the opposite side at all. Muscle exposure is done only on this side. The entire muscle ligament complex and the facets, everything on the opposite side is intact. So for 1 level, 2 levels, I think there is absolutely no need for stabilization if you do it by a unilateral approach.
Yeah, but if you think to achieve physiological what was there before, if the foramen is widened and facet is already damaged, that means the patient is already used to that with the one facet. But if we are damaging and removing it, then I prefer that we achieve what was there before. So I do a unilateral fixation.
Thank you. Thank you everyone for active participation. Thanks Dr. Ramakrishna Ishwaran. Thanks Dr. Manas. Thanks Dr. Anand and Dr. Sukumar Sura and Dr. Shankar.
Thank you.
Thank you so much. Hope to see you in the next few sessions also. And please encourage your students to actively participate. Thank you so much. Thank you.
Thank you. Thank you for the opportunity.
Thank you. Thank you. Thank you.
We'll move on to the next session. We have 4 speakers and now we'll be moving on from spine into cranial. We'll have Dr. Dilip Panikkar speaking on awake craniotomies, Dr. Rajkumar Deshpande speaking on how to clip an ACOM aneurysm, and Dr. Suchanda Bhattacharjee speaking on epilepsy surgery for the beginners, and Dr. Kuntal Kantidas from SGPJ Lucknow, who will be speaking to us on perisylvian gliomas. And I think we've got a fantastic team here. And may I request Dr. Dilip Panikkar's talk to be put up, and request all the 4 speakers to actively participate and moderate.
My name is Dr. Dilip Panikkar, and I will be talking to you today about awake surgery in hemispheric lesions. I come from the Aster Medcity at Cochin. We do encounter a large number of hemispheric lesions in our daily practice, and the majority of them are gliomas. What we realize now, what we know now, is that in the management of these tumors, the extent of excision is a very important determinant of outcome. However, when one tries to excise these lesions radically, it is very likely that one will encounter or create certain deficits in hemispheric function which might significantly affect the patient. As the survival of patients with these hemispheric tumors, especially gliomas, keeps getting better and better as the understanding of these lesions and treatment modalities get better, it is important to recognize that the quality of life for these people after treatment is as important as just plain survival. So, to aid this, the need for functional assessment of the hemispheric functions during surgery is exceedingly important. Now, this brings us to the question, can these be done with the patient asleep or awake? This is an age-old question, and what we know that there are certain functions for which the patient can be asleep during the procedure. For example, the assessment of motor functions. But for a number of other functions, especially language and other hemispheric functions, the patient has to be awake and responsive. Traditionally and in literature, intraoperative assessment has been largely confined to motor and language functions. And as a consequence for this, the risk of deficits of motor and language deficits has considerably reduced as these assessments are routinely practiced. What are the assessments that are possible with your patient awake? Language functions include number counting, visual object naming, and auditory comprehension, amongst others. Motor functions include simple and complex movement of extremities, both spontaneously and on command. Apart from these, there are a whole lot of other lobar and cortical functions that can be assessed, including writing, drawing, vision, memory, and so on, and lobar functions, and so on and so forth. To aid the functional assessment during surgery, the use of direct electrical stimulation either on the cortex or in the subcortical regions is a very common method. The use of a small current, the use of a small stimulating current will either induce a positive response where there is a brain function that is evoked by stimulation, classically motor functions like movement, or a negative response where a particular brain function is suppressed by stimulation, classically seen in language functions in the form of speech arrest and errors in naming and object recognition. Though this is a very common method of assessment, it is important to recognize that there are a number of false responses that can cloud interpretation of the patient's responses to electrical stimulation. These false responses could either be positive responses or negative responses. The positive responses, for example, where you have a contraction of muscles of articulation causing a speech arrest, or a negative motor response where synergistic movements are suppressed. This is classical. This is very typical for stimulation in the precentral gyrus. These are some examples of assessments of motor and language functions that are possible and routinely practiced during awake surgeries. These include speech, writing, object naming, motor functions, and so on and so forth. The picture below shows a typical setup of an awake surgery, especially the use of transparent drapes which allow an easy communication between the assessor and the surgeon during the procedure. As one moves into the awake surgical procedure, it is very important to prepare the patient adequately for this procedure. And for this, a very important step is for the patient to develop a very good rapport with the entire clinical team going to be involved in the procedure. So this mandates repeated interviews with members of the surgical team, the neuropsychologist, or the assessor, the person who's going to be assessing the patient during the surgery, and the anesthesiologist, who is very important during the entire procedure. As usual, a detailed preoperative assessment is required, which includes a detailed radiology, different sorts of imaging as is required by the patient and the lesion. And what is important is a detailed neuropsychological assessment, which gives us the baseline cognitive status of the patient. Now, the need to understand the baseline cognitive function is important because it tells us which functions, which abilities are retained and can be assessed during surgery and which are lost. It also categorizes them into a high and low functioning individuals, looks at educational status, work, hobbies, all these which allow specific interrogation of the patient during the intraoperative assessment. An understanding of the patient's level of anxiety and or depression is important because this can affect the performance during this, and also important to understand and know the handedness for hemispheric dominance. These are the tests that are routinely administered during the preoperative assessment. There are a wide variety of tests that are designed to assess specific cortical and subcortical functions. The procedure of awake surgery follows certain predefined paradigms. The most common procedure is what we call a sleep-wake-sleep cycle, where the patient is asleep or sedated at the initial part of the surgery. The patient is woken up once the lesion is reached and assessment is required, and at the end of the resection, the patient is put back to sleep for the closure. As opposed to this, the other process is one where the patient is continuously awake through the entire surgical procedure with a liberal use of local anesthetic agents with a little bit of sedation as may be required, especially during moments of bone drilling. The use of intravenous anesthesia in the sleep-wake-sleep paradigm is mandatory. It is optimal to use a target-controlled infusion system to obtain a very precise depth of anesthesia here. The common drugs used are propofol, dexmedetomidine, or remifentanil, as is now recommended, but unfortunately is not available within the country. A scalp block with a long-acting local anesthetic agent is mandatory, and so is a urinary catheter. The use of a nasopharyngeal airway or laryngeal mask is optional depending upon the state of the airway of the patient or the assessment of the anesthesiologist. Monitoring is important, especially BIS, SpO2 and blood pressure monitoring through the entire procedure. A typical procedure of awake craniotomy starts with the position and head fixation, which is typically done with the patient awake, so that the patient is allowed to assume a position of comfort, so that when they wake up, they are not under any kind of strain and they are able to be cooperative through the procedure when they are awake. Once this is done, the patient is sedated. The draping is important to plan the draping so that the entire face is free, using additional supports as may be required. The use of transparent drapes helps a lot. Very good scalp infiltration prior to incision. The craniotomy as needed. After the craniotomy, it is important to cover the patty, to cover the dura with cottonoids soaked with lignocaine prior to dural incision, as the dura is pain sensitive and can provoke a response. Once the dura is open, we generally withdraw the sedation and wait for the BIS to rise and keep assessing the patient for the state of wakefulness. Once the patient is awake enough to be assessed, the procedure is commenced and completed. Small additional boluses of local anesthetic may be required around the wound to deal with pain if necessary. And once the resection is complete, the sedation is restarted until the completion of the surgical procedure. The problems that can be encountered could be a restless, delirious or agitated patient as they wake up from the sedation. Some of them may be very difficult to control. So also the patient who does not wake up very well from the sedation, and these people become very, very difficult to assess through the procedure. Pain, some people do complain of pain in spite of adequate scalp blocks and may need additional boluses of analgesics. Seizures are a major problem with awake craniotomy and may occasionally necessitate a termination of the procedure. For most patients undergoing awake craniotomy, there is an additional bolus of anticonvulsant administered preoperatively, and in the event of intraoperative seizures, the best way to terminate them is to use ice-cold saline irrigation on the brain surface. During direct cortical stimulation, we usually use a corticography strip on the exposed cortex to record EEG and to look for after discharges which are indicative of probable seizures. The time of surgery is important, as some of the detailed assessments may prolong operative time, and the cooperation of the patient is inversely proportional to the time that the surgery takes. The absolute contraindications to an awake procedure are a patient who has an upper airway obstruction or any condition that precludes the safety of non-intubated sedation. So also is a patient who has severe preoperative language disorders or personality disorders identified preoperatively that will make intraoperative assessment almost impossible. A patient who preoperatively exhibits marked sedation, marked anxiety or delirium or restlessness is also not a good candidate for an awake procedure. Over the last few years, we have over 152 awake procedures. Now the number is now closer to 200, of which the majority have been gliomas, as expected. These are some examples. A young man with a dominant hemisphere insular glioma, which was completely resected, and another young girl with a non-dominant hemisphere cavernoma, which we later on discovered that on preoperative assessment that she was originally left-handed but trained to use her right hand, and we consequentially got a stimulation positive language area sites from the lips of the brain adjacent to the lesion on the right hemisphere. What is interesting is to acknowledge is the changing concept of eloquence, where we now recognize that every part of the cerebral hemisphere supports functions that are important for quality of life, and amongst these are important functions include executive functions, visuospatial function, social cognition, amongst others. And it is now increasingly recommended to use awake procedures to assess patients, even in non-dominant hemisphere lesions, to protect functions that are important for maintaining a quality of life. There are certain tests that are done preoperatively which assess these functions, these non-language and non-motor cognitive functions. However, some of these may not be administrable during surgery, and these have to be modified as required to use them during awake surgery to assess these functions. Again, important to recognize the impact of these functions on the quality of life, and these can be as significant as the problems that arise from disorders of language. It's also recognized that amongst these cognitive functions, and impairment in executive functions are amongst the most commonly encountered deficits seen on preoperative assessment in patients with hemispheric lesions. So, generally, when one does a direct electrical stimulation to identify cortical functions, a negative stimulation response for motor or language functions is considered evidence for lack of function. But this is not always true, because many of these functions that are not assessed can be represented in the areas that do not evoke a stimulation, an evident stimulation response. Now, either not recognizing these or giving them undue importance can either lead in unanticipated deficits or inadequate resection these lesions. So what is important is to develop a paradigm of a continuous real-time testing, where all these functions are assessed by repetitive tests by using different stimuli to try to identify these different functions. And these tests can be tailored to the tracts that are predicted to be involved by the lesion based on preoperative assessment. Now, this table shows you how individual tracts have specific functions that can be assessed by a series of specific tests. And all these are tests that can be administered during surgery to assess a function of these tests. The sequence of assessment that we generally follow is to start with basic cognitive functions, including language and memory. All the various tests are shown, and then go on to more adapted assessments that are based upon the deficits identified on preoperative evaluation, and then as the resection commences, to move on to tract-based assessments that identify that interrogate the function of tracts that are either at risk or in the vicinity of the area being operated. Now, this is an example. Now, this illustration shows the language tracts according to the model that is currently accepted, and the deficits that can be identified or can be elicited by stimulation or lesions at different parts along the language pathway. Now, these are very, very specific and are very reproducible. The problem here is that some of these, the standard assessments of language and motor functions, are reasonably straightforward and easy to administer. The other ones, the non-language assessment, is more difficult, especially when one tries to link it to stimulation. So trying to adapt the preoperative tests to the intraoperative use can be pretty daunting, but is possible. These are some examples of the patient's responses and the assessments and the patient's responses during awake surgery. Assessment of visuospatial function, attention, the parietal lobe functions, the line bisections, the clock drawing, all these are possible during that. And things like emotional recognition of facial expression to identify executive function and frontal lobe functions. The reading the mind in the eye test is a measure of social cognition. The Stroop test, which looks at colors and words, is a measure of inhibitory control and executive functions. The Bell test, where one identifies the bells of specific objects from this maze of different objects in this picture, is generally tests attention, visual search, visuospatial function, and so on and so forth. And this is an example of a patient who has been through this test, and this is how it is scored with the time. This is an example of using hand gestures, asking the patient to mimic hand gestures to assess especially the frontal lasallant tract and sequential motor planning. And at the end of the surgery, we always generate a report based upon the performance of the patient through this entire test, through the entire procedure, including the stimulation response, the assessment under different conditions, and the response to different tests that were administered. This is important to understand the function at this point of time, and in patients who would need to undergo repeat surgeries down the line, this assessment is extremely important to understand the function at the prior procedure. So in conclusion, an awake surgery is an important tool for lesions involving the cerebral hemispheres, permits a detailed and ongoing assessment of the functional status of the patient during surgery. The intraoperative assessment for language and motor functions are very standard and reproducible. Those for non-language functions and other cognitive functions are more complex and will need to be customized depending upon the patient's need. And preservation of functions should be attempted in all cases to improve or maintain the quality of life. Thank you very much.
So thank you very much, Professor Dilip Panikar. So we'll move on to the next talk. Next talk is by Dr. Rajkumar Deshpande, who is going to talk on techniques of ACOM aneurysm clipping for the young neurosurgeon. Saravanan, can you play Dr. Rajkumar Deshpande? Yes, thank you.
Thank you, ACNS and Dr. Balamurugan, for giving me this opportunity to present this paper on anterior communicating artery aneurysms. So the anterior communicating artery aneurysms are one of the most common aneurysms. It forms about a third of all intracranial aneurysms overall, and they represent about 40% of aneurysm-related subarachnoid hemorrhages. Now, the optimal procedural management is still being debated. Now, these aneurysms can be quite challenging due to the following reasons, where the angioarchitecture and flow dynamics can vary in each patient, the frequent anatomical variations, sometimes the deep interhemispheric location, and of course, the danger of interrupting the perforators leading to neurological deficits. So right away, let's get into imaging. In a non-contrast scan, you get the septum pellucidum hemorrhage, intrahemispheric fissure hemorrhage, intraventricular bleed, and of course, some intraparenchymal hemorrhages too. The good test to do will be a 3D CT angiogram. This is a non-invasive and quick test that can be done. You can also tell us about the aneurysm calcifications in the wall, and a 3D image, as we show subsequently, will be very useful. So the important considerations that we need to look into are the aneurysm projection, location of the neck and the dome in relation to the aneurysm, and the location of the ACOM, whether it is high or low, the height and distance from the plenum sphenoidale and the A2 fork, which we'll discuss again. This is a typical 3D angiogram. Now, in this particular paper, which was on the anterior communicating artery morphology and the risk of rupture, the authors found that the size ratio, the direction of the dome, and the fenestration are the three important factors which determined which aneurysm would tend to rupture. The size ratio is defined as the ratio between the maximum height of the aneurysm and the average diameter of all the vessels related to the aneurysm, which is a very difficult thing to do. So it is good for academic work, whereas the direction of the aneurysm is more possible to assess on a regular basis. And it sees, in this particular paper, more anteriorly located or anteriorly directed aneurysms have a higher risk of rupture. Fenestration is another factor which makes the aneurysm rupture far higher than other reasons. Angiography gives us important and crucial information about the vascular anatomy, the dynamics of flow, and the possible approach to surgery. And it's important to perform the cross compression test. So let's take this example of an AP and a left oblique projection of the aneurysm. It's very difficult to see in this particular patient. Even if you zoom that area, there are a lot of overlays of vessels, and therefore the aneurysm is there, but not very clearly defined. So in such situations, if you have a video of a 3D DSA, you can easily see the anatomical orientation of the neck when the group of vessels are actually, see here, the loop of the vessel is around this area. The two A2s are sort of combining together to form an own location. And the projection of the aneurysm is in a vascular ring. So a good video of such 3D rotational angiogram is a very useful methodology. And of course, we sometimes project it in an anatomical surgical way, where the two anterior canals are seen, the plenum sphenoidale is seen, and the distance of the aneurysm from these areas can be easily assessed. Now, the concept of A2 fork is very simple. If the two A2s are parallel or one in front of the other, if the approach is made in such a way that the distal or the opposite A2 is in front, not behind, then that's called an open fork. And an approach from the side with the A2 located posteriorly, it is called the open A2 fork. This is a slightly easier way of doing it. So if you do MRI, it's very useful in detecting the changes, ischemic changes due to vasospasm. And in giant aneurysms, it's very useful to distinguish the amount of thrombus inside the aneurysm. So in an example like this, you can make out there is a lot of thrombus inside. This is a case of multiple aneurysms with a large giant aneurysm in the ACOM area. And you can see a lot of artifacts, and you can see the flow here. Only this part of the aneurysm has flow. All this is thrombus. Now let's concentrate on some anatomical concepts. This is the picture you would like to see when you open the Sylvian fissure in a patient of ACOM. The initial picture where you see the ICA, the optic nerve. This is the right side approach, the MCA, the ACA, the lobes which are seen. This is done, all this dissection can be done without a contact. In relation to the projection of the aneurysm dome on the neck, the anterior inferior projections are much better for clipping, and therefore this is a very good anatomical orientation for surgery. Whereas the superior projection, where the A2 can hardly be seen, and the posterior projection, where you have the perforators across the dome, you require more dissection, and the exposure can be very tricky. The surgical approaches are dependent on the dominancy of the A1, how large is the intracerebral hemorrhage, and the A2 fork. The common approaches that we normally use are the pterional and the anterior intrahemispheric approach. There are other mini-open approaches the lateral, supraorbital, glabellar, and the mini-terminal. I will today talk only about the terminal approach. The positioning is in this following way. Your head is tilted about 30 to 45 degrees to the opposite side and slightly extended in such a way the malar eminence is prominent. You do the dissection with the nice subgaleal flap, and you raise it with the fat pad very clearly separated out. This is what we call as the esophageal technique. And you can see that the fat pad is seen clearly here, the deep temporal fascia, aponeurosis, the muscle, which is cut up to the bone. And you raise the skin flap, muzzle flap very nicely with hooks and stitches, and you are ready for the craniotomy. Important is to see this sliver of muzzle, which is kept there, so that when the closure happens, this is available for putting the temporalis muzzle together and reduce the chance of a temporalis muzzle wasting. And you can do a single burrow or a multiple burrow craniotomy. Once the craniotomy is done, we then nibble the terminal as much as possible with the nibbler, and then the rest is done by drilling. So here is the drilling. So you can use a diamond drill, or you can use a small-sized regular drill, and you basically flatten the whole pterion in such a way that you have in this post-op CT, you can see the amount of drilling compared to the opposite side, almost up to half to 3/4 of the greater wing of the sphenoid is drilled. This much of the bone has to be drilled, so you get a completely flatter approach. This distance is minimized. So once that is done, you open the dura, and then start the surgery. So let's take the case of this 54-year-old lady who had come with a typical subarachnoid hemorrhage, and then she presented some 2 weeks after the hemorrhage. We have this 3D angio. The angiogram was done. You can see the aneurysm very clearly, and we'll start with the dural opening. So once the dural opening is started, we make sure that it is hitched up properly. I like to make this additional T incision so that the whole of the frontal and the temporal lobe that is exposed much clearly. You can use a needle to open the cilium fissure arachnoid initially. It's a very nice and gentle process. You separate the arachnoid either sharply. If there's a small bleeding, like the small capillary or a vein, you don't have to coagulate it. Keep a cotton for a while. It generally stops. All the veins are preserved. We don't cut any vein. And then you go deeper into the cilium fissure and separate the arachnoid sharply. Sharp dissection is preferable than pulling the vessels. Yeah, it's a combination of dissection very gently, patiently, very clearly, and making sure that all the vessels are separated. Use patties to hold the brain and away. And as you can see, all this dissection is done without the use of a retractor. So as we come to the medial end of the cilium fissure, you'll see the optico-carotid complex. The ICA is seen very nicely. The bifurcation is seen. And then all the arachnoid strands are very nicely separated and cut. You can see here very clearly the third nerve in that area, the optic nerve, the ICA, and you identify the chiasm ipsilaterally first, and then you go into the interoptic space, cut the arachnoid, and you can see the opposite optic nerve and the opposite A1 as it comes into view. So once we reach this stage where you're seeing the opposite A1, then it's time to hold the brain back if it is not possible to do without the retractor, please put a retractor, but it's not with pulling, it is just to keep it in place. Then you do a gyrus rectus resection, about a centimeter maximum. And then when you're doing the gyrus rectus resection, all the arterial branches from the A1, A2 junction, and the A2s are preserved. This gives us the exposure of the ipsilateral A2, and see if you can get exposure of the contralateral A2 if possible. Then we put a temporary clip on the opposite A1 and then ipsilateral A1. So once the temporary clips are applied, you have the freedom to then dissect around the aneurysm. In this case, the aneurysm is posterior and somewhat superior. So you look for the gap between the A2 and the aneurysm. You can just make sufficient space to see the opposite A2. So you know the location of the opposite A2. Make space for it under the ipsilateral A2, like that, you can see, and see if there are any perforators there. Small perforators are sometimes difficult to see, but every attempt must be made to separate the perforator like that. You see the perforators attached there, and that is pushed away. So once the perforators are pushed away, you can see the neck of the aneurysm. In this case, the neck involved the origin of the A2. You see the neck is involved in the origin of the A2. There is no separate part. So it is not possible in such situations to clip the aneurysm with a single clip. So we make an attempt to clip with the first clip being put across. It's a ring clip. The ring encloses the part of the neck of the aneurysm which is still open, but you want to make sure that the opposite A2 is paired, and you make the clip in such a way that most of the aneurysm is clipped. It's not a complete clipping procedure still. It is to make sure that what we want to see is most of the aneurysm is enclosed or separated and clipped by the first clip. We are doing the ICG here, you can see, and we dissect around that area to see that all that is well. Now, the temporary clips have been removed, and therefore we have sufficient space here now after dissection to put an additional clip. So the clip is placed in such a way that the opposite A2 here is not included. You see there's a nice space there. You dissect that area and you make sure that the ICG repeat shows that the whole aneurysm is excluded. The ipsilateral and the contralateral A2 are nicely seen. You just saw there the ipsilateral A2 and the contralateral A2 have been spared. The post-op scan looks pretty good. The patient had no deficits. So basically, you have some surgical blind spots based on the dome projection. If it's an anterior and an inferiorly projecting dome, you will have difficulty in the contralateral A1. If it is a superior and a posterior, it hides the contralateral A2 and the ACOM perforators. So there are certain modalities that are present to check the patency of the vessel after clipping. One is ICG, which we just saw. Instead of ICG, you can use a much economical solution, which is fluorescein, and you can use a Doppler, micro Doppler. And you can take the assistance of the endoscope to visualize the corners, which are very difficult, and sometimes you have to retract the brain more. You can use an endoscope to see those corners. We use MEP monitoring during surgery. Let's take another case of subarachnoid hemorrhage, typical subarachnoid hemorrhage for ACOM. You can see the aneurysm there in the CT angio. In this projection, it's very interesting to watch. And the reason is the opposite A2, if this is the approach we're doing, ipsilateral, contralateral, the contralateral A2 comes back into it. So you have a bunch of vessels here. If you're using this approach in this direction, you'll realize that you have a bunch of vessels, and these vessels have to be dissected very clearly, and this clipping has to be done in such a way that the flow for both A2s are not obstructed. And you can see this anatomical, surgical anatomical orientation where the anterior clarinets are here and here. This is the plenum sphenoidale, you know the distance, and it can be very nicely appreciated here. We did an angiogram in this patient, but unfortunately there is a suspicion here, and beyond that, the angiogram did not prove any benefit except the left metavertical where you saw this aneurysm projection. In all the other areas, angiograms didn't prove any additional benefit to us. So let's proceed in this dissection. We have done the ciliary fissure dissection. We are dissecting the gyrus rectus. Partly has been done here. We are now seeing the aneurysm here in this location. This is the aneurysm. This is the A1, the A2, and you can see one big branch of A2 there. The contralateral A2 is coming here. Again, we are using a ring clip here. Now, we had some difficulty here. The difficulty was as I was releasing the clip, this clip applicator would somehow make the clip slip back and include the ipsilateral A2 like that. This happened once. This was a sort of a trial clip. So I was wondering whether this clip length was longer. But when I actually checked it subsequently, I realized that possibly it is a correct size clip, but still the clip tip should go right across the base of the aneurysm, not include the opposite. This is the opposite A2, not include the opposite A2. And I tried to release it. I mean, I still had this jumping. So probably it required a little more dissection. So we did a little more dissection and made sure there are no perforators anywhere. And then we applied the clip nicely in such a way that the opposite A2, which is going here and coming, looping back, ipsilateral A2, all are nicely preserved. So this is important to realize that, sometimes the clip tends to slip in the narrow space, and it may require multiple attempts to make sure that the vessels are not caught and the ostia are not narrowed. So ICG was done, and you can see very clearly that the contralateral A2 and the ipsilateral A2 are very close to each other. As we saw in the CT angio, the opposite A2 is nicely seen, the flow is very good. So indicating that the clip tip has not included, and this is the aneurysm. You can see the aneurysm completely, the whole thing is the aneurysm, and the aneurysm is completely excluded, which is not seen in the ICG here on the left side of the image. So that was a very successful clipping. Post-op CT didn't show any ischemia. Patient had no deficit. So during surgery, you have to release a lot of CSF to make the temporal and frontal lobes go separate. So wide dissection of the ciliary fissure is a good way to do that. In certain aneurysms where the projection of the ACOM is downward, you may have to go laterally and open the Lillquist membrane rather than trying to dissect on the opposite side, which may result in a greater chance of rupture. And the lamina terminalis is opened in almost all cases so that the third ventricular CSF is let out. So lamina terminalis is something which we open regularly. So you can have complications, due to electrolyte imbalances or vasospasm, perforator injuries, etc. So you should be very cautious about that. In general, for TRNL approach, you'll have temporal muscle atrophy that can happen. So be careful the way it is dissected. The facial nerve branches, should be very nicely preserved using the esophageal technique. The STA injury should be avoided, and make sure that the bone is applied and plated properly so the cosmetic deformity is reduced. So what are the general reasons for occlusion of perforators? and there are 4 common reasons. One is inadequate knowledge of the anatomy of that location, inadequate preoperative imaging and appreciation of the 3D angio architecture, inadequate dissection so that that whole area is to be nicely dissected. And if you're inexperienced, if you're a little anxious, the clipping is performed hurriedly, and therefore your clip will include the perforator. So enough time must be taken using temporary clipping if necessary to dissect all the perforators away from the site. Thank you for your attention.
I don't think that's yes. Thank you, Professor Rajkumar Deshpande. Now we will move ahead with the next talk, and towards the end of this session, we'll have a discussion. So the next talk is by Professor Suchanda Bhattacharjee. Saravanan, can you please load the?
Respected ladies and gentlemen, I take this opportunity to thank Professor Balamurgan and Professor Fatman, administration always promised, and the members of the scientific committee for giving me this opportunity to speak in the Asian Congress of Neurological Surgeon International Conference, the first virtual one. And I am supposed to speak on epilepsy surgery for the young neurosurgeon. So epilepsy surgery could be temporal or extratemporal. Basically, the anatomy of the substrates remain lesional and non in both the categories. And this is an example of hippocampal sclerosis, and which is shown on the, also on the flare sequence. And these are the various examples where a temporal lobe epilepsy refractory can happen, where you perform surgery. So these are the various approaches, but the most commonly performed is temporal lobe resection, a standard one, and the hemispherectomy. So I will be demonstrating these two surgeries. And hemispherectomy, I will show the vertical one, the Delilah approach, which I perform. Many people do lateral as well. Epilepsy surgery protocol is clinical examination, video EEG, MRI in epilepsy protocol, and optional women's static functional MRI, DPI work at some time. And the most important is concordance between video EEG, immunology, and craniology, and of course the mandatory discussion agreement in epilepsy surgery is institutional meeting. So the alphabetical more or less is epilepsy. It becomes refractory. You do a physical evaluation, you do video imaging, then it is either a temporal or an extratemporal or generalized epilepsy. So this is the most commonly performed surgery, as I told you. And what we do is we remove the anterior part of the temporal lobe and the hippocampus. This is the medial view. For orientation, this is the lateral view, superior, middle, inferior, and this is the medial view of the temporal lobe. So the position remains supine with the head fixed on nasal or fujita, whatever you use. A gel roll is kept on the lateral shoulder to raise it. The head is extended slightly and rotated on 30 to 45 degrees so that the hippocampus falls in line of your vision and the neck is slightly extended by lowering the cursor. And so the right one remains the highest point. And then the craniotomy is done centered over the sphenoid ridge. The temporal is more and frontal little bit of the frontal bone. Once you do that, the exposure remains from William tissue up to the temporal bone, lateral part of the temporal bone. And then you do the temporal lobectomy, as I told you, 3 centimeter in the dominant side, 4 centimeters on the non-dominant side. And it is mastoid. And once you do the temporal lobectomy, this is the anatomical structures you see. This is the choroid plexus, this is the hippocampus, this is the choroidal, the anterior tip of the choroid plexus, this will be the uncus, and here will be lying the uncus along with the amygdala, and this is the hippocampus, and this is the fimea. So once everything is removed, the hippocampus looks like a loud block tissue like this, medially by the choroid plexus, laterally by the collateral surface, and it sits on the hippocampus. As I told you, what are the things removed this? Anterior 2/3 of the hippocampus, lateral 2/3 of amygdala, perihippocampus, and the uncus. So I'll explain through this phase of a typical complex special seizure due to a hippocampal sclerosis. And this is the image which I've also shared before. And this is the position, and this is how we raise the skin flat, and then this is the view after the craniotomy, the dura mater, and then these are the steps: temporal lobectomy, identifying temporal horn, removing amygdala, hippocampus, uncus, mobilization of the hippocampus, coagulating hippocampal artery, removal of hippocampus, and then hemostasis and de-escalation. So this is a video of a classical. I'll just show you this small video of how you do a temporal lobe. This opening the dura and then the temporal lobe. You can see I marked it with a bipolar, with a monopolar, and 3 centimeters from the pole. How do you mark it? You take a brain cannula or a scale and along the middle temporal gyrus, mark it on 3 centimeters. Remove it. Then once you remove, you should have this image in your mind. The medially remains corax plexus, laterally the collateral sulcus and the parahippocampal gyrus. This is the 10th here. This is the sylvian tissue, coronary tissue, temporal gyrus. This is the floor or the cavity of the temporal horn. This is the merger of temporal lobectomy. The green one is the hemispheral image which falls over the hippocampal. At just a schematic orientation for your understanding. So once that is done, the next step is step by step, which is first step is temporal lobectomy. As I told you about temporal lobectomy, you first mark the temporal lobectomy, how much you do. The nuance in this are that there may be a lot of veins which may communicate with vascular, so you have to coagulate them and cut it. The veins may be separating along the polar region, along with the tent or the dura mater, and in order to keep it non-messy, you should first cut it, seeing them visually. Many times big veins remain and you might have to sacrifice, but you should be sure that you never sacrifice the vein of labia, otherwise you can do a disastrous infarction later as a complication. So always remain entry to the vein of labia. You usually remain, but sometimes abnormally the vein of labia may be entry. So you have to take care of that part. And then you don't remove the superior gyrus. If at all, the pattern of ECOG suggests the temporal is breaking the venom living, especially on the left side. You should not. Once you do this temporal lobectomy, your next step is identifying the temporal horn. You identify the temporal horn, you will see the corax plexus and the CSF sticking out. You touch them with the cottonoid. Sometimes here you have to be careful that you might be too medial enough in the sylvian system, then also CSF will come out. So you have to see the corax plexus. Once you see the corax plexus, you expand to the opening of the temporal horn. You go posteriorly as well as anteriorly, so that maximum extent of the hippocampus in the formative temporal lobectomy boundary of the hippocampus is exposed. Here you can see that here this is the corax plexus which you will access. Okay, so once that is exposed, then you do mobilization of the hippocampus. You follow a particular pattern, it becomes easy. First, you do the lateral wall mobilization, remove all the tissues, which includes from the parietal sulcus laterally. This includes parahippocampal gyrus as well as part of the inferior temporal temporal gyrus. And really, with the help of a suction, we use some people use clipper, but I feel suction is a controlled way of removing the tissues. After that, you focus your attention on the medial side and remove the amygdala and the answers in a similar way as you did for the lateral side, taking bit by bit, suctioning the tissue out. It may take some time. The patient is of utmost importance in this surgery because you are not allowed to damage the flea. If you damage the flea, you can have the potential risk of injuring many of the vessels. Once that is done, you will find the fimea which lies on the lateral border of the corax plexus, that is at the parietal fissure. That is a very thin tissue and it easily gets built off like that with a hook or the spine microdissector. Once we do that, the medial side gets isolated, the lateral and then you roll from anterior to posterior. Again, you remain subclavially using the suction and the dissector as your tool. Some people even use some cotton as a tool for rolling it, but at some point you'll find some scattering. This scattering is because of the arteries which supply it. These arteries are the hippocampal arteries, which come directly from the posterior cerebral artery and their end artery. So you have to be very careful. You have to identify the tiny ones. You may use your microscope to identify them and cut it after coagulating near the hippocampus rather than near the flea, because if it fails and retracts, you may go on tracing it and you may put a rent in the PCA. So that could be a dangerous complication because you are working with depth of 5 to 6 centimeters and then it becomes very difficult to control bleeding. in that area. So to avoid that, we should take each one by one with a lot of patience and cut it at the body of the hippocampus. So once we do that, we will find that the hippocampus is free, and now the only tethering element remains the posterior part and in posterior part, and the fire should not be disrupted until in again because until the fire remains alternated vessels. So next the posterior disconnection is done. You can just do with suction and the narcosis. Sometimes you might have to give one or two shots of the coagulation if it is very high. Once you do it, the hippocampus is completely separated from outside and it will get delivered with the tumor process like a baby. Why also the fire needs to be removed? Because there are three important areas in this surgery, so we should remember that the it can cause potential a lot of vascular injury. The first is when you are removing the ankle, the fire underneath lies the MCO. Then while you are removing the amygdala and answer again the encephalorhodina, there is tiny arteries and you can damage when the fire is. And then of course it is rolling out the hippocampus, but it remains towards the whole course underneath. So after that you can see the like this, the whole fire is intact. You give a good wash and then close the door. If you require some hemostasis, you can do, but usually a good wash suffices for the hemostasis. After that, once you are done with that, that should be the floor, how it looks, the PCA, the fire, and here somewhere here you should be able to see the third nerve and this is the rest. So the hippocampus should come out in a total like this, otherwise the pathologist is reality because to make a diagnosis of muscle central sclerosis, they need the whole of hippocampus. Once that is done, this is how the post-mortem image looks. So with the excision part and the remaining temporal guidance. Next surgery is hemispherotomy. Hemispherotomy is done in generalized epilepsy involving one of the folks. And again, through a case I'll explain, this is a 19-year-old girl, one of her disease consanguinity, and 3 years she had encephalitis following which she developed hemiplegia. And there was later she also developed dystonic posture. This is the girl. She already had damage in her hemiparesis. And so what is the steps of surgery? Corticectomy, middle disconnection, anterior disconnection, lateral disconnection, posterior disconnection. So this is the position supine is quite flat, just like it is for coronal suture and 10 centimeter length incision using centering of our coronal suture. After that you get the incision and then you do the sternotomy and like this and that. This is, I will explain through this. This is the axial and this is the sagittal. Here remove the cut and go inside the cavity of the lateral ventricle. Then remove the medial cut on the corpus callosum also. In the frontal base cut, the lateral cut and the posterior cut along the base of the atrium. On the sagittal, on the temporal side, on the frontal side, anatomically like this we go also. This is the cut, this is the cut, this is the cut. So let me explain you through this video of this particular girl. There is the anterior side, lateral side, the medial side, with the flap and dura to the flap vertical sinus. You do the corticectomy. You can do in the interhemispheric fascia or you do in the junction between the middle frontal gyrus and the sagittal frontal and the occipital frontal gyrus. Why you choose this area? Because it has the watershed region between the blood supply and CA and the ACA, so the chances of infarction are low. You have to go straight into the cavity of the lateral. Usually the ventricles are very enlarged because of the atrophy and it becomes easy. But sometimes in certain special situations like hemimetal and capillary, it may be very difficult. The tissue bulk may be so high, it may be very difficult. And in such a case, you can do a little bit of the frontal lobectomy to gain access to the lateral ventricle. These are roughly around 4 to 6 to 7 centimeters of the depth from the surface of the cortex. Once you enter in, the next step remains identifying the corpus callosum. This is the corpus callosum. You see, in the septum is from corpus callosum. Here from inside out we are saying, so corpus callosum is like this from the septum to the corpus callosum. Once you remove it, you will find the callosal sphere of the callosal system or the gray matter of the cingulatus. Remember, when you come from the interhemispheric side, after the corpus callosum, you see the intracerebral artery in the callosal system. But here you are coming from inside out, so you may see it if you're quite medial, or you see the gyrus of the cingulate gyrus gray matter. So you do this from anterior to posterior in the whole length. You can start anywhere, wherever you find the corpus callosum. While that system goes on retracting for you, and you take it out slowly with the help of the suction, controlled suction and coagulation. And once you finish that, next you do the frontal system. So how you do that? Again, you follow the ACA and go laterally as the ACA courses, but many times the Acns is not very clear. You might not be able to use ACA alignment. In such a case, you should keep in mind that you remain 1.5 to 2 centimeter anterior to the foramen of Monroe, otherwise you may have the potential of damaging the caudate nucleus on the lateral wall of the frontal horn. So that way you go laterally right up to the Sylvian system as much as possible. Once I reach the lateral most extent, I put a fastener there so that when I come from on the lateral side, I am able to see this through the ear. So that is what I did. Once you do that, the anterior connection is complete, and then you change your microscope and focus posteriorly in the atrium. Here, from here, the thorax plexus remains as I did. So here I am removing a little bit of the remaining corpus callosum, and then I will follow this corpus sequence with a V shape which goes inside the temple horn. It is very sharply see it goes into the temporal horn. So you have to follow that and remain lateral to the thorax plexus. Like this. See, if you are now, you can see that this is going laterally inside the temporal horn. So I follow this laterally and going and cut all through and reach the almost near the temporal hole area, but remaining, keeping the spear intact, go in. And once I reach there, I might be able to, most of the time you are able to see the partner through the spear method, and then cut it up. This is very difficult. The system goes on extracting the tissue and do it. And once you finish that, then you do the posterior cut. You remain lateral to the atrium, lateral to this V. You remain posterior to this V, and you cut from the cranium right up to this lateral cut along the floor of the cavity of the occipital horn and it appears to be mixed because underneath the next vector brainstem. So once that is done, what remains last is the horn is very easy to connect. It's just lateral to it. You just peel off the tissue, and below is the entire roof of the third ventricle. Okay, this is the horn and this is the septum. So this horn is the outflow hippocampus, so it is easily done here, or you can even cut the hippocampus ratio. So once that is done, this is again this is the last foramen of Monroe with the beautiful thorax plexus coming and going with the lateral. So with this complete plus surgery for you can keep in train, which I usually take for 48 hours, but a good wash gives all the hemostasis. So this is the poster scan on subdural hematoma that the symptom is also, and these are the cuts which you can see the stomach 3 months post surgery. So this is the girl post surgery after 6 months. And I don't know, the video is not working, but she did not have any additional surgery. So what are the complications? The complications in medical complications are minor and measuring 1.5% urologically. That is extremely rare in any of the surgery of chemotherapy offering only 0.4% of cancer on controversial cancer surgery. These are the outcomes, you can say very good outcomes. And like top of the complications for specific central surgery in visual deficit, that is the pile in the sky, and infection or stroke or manipulation or retraction hemiparesis, which is transient, certain portion of potential, language disturbance, moderated is less than 0.5%. This is an example of cortical sinus and external system in the first case, and this is my only single case who has landed up in hemiplegia because of later while giving the video I've seen that probably interparietal artery was and hysterotomy, significant hemiparesis, vertical dexterity, monocytes, complete partial deposit, hydrocephalus, meningitis, blood loss, hypovolemic, everything that happens. contains hemisphere complications. For some examples, subdural hematoma, between cortical sinus and thrombosis, or respective subdural hematoma requiring some intervention. Positive ideas with this positive complication, such as cosmetic measures, especially in children, and decrease in hyperactive and aggressive behavior in case of children with schizophrenia. The 57-year-old was showing fevers at every 5 minutes on multiple anti-epileptic drugs. He had congenital malformation of the brain, and this was always CP because of the drug. And this is a child who is not only schizophrenic for now 5 years, but is also doing very well in school. And so I always show this picture whenever I get an opportunity to speak on epilepsy surgery. So epilepsy surgery is safe. Measure risk start visit is less than 1% experience centers. Long-term severe remission after surgery is more than 60%. I'm talking about 18 to 20 years post-surgery data. Good evidence that epilepsy surgery is significantly more efficacious than medication. In conclusion, complications are not life-threatening. Learning curve is required. Surgical techniques respect the clear mirror. Stage selection is of utmost importance for good treatment. And as I said, thank you for everything, and we need a good team. And this is my team where we work together, electrologist, radiologist, neuropsychologist, and nuclear physician. Thank you very much.
Thank you very much for the wonderful talk, Dr. Suchanda Bhattacharjee. In the lack of time, we'll move ahead with the next talk. Next speaker is Professor Kuntal Kantidas, and he's a professor at SGPGI Lucknow. He'll be talking on perisylvian glioma operating techniques for young neurosurgeons, tips for young neurosurgeons. So, Mr. Saravanan, can you play his video, please?
Good morning, everyone. First of all, I'd like to thank the organizers of this meeting for giving me this opportunity to present my work here. And today I'm going to talk about surgery for insular gliomas in the bread and butter session. Insular gliomas are one of the common neurosurgical problems, and sometimes they would present with a tumor inside the insula, or sometimes they will have extension to the surrounding operculum and the adjoining areas. Sometimes they would present on the dominant side, and sometimes on the non-dominant side. And these various extensions and locations have surgical implications. The indications of surgical resection in insular glioma are same as gliomas elsewhere in the brain, and these include control of the symptoms, that is, control of mass effect and seizures, obtaining tissue for histological diagnosis and a complete molecular characterization, the oncological parameters, improvement in oncological parameters like improvement in overall survival, progression-free survival, and malignant progression-free survival, and by dint of improvement in the symptoms, particularly seizures, to cause improvement in quality of life. The insular glioma patients are typically investigated with the help of a high-quality MRI, wherein various sequences like T1, T2, T2 flare, and contrast-enhanced images are obtained. And sometimes special sequences like functional MRI and DTA are obtained, particularly to look for eloquent functional cortical and subcortical structures around these tumors, which can be at risk during surgery. And some studies have shown that the lenticular striate artery perforators can be imaged very well using a high Tesla time-of-flight 3D angiogram, and wherever possible should be done. Preoperative neuropsychology, whenever possible, is recommended because many of the low-grade glioma patients will have handicap of the neuropsychology. And if the patients had presented with intractable seizures, then preoperative video EEG would be essential. Now, there have been numerous papers which have shown that certain imaging parameters are a potent, dangerous, or rather a risky situation in the resection of insular gliomas. And these include an irregular tumor border, particularly on the medial side, enhancement inside the tumor, that is high-grade lesions, then encasement of the lenticular striate artery, and involvement of the superior insular sulcus. So if these are present, then they indicate that radical resection will probably be not possible, and the chances of complication would be higher. The positioning is typically a supine position with the torso elevated above the level of the heart, and the head is typically positioned in either of the two ways. A 45-degree rotation allows opening of the sylvian fissure if one is approaching through a transsylvian route, whereas a 90-degree rotation allows one to use a transcortical corridor, particularly from the temporal side. And more importantly, it allows the irrigation cavity, the cavity to be irrigated with saline and keep the water level steady for a transcortical or a transcavitary ultrasound if it is being planned. The incision is typically a large frontotemporal incision, and here the idea is to expose not only the area of the tumor but also the surrounding areas for this intraoperative monitorings to come into play and to utilize the ultrasound probe. And head can be rotated if your frame allows you to, and flexion and extension of the neck can be done to access the deeper located portions of the tumor. Now, to give an overview of the technical subtleties of these tumors, I'd like to present two cases here. Case number one is a 22-year-old female who was a right-handed college-going girl. She presented with partial motor seizures of 6 months duration. And on MRI, there was a left-sided insular glioma, and the glioma had expanded the insula and was encroaching into the surrounded operculum, but this encroachment was quite minimal. The tumor border were, however, clearly demarcated, and most of this tumor was located above the sylvian fissure. Now, ideally, this patient should have undergone an awake craniotomy, and we also planned so, but the patient was found unsuitable during our pre-anesthesia checkup, and eventually we had to go for a general anesthesia excision. And we decided to go for trans-sylvian approach, primarily with the concept in mind that the trans-sylvian corridor provides a natural access to these tumors, and the operculum would not be endangered because we did not have the patient in awake condition during surgery. The monitorings that we decided to go for were intraoperative ultrasound and cortical subcortical mapping. This patient was operated using a trans-sylvian route, and we began with a limited opening of the sylvian fissure in the most prominent part. The opening was increased, and it was deepened in the small portion to get an inside-out opening of the sylvian fissure as taught by Yassergel. Thereafter, the middle portion of the sylvian fissure was opened in order to visualize the proximal part of MCA. The MCA was traced, and as you can see, the apex of the insula was bulbous because of this tumor. The MCA was traced in the inferior insular sulcus, which is easier to open. And this gives us the base of the sulcus, which is a very important surgical landmark. Any prominent vessel should be preserved using meticulous microsurgical techniques. And once exposure is done, the tumor decompression started. Here we started in the apex of the insula, and the decompression was continued. And as you can see, as decompression is going on, the corridor is enlarging. Then transcortical ultrasound here tells us where to go. Therefore, we resected the orbitofrontal portion of the tumor. Thereafter, the remaining portion in the posterior superior part was removed with the help of ultrasonic aspirator and bipolar coagulation. Thereafter, we went to the posterior part. The tumor was internally debulked. And it is very important to remain subpal. Otherwise, the cortical vessels, here you can see the MCA on the cortex, on the pia. So remaining subpal helps in their preservation. Then the base of the surgical cavity was inspected. And here you'll find that there is a granular appearance of the striatum, the typical nutmeg appearance. This is the medial limit of the tumor resection. And one has to be really careful not to go deeper than this. Thereafter, the anterior superior quadrant or zone 1 was visualized and tumor was decompressed. The very idea is to have a flat tumor base. The tumor should be resected in the same plane. And as you can see, as the tumor is decompressed, the sulci, they come into the picture really well. Subpal resection of the residual tumor is being carried out with utmost care. And any remaining tumor fragments are removed with a low setting ultrasonic aspirator. Then a transcavitary ultrasound is done to see if there is any residual tumor remaining. Now here there is an important thing, subcortical mapping of corona radiata in the posterior superior part or the zone 2. Any residual tumor in the temporopolar area is opened through a temporal corticectomy and removed. And once the surgical excision is complete, the MCA is inspected and papaverine is applied directly on the vessels. An ultrasound is done to see if there is any residual tumor. Postoperatively, this patient developed subtle weakness on the right side, which recovered at the end of 7 days. Histologically, she had a grade 2 diffuse astrocytoma, which was IDH mutant. Post-op scan showed a complete tumor excision, and we have decided to follow up the patient, and her seizures have improved. Now, the second patient is a 38-year-old male who was a right-handed gentleman who presented with complex partial seizures of 1 year duration. On examination, he had a right ptosis. And compared to the previous patient, this patient had a bulkier tumor and the tumor margin was irregular. Moreover, it was encroaching into the region of the uncus and was causing uncal herniation. And we can see some blood vessels inside the tumor mass, and the middle part of the tumor was enhancing. And there was a lot of mass effect. So considering all these findings, we decided to go ahead with transcortical approach, which would otherwise give us a wider exposure. And we decided to use sodium fluorescent guidance resection to target this enhancing area. In addition, we used intraoperative ultrasound and motor mapping. In this patient also, we went ahead with frontotemporal craniotomy. Here the Sylvian fissure is effaced, as you can see. So we started with limited Sylvian fissure opening, and we found that the tumor was occupying this area just beneath the pia here. So it was having an exophytic component. So after a limited decompression, what we saw was the middle cerebral artery running on the MCA, on the insula. Thereafter, the temporal polar portion of the tumor was decompressed. As you can see, it was infiltrated by tumor. And on fluorescence, the high-grade area were very clearly seen, ultrasonic aspirator. Once it was done, the insula proper was exposed, and the bulging insula corticectomy was performed. And the tumor from within was decompressed with the help of suction and ultrasonic aspirator. This emulsification technique is really useful in low-grade glioma surgery, and the tumor is sequentially decompressed, and multiple corridors on either side of the MCA is created to decompress these tumors. And a subcortical stimulation is necessary to know how far is the subcortical tract. And once the tumor is decompressed, you can beautifully see the borders. Here you can see the superinsular sulcus. This is a very important landmark because you need to be really careful in the portion just above it, which contains corona radiata. The remaining portion of the tumor is gradually decompressed. And the resection plane has to be flat. Here we can see the posterior insular point is seen where, this is a very important landmark, and your resection has to remain above this plane. Otherwise, you can enter the deeper structures. With the help of ultrasonic aspirator, it was removed. Then papaverine was applied on the middle cerebral artery vessel. And here we could see that some tumor was infiltrating in the orbitofrontal area, which was decompressed, and it was also involving the olfactory nerve, the optic nerve, and the area between the IC and the optic nerve. So this part was decompressed carefully, not to injure the internal carotid artery that is lying just beneath. Here you can see the internal carotid artery and its bifurcation. Thereafter, the portion of the tumor in the lower part of the insula going to the frontal lobe was decompressed carefully, not to injure the underlying lenticulostriate artery perforators. Ultrasonic aspirator is a very handy tool here. Then likewise, subcortical monopolar stimulation is done to know the position of the corticospinal tract. Now, a transcortical ultrasound here told us that there was some amount of tumor which could still be removed, and it was removed. And finally, we diverted our attention to the portion that was going below the tent. The tent was opened, and you can see the third cranial nerve was closely attached to the tumor, and it was carefully dissected. And we realized that this tumor could be adherent to the perforators here. So we plan to only decompress this portion and leave some portion behind. So this was the view after resection of the tumor. Papaverine was applied, and the tentorium was opened further to make space for the residual tumor. Postoperatively, as you can see, some residual tumor was still there in the region of the tentorial incisura, but rest of the tumor was removed. The patient remained intact neurologically. Histology revealed a diagnosis of anaplastic astrocytoma IDH negative. So he received adjuvant chemoradiation as per protocol. His seizures reduced, but he was still on AED, and unfortunately he expired because of disease progression after 15 months. So insular glioma surgery, while it looks elegant and easy, is fraught with complications, and the complications are mainly in two categories. One is vascular injury, and the second is neural injury. Vascular injury can happen to the MCA trunk, although it is very rare. It can occur because of the long insular perforators, or more commonly it occurs because of lenticulostriate artery perforators. These LSA perforators, they are very difficult to visualize once you are inside the parenchyma. So the best way to visualize them is extraparally locate them. and remaining lateral to the plane, as you can see on the picture here. This black line shows the base of the sulci and the lateralmost lenticular striate artery. So if you are lateral to this plane, then you are likely to preserve them. And if you want to go any further than this, then you need to use intraoperative adjuncts. Moreover, application of papaverine over the exposed vessels have been found to be really useful. Neural injury usually takes place because of opercular retraction. So retraction has to be dynamic and it cannot be constant retraction. Subcortical mapping will help in preservation of the subcortical white matter. And language tracts can only be preserved if you are operating under awake conditions. And sometimes the insula, particularly the posterior part of the insula, may have some language function. So it can only be found out during an awake craniotomy. So whenever possible, awake craniotomy is the best option, but whenever it is not, then monitoring with GA can also be done. So the take-home message is the key to success to these tumors is the sound anatomical and functional knowledge, thorough evaluation of the preoperative radiology, particularly the danger marks that I have mentioned, tumor border, enhancement, etc., meticulous surgical technique, and supplementing this with the available intraoperative adjuncts that are at our disposal should be done. And all this will ensure that this bread and butter surgery does not become a bad and bitter experience. I thank you, the organizers. Thank you.
Thank you very much, Professor Kuntal Kantidas. That was an excellent lecture and demonstration of the surgery. I think we are overshooting the time, so we'll make a small change. We'll not have a discussion session right now. We'll go with the next session now, that is complications of neurosurgery, for how to handle it for the young neurosurgeon. That is just 3 talks, and towards the end of that session, we'll club the discussion of this session. So I request all the faculties to stay with us for next 3 talks, and then we'll have a discussion following that, because 3 o'clock we're having our inauguration session. We have to stay with that. So we'll go ahead with the next session, that is the complications of neurosurgery. And our first speaker is Dr. Rupesh Kumar, and he'll be talking on complications of neurosurgery, how to repair the dural sinus injury, tips for the young neurosurgeons. Thank you. Saravanan, can you load? Yes.
Good morning, everybody. So, at the outset, I thank the Acns organizers for giving me an opportunity to talk on this August session, especially for a pre-conference workshop. And I'm going to speak to you upon a very practical yet very important topic on how to deal and how to manage the dural sinus injuries. This is one of the common problems which we face day-to-day in our regular neurosurgical practice, and one should be very, very aware and should be able to handle these type of complications till you get somebody's help, if at all you have a significant problem. So myself, Dr. Rupesh Kumar, I'm the Senior Consultant Neurosurgeon from Apollo Proton Cancer Center, Chennai. So dural sinus injuries, they are basically 2 groups. One is a trauma, and other is iatrogenic, what we do during our surgical maneuvers. The iatrogenic injuries are especially happens whenever we operate or do a craniotomy close to the sinus, something like a parasagittal or interhemispheric approach. Generally, we expose the sinus to go into the fissure. That is when we see, or exposing a CP angle tumor, where we regularly expose the margin of the transverse sinus, sigmoid sinus, to have a proper exposure. So these are the 2 common problems, common procedures where we encounter these type of injuries. The other important area where we get these type of injuries are whenever we resect a parasagittal meningioma or anywhere meningioma which are close to the dural sinuses. So we'll see upon how to deal with these type of problems when we come across in our life. So whenever there is a coagulation or any bleeding, the coagulation cascade comes into the view. So as soon as we have any vessel injury, the first thing will be a vasoconstriction, then the platelets will form, then the fibrin clot, and finally fibrillosis. This is a regular coagulation cascade. But what happens in sinus is that the dural sinuses do not have a proper muscle layer. So they are just the dural sleeves, So they cannot contract, so they cannot have spasm. So it will bleed like horrendous. So this we should be able to understand, conceptualize, so that we understand and manage this issue. So these are some of the one of the emergency things which you come across, if not very commonly, but at least you'll have. So you can see that there is a large midline depressed fracture. So this is exactly over the superior sagittal sinus. So whenever one needs to, and there's a large extradural hematoma, possibly from a tear in the superior sagittal sinus. So this is one of the very important thing which we should be handled. So whenever you encounter, especially if you're very much junior, you need to have somebody's help before you contemplate on this issue, because sometimes the bleeding may be so horrendous that you will lose the patient on table. So we should be very, very careful whenever we elevate this fracture, and we should be mentally and prepared, and our whole operating team, not only the surgeon, the anesthetists, the sisters, everybody should be prepared to handle this problem whenever you encounter in your emergency OR. So what are the simple steps we would do? So the first and foremost thing is, whenever you get a sinus bleed, try to elevate the head so that the venous sinus pressure comes down. At the same time, you should avoid ARM parts. Never ever try to coagulate, because the more you coagulate, the dura will shrink and the bleeding will become more. So never try to coagulate. And the first thing is, you should identify where it is bleeding. It is a single rent, is it from the sinus, or it is from the bone, or if at all, where exactly it is bleeding, so that you can pack sufficiently, not so much so that the whole thing gets lifted out. And whenever, if you can arrest the bleeding with a firm pressure with a patty, then you know that that is the point where it bleeds. So you can get ready as gel foam and a Surgicel, you can wrap around it and then keep it exactly on the end, put a patty, keep it firmly on some time, usually the bleeding stops. And once it is stopped, and before you close, you check with Valsalva so that it doesn't blow up again and cause a post-operative extradural hematoma. So this is how you manage, and whenever you are elevating the depressed fracture over the sinus, you need to be very, very extremely careful, so that if there is no underlying injury, you should not produce a sinus tear. Always prevention is better than treating a sinus injury, especially if you are creating it iatrogenically. As I told you, the two common procedures which we do are the craniotomy near the sinuses, are the interhemispheric approach and CP angle approach. Generally what we do, we put a burr hole, not on the sinus, but slightly away, try to separate the dural sinuses so that you can subsequently increase the craniotomy. So whenever you try to do, as you see here, so never put the burr hole on the sinus. So you should know where your landmark is. If you have a navigation, that is well and good. You can mark the sinuses with the navigation. If not, you go by anatomical landmarks. So if you have a midline, you have a superior sagittal sinus. So you put a burr hole around 1 to 1.5 centimeters away from that, so that you are safe. And then you can try to separate it from it. Same thing. So you can, if at all you are doing a CP angle, you can use your arterial point to make sure that you don't put a burr hole exactly on the transverse sinus. So generally, you do the burr hole near the sinus and then you try to separate. If you are very close, and this injury can happen, and this, when you are putting burr hole itself, sometimes you can tear the sinus. So that is very, very important. So what are the nuances when you are doing a craniotomy near a dural sinus? Never pass the drill, something like this. Never pass your craniotomy through and through like this. You may tear apart the sinuses. So always separate it well, and then you pass your cranial broncher perpendicular, tangential to the bone, so that you prevent an injury. Because if you're doing this, you can see, you can completely rip off the dural sinus and it can cause disaster during a surgery. So, and if at all you want to expose, you expose the rim. There is no need to expose the whole sinuses. The more you try to expose, you may create more and more bleeding. So if at all you try to see the edge of the sinus and then you stop there. And if at all you want to expose the sinus completely, you, after exposing it, you separate it nicely and then you make a cut under vision so that you don't create any injury. So the important things, that do's and do nots when you have a sinus injury. Number one, the do's, always, if there is an injury, the visualization is very important. Never try to allow the bleeding to pop up, and then, so you have proper exposure so that if at all you want to repair the sinus, you can do so. Always take a suction and put a gentle suction and try to stop the bleeding with suction so that you know where exactly is the bleeding happening. And once you can do that, you put a gentle patty, soak with saline, and try to arrest it. Put a patty, and then you know exactly where the bleeding is. And once it is known, then you can take Surgicel wrapped with the gel foam. The problem is, do not put a small gel foam and then try to push inside the lumen. It can cause embolism by itself. Gel foam can go inside, and then it can cause block the sinuses. So that should not be done. So if at all you want to put a gel foam, you put a bigger size gel foam, not a smaller size. It should be bigger than the rent, but it should be exactly placed on the rent. If you place something away from the rent, the pressure of the bleeding can lift the gel foam away, and then it can cause bleeding again. So you identify the size of the rent, you create a sandwich of Surgicel gel foam, and then you place it slightly bigger than the size of the rent. You put a patty, 2-3 patties, wait for some time, patiently irrigate it. The pressure of the gel foam, the pressure of Surgicel, and your gentle pressure can stop any major sinus bleeding. So, and do not try to coagulate with the bipolar. It will shrink and cause more bleeding. A gentle elevation of head will help to reduce the sinus pressure, and thereby you can see the bleeding, but do not include to significant height. Otherwise, the reverse can happen. Bleeding can stop, but air can go inside and cause life-threatening, significant air embolism. So these are the things which one should be very, very aware. And when you are doing a sinus injury, most of the sinus injuries can be controlled, preserving its lumen. Your aim should be preserving the lumen at the same time arrest the bleeding. It should not that you have to clamp it and then coagulate it, because closing a sinus abruptly can cause disasters. So whenever possible, you try to reconstruct the sinus and then do not try to block it. So these problems happens of the air embolism, especially if you are doing a sitting position. You may not get bleeding from the sinus, but then it can be the other way in the air embolism. So we should be very careful. So whenever you do a sitting position, this is the transesophageal echo. So your anesthetist will be aware of this complication, and so he will be prepared, and he can detect this air embolism, and it's very, very important. So in sitting position, air embolism is very, very common, and you should be very careful. And whenever you're operating on a surgery for parasagittal meningioma, where you elevate the head end, again, you need to be careful about this role of air embolism. So what you should do, and how do you detect unexplained hypotension, sudden hypoxia when you're operating should be warning signs of air embolism. Increasing pulmonary artery pressure or PaCO2, end-tidal nitrogen also are signs of air embolism. The most sensitive methods are, as I showed you in the previous picture, whenever you're operating, your transesophageal echo will tell you whether there's any air embolism, and you should be very careful of it. Even if you not have that, even a precordial routine Doppler can show something called the washing machine sign, and your anesthetist can pick that out. What is more important is that 1/4 of population have a patent foramen ovale, and if you don't recognize this entity, this air embolism can cause stroke, and that is more disastrous. So what all you do, if at all you see any sinus injury, the first thing is inspect the operative field and irrigate it well with saline so that the air doesn't go inside, and slightly lower the patient's head end so that you know where the air is going in, and then you can put a tamponade on that. If you're unable to do so because your head is clamped and you're sitting position, you ask anesthetist to give a jugular venous pressure so that the air pressure increases and the air embolism can come down. So what anesthetist you should corrective measures from the anesthesia aspect is that arrhythmia, hypoxia, hypotension has to be corrected, and anesthetist, they will be on their toes when this complication happens. And whenever there's a central venous line, and they will try to aspirate the air through the right atrial chamber and try to put the patient on left lateral decubitus position, because that is the position where air can be in the right atrium and it is safe there to aspirate the air. And if the anesthetist is giving nitrous oxide, generally it has to be stopped because it can expand. If a patient is hemodynamically unstable, abort the procedure and then take the patient back to ICU, stabilize him, and they can always bring him back the next day to the OR. So I will be to show you two cases of sinus injury. I not say sinus injury, it's a planned sinus resection, so that you know how you correct a sinus repair. She's a 32-year-old female who presented as an ophthalmologist with visual loss of 3 month duration. She had florid papilledema, and also she had intermittent headaches. And you see, it's not a very big meningioma. This is a small meningioma. One should wonder why a small meningioma like this can cause papilledema to that extent. And this is the reason. So this meningioma was occluding this transverse sinus, and that was the dominant transverse sinus. So what happened to the opposite side? It was hyperplastic. So she had a dominant transverse sinus, and that got blocked by the small meningioma, causing future suggestive like an idiopathic intracranial hypertension with florid papilledema and visual loss. And we did a DSA. We can see that there's a significant kinking, narrowing of the transverse sinus lumen. The opposite transverse sinus was very, very hyperplastic, and the entire venous system was dependent on this dominant transverse sinus, which got blocked like this, and that is why she had this papilledema. So this is a tentorial small meningioma with the dominant transverse sinus occluded, causing intracranial hypertension. What we should do? She needs to be corrected. Either we can do a sinus simple shunt, thicopeptidoglycan shunt, to take care of the rise ICP, but the corrective problem is the transverse sinus occlusion. So we can probably, removing the meningioma can restore the transverse sinus patency and also can correct her hypertension. So that's what she will plan. So we plan to excise the meningioma and then repair the transverse sinus with a patch from saphenous vein. So we did a two-piece craniotomy like this. First was occipital and then a suboccipital craniotomy. So a two-piece craniotomy so that you can have access to transverse sinus from above and below, so that you can have a proper repair of the sinus. And saphenous vein patch was taken to reinforce and to do a microvascular suturing. And this was the venogram. You can see. So this is the lumen. So this is the occipital, that is the suboccipital cerebellar surface dura, and we can see that the meningioma was from below and it was pressing on the sinus, causing significant narrowing. So we know that the flow. So this is the ICG angiography which showed. So we know exactly. So it is a dubious. So even if it's a thin film, it will be filling, but we know that the block exactly here. So we planned our craniotomy and dural opening accordingly. And so this is the surgical video. And we can see that. So this is the occipit, that is the suboccipital region, and the same thing which I showed you, and that is a meningioma which is blocking it. And we open the dura like this. So this is the occipital dura, that is the tentorium. So we just closed, and then we also opened the suboccipital dura, exposing the cerebellum. So now we have, this is the transverse sinus. So we have both access from above and below, and we could see that meningioma, which is coming into the cerebellar surface and occluding, but also significant portion of tumor, we know that it is going inside. So first we tried to remove the meningioma on the cerebellar surface, so attached to the transverse sinus. So you can see that the extraluminal portion, this is like a collar stent. So there is one portion of the meningioma which is outside the sinus lumen, and the similar size of meningioma inside the sinus lumen. So first we removed the meningioma of the extraluminal portion to get it out, as we see here. So you can see it is a firm meningioma, and you can see that there is a good plane there, however. So this meningioma got excised, and in a veil you see. So once it is meningioma, that is a meningioma which is going inside the lumen. So we got prepared. So that is a saphenous vein patch. So we kept it ready, and then we started opening the sinus. We didn't put any clamp till now because there was no bleeding, because the meningioma was blocking it. So once we started removing the meningioma, this is the intraluminal portion of meningioma which is blocking or occluding the transverse sinus. So we started removing, gentle rocking movements. It was very firm. We didn't want to increase the rent, and we see that. So once we did so, the bleeding started occurring. So we know that once the bleeding occurs, that means we have cleared the lumen space. So you can see that the meningioma was attached to the lumen wall. So that is the rent. You can see how bleeding from the transverse sinus. So we know that this is the way to arrest any sinus bleeding. So once we did, so we put 2 clamps on either side, and we know there is some more tumor there. So that is the rent. So we went inside the rent and tried to remove whatever the remaining tumor. And that was the remaining tumor there, and we slowly removed, and that was the attachment. So because we wanted to clear the lumen so that it doesn't recur again. That is the lumen you're seeing there now. So this is the rent, and that 2 clamps are in place. So now we can start repairing the sinus wall with a patch. So that is a transverse sinus. This is a saphenous vein patch. So we used an 8O ethylone to repair this. So we can see that. So this is an interrupted sutures, and So you can see you should not occlude the lumen. So we should be doing it very carefully. And in the simple interrupted sutures. So this microvascular anastomosis techniques will help you in reconstructing these sinuses. So you can see that. So edge to edge. So don't take a very thick bite so that it can narrow the lumen further. So edge of the edge. So first you take the back wall. So once you finish the back wall, and then you can do the front wall. So these stitches, around 3 to 4 stitches on either side, that should be sufficient. And you can see gently you do. You can see that sometimes, unlike a STMC bypass, these needles can break because these are tough. They are not very soft like a STMCA lumen. So you need to be a little bit more careful. So you can see that. So once you are done with the back wall suturing, now we are coming to the front wall. So you can see that slowly the sinus is getting reconstructed. So you have finished the back wall, that is a front wall suturing now. And 2-3 stitches more. So you know that you are under vision. So you are always not very correct. Little bit oversized saphenous vein patch is better because you can try to overlay it beyond the rent size. So they can, and then you can put some Surgicel there. So that's a final picture. So you can see that now we have removed the clamp, and then you can see the sinus nicely filling now. And that is a post-operative angiography. And you can see now that the sinus is now completely filling, that luminous obstruction is cleared. So that is very, very important. So this is how you do a reconstruction of the sinus. You can do it nicely, and there is a post-op CT scan. You can see the meningioma is out and the wall is reconstructed well. The another case too is a parasagittal meningioma in a young guy with seizures. As you see here, the lumen is occluded by the meningioma, and you can see that is the meningioma which is coming up very close, and the one here one wall, and here the whole total lumen is occluded. So this is a short clipping of this patient. So we have removed the meningioma, and that is a sinus. So that is a sinus portion, that is a suprasagittarian, the bone edge. So we see that we wanted to clear, this is a young patient, so we wanted to clear the lumen of the meningioma. So you can see that the involved wall of the dural sinus was removed so that we can give a good clearance of the tumor. And we can see that, so we wanted to remove some more. So you can see that the edge is cleared of the tumor. Though it is anterior third, we can sacrifice the lumen, but it is not a practice because some patients can develop problem, and that is the fox. So you can see that there is a straight lumen. So now we can suture the dural. This is a double speed. It's for saving time. So you can see that again. This is a 7 proline stitches, and you can suture it like a continuous running stitches. You can reconstruct the wall. So your suturing should be very close to the lumen, otherwise you can occlude the lumen. So you can see that. So gentle suturing can help you. So using the other tooth forceps to invert the sinus wall can help prevent bleeding because you have a stay stitch here and the other lumen here, so that can invert the sinus, and that can avoid bleeding. So you can see quickly you can suture. You should be a little fast. And this is actually double speed. This is not a real speed. So that is nicely you can reconstruct the lumen with the running stitches. One also can do interrupted, but running stitches, especially if it's a long rent, you save time. So there is a final picture, and you can see that you have sutured it nicely, and then you also reinforce with some Surgicel over there. And you can see this suture helps you to invert the lumen so that you don't get bleeding when you are suturing it. So, and that is the final position. So this way you can reconstruct the sinus wall even if it is injured, and you can see that the post-op lumen, as you see here, it has got reconstructed, and you can see that the meningioma where it was. That's a post-op MR. So to conclude, sinus injuries are to be prevented. If at all it gets injured, try to pack judiciously, never try to overpack it and cause blocking of the sinus if it is already partially blocked. And whenever possible, you can reconstruct it nicely, especially if it is a big rent. The only thing what you should remember is never try to coagulate if it is a dural sinus bleed, because you are going to cause more bleeding by coagulating because it shrinks the dura more. And always one parallel aspect of bleeding, the other aspect is avoiding air embolism. Whenever you encounter major sinus bleeding. Thank you very much.
Thank you very much, Dr. Rupesh Kumar. That was excellent 2 cases where you've shown how to handle the complications of dural tear. In order of lack of time, we'll move ahead with the next talk. Next talk is by Dr. Vikram, and he'll be talking on repair of frontal and mastoid air cells. So, Saravanan, can you load his talk, please?
Good afternoon, everybody. Thanks for giving me this great opportunity to speak in this first Asian Congress of Neurological Surgeons International Webinar Conference. It's a great pleasure for me to be invited by Professor Sridhar and Professor Akaketu for talking about the surgical complications and its managements, mainly regarding the repair of frontal and mastoid air sinuses. We all know after a great surgery, the main problem of CSF rhinorrhea as well the otorrhea, which leads into meningitis, as well the mortality and morbidity related to the meningitis. As much as we concentrate on the skull-based surgery, it is more important for us to prevent these complications by taking care at the least end of the surgery, which is the end of the procedure, where all these frontal and air sinuses, mastoid air sinuses repair has to be done meticulously to prevent all these complications. This is a schematic diagram which shows us the frontal air sinus, sinus ostium, sinus infundibulum, frontal recess, and the ethmoid air cells, as well the middle turbinate, and through the frontal recess how the frontal sinus drains finally into the middle turbinate, middle ostium. We can see the lamina perpetua, which is the medial most part of the orbit, and the lateral most part of the nasal cavity, forms the barrier and identify us to lead into the part of the frontal recess where the frontal sinus drains. Needless to say, knowing all this anatomy will help us to identify both by transnasal as well transcranial approach to make sure that the exit path is properly sealed for prevention of the infection and the leak. There are certain anatomical variations of the Alzheimer's process which is well known. Either the Alzheimer's process can end in lamina perpetua, or it can end to the skull base, or sometimes it can lead into the middle turbinate. Knowing this anatomy in the 3D angiography, 3D skull base CT PNS will help us to identify the course of the septums as well as turbinates for us to identify how the sinuses are formed. We always know sometimes the frontal sinus air cells can extend supraorbitally as well and can be extending even up to the anterior clinoid sometime through the sphenoid sinus. And the frontal sinus repair is a very important and a meticulous job that has to be done to prevent complications in the postoperative period. The indications are skull-based approaches for anterocranial fossa tumors, like in this olfactory groove meningioma, where you can see the frontal sinus is such a large one and going at least 1 centimeter above the glabella, nasion, and you can see if we have to come to the nasal base, skull base, we have to cut the frontal sinus close to the supraorbital region to reach the base of the tumor. And the same way, when there are injury to the posterior table of the frontal sinus, that the fracture line can tear the dura and the CSF leak can communicate into the frontal recess. Some of the pathologies like mucocele of the frontal sinus can extend intracranially to the same because of the blockage of the frontal recess and the erosion of the bone. It can even enter into the intracranial space. Some of the rare skull-based pathologies do extend into the frontal sinus. And after removal of all these complex pathologies, the repair of the frontal sinus becomes a very important step for us to prevent further complications after a successful surgery. The main investigation behind this is the 3D CT PNS, which is essential before planning surgery. Though MRI gives you a average image, the best investigation for this frontal sinus is the 3D CT PNS. How do we do the frontal sinus repair? Either accentration of the frontal sinus or cranialization of the frontal sinus. Though both relatively the words remains the same meaning, the accentration of the frontal sinus, the osteoplastic flap with obliteration of the frontal sinus is the main theme, where the laterally located mucopyocele, or when there is a major destruction of the posterior wall, or in inflammatory complications after trauma, the major benign tumors with or without obliteration. Problem frontal sinus sometimes is combination with complete endonasal ethmoidectomy. How do we do this osteoplastic with obliteration of the frontal sinus? It is by this bicoronal skin flap. Either you take a zigzag or a standard Souttar's flap. Skin flap is always preserved with the supraorbital and supratrochlear nerves. This gives you a large pericranial periosteal flap for us to cover the frontal sinus. Based on the CT and the 3D MRI findings, the vascularized pericranial flap will be raised either towards the base, that is towards the frontal base, or it can be raised even laterally. The cranial cuts are done as close to the supraorbital region, and it is always preferable to preserve the supraorbital ridge for the cosmesis purpose. After, you can see in this, the skull base is taken as close to the base, and you can see the part of the supraorbital area there. After doing this extradural procedure, even both frontal sinus are linked, removing the septum in between the frontal sinus. The osteoplastic flap is raised from the skin flap, and the obliteration of the frontal sinus is done. Usually, the mucosa is stripped towards the frontal recess, and the mucosa is pushed in or removed, followed by putting up a facial graft or a free fat graft overlaid with gel foam and supported with tissue glue, which is further covered with osteoplastic pericranial flap to obliterate the frontal sinus. The frontal inner sinus is broken, and if possible, many a time we can even use a partial thickness posterior table graft, which can be used to cover the osteums bilaterally, after which a pericranial graft of this vascularized graft can be taken from the bicoronal skin flap. As this is a vascularized graft, depends on the size of your pericranial incision and the length, you can raise a vascularized pericranial flap either from the bilateral sides, or you can take it from the midline and switch it towards the one side. Once the peripheral graft is raised and posterior inner table of the posterior frontal sinus is preserved, the graft is laid after denuding the mucosa, putting up the fat graft as well, fibrin glue with coverage of the bone graft, and then the pericranial graft is covered with a vascularized formation completely. This can be done both extradurally and intradurally, but preferable to do it extradurally to get maximum coverage for the frontal sinus. The difference between the cranialization of the frontal sinus and the accentration is the posterior table is drilled off in the cranialization of the frontal sinus, so that the frontal sinus is completely incorporated into the intracranial cavity after closure of the frontal recess. The original description consisted of removing the posterior wall of the frontal sinus, meticulous removal of the frontal sinus mucosa, and allowing the frontal lobe dura mater to come to rest.
The initial part remains the same as in the excenteration. The posterior wall is removed completely and the sinus is cranialized, and so the removal of the mucosa is compulsory. The outer table is maintained to give the cosmosis. Either the original bone is maintained or using prosthesis of PMMA or titanium after covering the sinus using the pericranial fat gel foam grafts in the tissue glue. We can even do endoscopic approaches if there are multiple attempts of transcranial approach and failures, where in case there is an endoscopic approach, the frontal sinus is approached through the beak of the frontal recess through the endonasal approach, and the agar cell and the beak is drilled to expose the frontal sinus, and the same work what is done from cranial side can be done from the transnasal side, where the drilling of the axar cell as well the beak of the frontal sinus links both the frontal sinus cavity into the single cavity, and this entire cavity can be filled with the fat graft, fascia as well the tissue glue and supported by cartilages. This forms a transnasal endoscopic excentration of the frontal sinuses. Unlike frontal sinus, the contamination of the mastoid air cells to the nasal mucosa is less. So, most of the time when the mastoid air cells repairs are done, if the mastoid air cells are small in size, it used to be covered with small portion of the gel foam and bone wax is sufficient. Unlike frontal sinus, which were connected directly to the paranasal cavity and the nasal cavity, mastoid air cells connectivity through antrum and eustachian tube makes it less infective than frontal sinus. This gives advantage of using the simple bone wax muscle with pericranium for closure of the mastoid air cells inadvertently opened during the retromastoid procedure. However, when used pre-sigmoid, sufficient use of fat and temporal facial grafts becomes essential along with fibrin glue for tight closure of the defect. In retromastoid, when air cells are small in size, simple waxing using the bone wax and overlaying with muscle or gel foam seals the defect. When the air cell sizes are bigger, packing the air cell with muscle, gel foam followed by waxing and overlaying with vascularized pericranium is the region sealed and fibrin glue aids complete closure, preventing the leak through causing CSF rhinorrhea. Rarely, mastoid antrostomy and packing of the antrum with muscle fat graft is required when recurrent CSF autoria or rhinorrhea occurs. The best investigation again here is the 3D CT temporal bone, which helps us to identify the mastoid air cells which is overlaying the sigmoid sinus or the transverse sinus. Here you can see the position of the patient head as well the skin incision, and you can see the vascularized pericranium is left as a separate layer which can be covered after the mastoid air cells are open, which were packed with wax and gel foam and muscle. This helps to completely seal the mastoid air cells and prevent CSF rhinorrhea. Thank you.
Thank you very much, Professor Vikram. Now we'll go ahead with the last talk. Last talk will be given by Dr. Umesh Srikanta, and he'll be talking on repair of spinal dural tear. So, Saravanan, can you please load his talk, please? Saravanan? Saravanan, are you there?
Yes, he's just sharing. He's just sharing.
Okay. audio is not coming. I think its presentation is in the form of a PowerPoint with the voiceover, but the audio is not coming. Dr. Umesh, you have your presentation with you right now?
Yes, I have it.
Maybe Saravanan, can you just allow him to share his PowerPoint, and then since it's the last talk, he can. But just I request you to, if you can wind it up in 10 to 12 minutes, because we are really lacking and running short of time.
No problem.
Yes, thank you, sir. Saravanan, just please allow him to share his screen and he'll present his talk.
Yes, Dr. Umesh, you can now. Yeah. Hello.
Yeah. Well, at the outset, again, I would like to thank the ACNS organizing committee for giving me this opportunity. I'll be talking on dural tear repair in spine surgeries, and I'm going to give some clinical examples to show the dural tear repair, especially in MIS procedures, because that is what I have. So accidental durotomy, as we know, is either more commonly due to surgeon inexperience or an incorrect technique. But there are several risk factors that can be responsible, that can predispose to a higher risk of accidental durotomy, like an older age group or a coronary compression, in both cases where the dura will be thinner, an ossified ligamentum flavum or synovial cyst due to adhesions, and of course, scar from previous surgery, again due to adhesions, which is probably one of the most important reasons for encountering a dural tear during spine surgery. The incidence is significantly higher in revision cases as compared to primary cases. So coming to the classification of dural tears, they can be classified in both the sagittal as well as in the vertical as well as the horizontal plane. In the vertical plane, it's not very important. They're classified as type 1, 2, 3 based on whether they occur in the lower third, middle third, or an upper third of an operative field. Whereas classification in the horizontal plane is more important. That is, either they can be type A tears, which are usually dorsal, that is median or paramedian, and which are clearly visible. The dural edges can be clearly visualized, and primary repair, of course, can be done easily. The type 2B tears are the lateral tears, that is, they occur usually in the nerve root axilla or the lateral recess in the shoulder of the nerve. So these tears are usually difficult to, they're difficult to suture primarily, and usually need some kind of an adjunct to repair them. Type C tears are ventral, which do not cause significant problem in majority of the cases, and we'll be discussing that later. So it's very important to understand and repair these accidental dural tears because of the consequences they have. One of the most important consequences that we can have is a post-operative CSF leak, wound CSF leak, which actually is a harbinger of further complications to come. It can lead to wound dehiscence, it can lead to deep surgical site infection, as well as meningitis and several other complications. Whenever there is no CSF leak, there can be internal issues like a pseudomeningocele, more importantly, which can be small or large, and more importantly, it can cause nerve root entrapment leading to radicular symptoms. And of course, in either of these cases, patients who develop post-op CSF leak or who develop internal pseudomeningoceles are more likely to develop failed back syndrome as compared to patients who do not have encounter an intraoperative dural tear. So there are several types of repair possible. One of the best and the most successful type of repair is direct suturing, and of course, whenever possible, watertight closure should be attempted and should be our aim. If watertight closure is not possible, either tack sutures to approximate the dura and using tissue adjuncts like fascia, muscle, or fat to occlude the remaining of the opening, as well as using some kind of an augmenting the repair by either a fibrin glue or even sometimes dural substitutes can be used in all these cases. So as I was telling, primary repair has the highest chance of success, and watertight closure should be attempted. So this is video showing the watertight, means usually showing an intermittent suture in a minimally invasive after a tumor resection. So that is our principle based on which we can repair the dura in these cases. The idea is to prevent pseudomeningocele, underroot prolapse, or CSF leak, as been mentioned. Coming to the steps, it's very important to identify the edges of the dural repair. So in order to see whether the dural edges are regular or irregular, whether they are approximatable or not, and whether a primary closure can be achieved or not. Many times it will be necessary to remove extra bone either above, below, or on either side of the dural repair, because most of the times dural repair happen at the edges when we are resecting the bone or the ligament. In many cases, once we have identified the dural tear, an approximation test has to be done by usually putting one stitch at the center of the tear, or usually approximating it with bipolar or by the bayonet forceps, and to see whether primary repair is possible or whether any dural adjunct is required in order to repair these kind of tears completely. So whenever primary repair is not possible, again, as mentioned, tack sutures in order to approximate the dura can be used, or dural adjuncts or synthetic dura can be used in these cases. Several types of synthetic materials are available, including fat or a muscle graft, synthetic dural substitutes, and either they can be used as standalone or can be augmented by using either a blood patch or a fibrin glue in order to hold them in place. It is important to understand the different properties of different dural graft options available. I will not go into the details of this due to lack of time. Again, role of fibrin sealants, it's important, or it's useful to use fibrin sealants whenever there is a leak, even after a primary suture. To augment the edges in a weak repair, especially if we have, there can be leak through the suture or entry or exit points, because we are using a slightly, either because of the needle entry points or because of the tension in the suture stitch itself, or it can be used in order to hold a muscle or a fat graft in place. Whenever there is a partial thickness dura, that is an arachnoid prolapse with no CSF leak, it should always be treated. Usually it should not be left alone, because it can act as a tension wall, can cause high pressure leaks, and have a high risk of progression and the risk of converting themselves to a later full thickness tear or developing an internal pseudomeningocele. So again, these can be repaired either by primary suture at the risk of actually converting a partial thickness tear into a full thickness tear due to the needle puncturing the thin arachnoid while we are taking the suture. This can be prevented by placing a small piece of gel foam and pushing the arachnoid down while taking the suture. And of course, in some cases, only just a fibrin glue application on this partial thickness tear is sufficient in order to prevent any progression of these pseudomeningoceles. Placing a drain again is controversial in these cases. Usually, when there is a watertight closure and we are very happy with the closure, we can follow general principles as to whether leave a drain or not. But of course, drain should always be left, especially in revision cases of the healing potential of the subcutaneous tissues and the skin itself is in question. And of course, whenever we have unsure repair with significant dead space for the for CSF to collect in these cases, the idea in these cases is to keep the drain in the submuscular or intramuscular or a subfacial plane, achieve watertight closure of the fascia and the skin, and allow sufficient time for the skin and the fascia to heal before we remove the drain, so that external CSF leak is not encountered in these cases. Again, principles of managing dural tears again are based on two main pillars. That is, one is stopping CSF leak, which is intraoperative, which we have discussed till now, either by direct repair or by using dural substitute. Post-operative measures like retarding CSF leak are equally important. Either they can be aimed at reducing intrathecal pressure by either positioning in a prone position or at a head-end position, or inhibiting CSF formation by giving drugs like acetazolamide. Though these methods are all controversial, again, each of them can play its own significant role in preventing any complications due to intraoperative dural tear. Increasing the epidural pressure, especially in these cases, as I was mentioning, by tight facial closure and usually using a blood patch or a prolonged non-dependent drainage using a submuscular drain, can actually prevent any kind of a post-operative complication. So this is one of the clinical case examples, MIS TLIF being done in a post-laminectomy case. So already laminectomy has been done in an open fashion, and this is a MIS TLIF being done for that particular case due to a listhesis. As you can see, while draining the medial portion of the facet, there is an unintended dural leak there, which can happen if we are not very careful, or we have not separated the dura completely before we drill in this particular area. So the main idea in these cases again is to identify the dural edge again to resect the remainder portion of the bone in order to clearly define the dural edges and clearly define the rent that we have caused. As you can see, the dura is being progressively sequentially separated, and then the inferior articular process has been removed, and that is the dural rent that we can see there. So in revision cases, it's very important to actually have significant or achieve kind of a release, because of the adhesions on the dura, it will not be able to approximate. So once adequate release has been obtained, so here we are putting the central stitch there in order to see whether primary repair can be achieved. And then after that, multiple intermittent sutures can be done. This is being done in a 22 millimeter tube. Of course, when we have adequate space and we are doing in an open surgery, then we can actually repair the dura in a continuous fashion. So once the dural repair is done, we can finish the procedure over there. And that is what was shown. So this is another case, again an MIS TLIF, primary case. This is not a revision case. So we are doing a contralateral decompression. So as we can see that is the contralateral side. So when we are removing the upper edge of the lower lamina, as we can see that there is a small slight hint of a CSF leak, and these are the things that we should be very careful, because these are the edge, and if we observe closely, there is a small nerve root that is actually prolapsing over there. So in these cases, usually these are at the edge, so we'll have to identify or define these tears more appropriately. So once we see there, multiple nerve roots are already prolapsed in this particular case through a small dural tear, as we are going to make out later. So obviously in these cases, again, bone removal has to be done with utmost care to preserve the nerve roots, and further decompression is achieved in order to clearly delineate. And as was being the teaching, whenever the dural tear is small and through which multiple nerve roots have collapsed, our idea here is to open the dura further to a larger extent so that we can reduce these nerve roots. But unfortunately, in this case, as you're going to see, once we open the dura, the nerve root prolapse also increased. As you see, the nerve roots are actually coming out. The entire chorda is going to come out into the operative field. So the trick in these cases again is to, not to panic, keep our patience, and in order to reduce the leak or reduce the nerve roots back into the dural sac, we have to adopt certain measures like put the head down, reduce the intrathecal pressure, and of course, identify one edge of the dura in these cases and try to push as much as gently as possible the nerve roots back into the thecal sac. So once that is done, we can actually achieve complete reduction of all these nerve roots. And then we can identify the edge of the dura, that is the lower edge or the upper edge usually in these cases. In this case, we have identified the lower edge there, and we are taking the first stitch, which is usually the most difficult one. So once we put in one stitch, then actually multiple sequential stitches can be taken. Again, this is being done in a 22 millimeter tube. So continuous suture usually is difficult in a 22 millimeter tube surgery. So because it is not a watertight closure, as you can observe there, the dura has been completely approximated. This is being augmented with a muscle patch as well as a fibrin glue. And the rest of the procedures can be completed. So just to summarize, the accidental durotomy depends on where the tear is. A dorsal tear we have already discussed in detail. If the tear is around the nerve sleeve, usually suture should not be attempted, because the suture itself can cause a constricting ring around the nerve root and can cause some compressive features post-operatively. So usually in these cases, it is better to use a dural substitute or a patch, a fascia augmented either with a fascia or a fibrin glue. Ventral tears usually are not a problem. We have not discussed that in detail. So usually they can be left alone. They heal spontaneously, do not cause any post-operative CSF leak. But of course, we have to augment the tear by using either a gel foam sleeve, and especially when there is already a nerve root prolapse, which has through the ventral dural tear. So in these cases, again, a transdural repair has to be attempted and close the ventral dura first, as well as close the dorsal dura later on. Again, dorsal tear we have discussed in detail. I will not go into the details of this flow chart. So thank you.
Thank you very much, Dr. Umesh. As always, you showed fantastic cases, and that nerve roots coming out like a noodles. That is a nightmare for any young neurosurgeon. But you showed it very well how to handle that emergency situation. So we are over with all the panelists talk. And I want to thank outside all the panelists, Dr. Dilip Panikkar, Dr. Rajkumar Deshpande, Dr. Suchanda Bhattacharjee, Dr. Kuntal Kantidas, Dr. Rupesh Kumar, Dr. Vikram, and Dr. Umesh Srikanta for accepting our invitation and being a guest speaker. All the talks were very interesting. And I'm sure all the talks will be available on the YouTube. So all the young neurosurgeons can go back and see it whenever we have any issues. I'm not sure whether we have time for discussion. Dr. Sridhar, do we have any time for discussion?
Maybe just about 5 to 10 minutes, because
Okay.
3 o'clock we should be starting the inaugural session.
Yes, sir.
So maybe,
So maybe
5 to 10 minutes.
5 to 10 minutes we can have a discussion.
Wow.
So the floor is open for all the panelists for the discussion. So. Only one question I had. You said for the dural closure, you're doing the intermittent closure and not a continuous. One thing. And second thing, one question for Dr. Vikram. We always have a confusion from a young neurosurgeon point of view that to seal the air cells, what is the better substitute, whether it's a muscle or is it a fat?
So shall I answer first?
Yes, sir. Yes.
Yeah. So because these were being done in a minimally invasive, these are 22 millimeter tube surgery. So usually continuous sutures are difficult to obtain because basically running sutures are not very easy. We have tried it, we have attempted it, and we have done it in 1 or 2 cases, but they are slightly cumbersome. In minimally invasive surgeries, as we know, I didn't stress that point, as we know that the post-op CSF wound leak is actually never a problem. Because once we remove the tube, the muzzle tract closes and leaving no dead space behind, so that the CSF cannot seep through the muscular planes into the subcutaneous tissue or the skin or through the skin. So wound CSF leak is actually never a problem. So our idea in these cases, minimally invasive surgery repairs, is usually to prevent pseudomeningocele. And intermittent sutures, just to prevent any kind of a pseudomeningocele or nerve root prolapse, is sufficient in majority of the cases. But of course, whenever we are doing this, whenever watertight closure cannot be achieved, it is always better, whether it is a minimally invasive surgery or an open surgery, it is always better to augment it either with some kind of a muzzle graft or use substitutes like fibrin glue in order to achieve a watertight closure in as many cases as possible.
Yes, sir.
So thanks for the question given to me. To me, as far as I have done, I have always seen the closure is much better with the muscle. And most of the time, you will have either temporalis or the suboccipital muscle for sufficient harvest, and you can pack it sufficiently. And the closure is much better with muscles than fat.
Yes, sir. Thank you, sir.
Thank you. Thank you very much. Any other questions? Dr. Rupesh, you want to add anything, please?
Can I ask Rupesh a question?
Sure, sir. Yeah.
I couldn't resist the opportunity. These meningiomas that invade the sinuses, we very frequently encounter them. Now, in your practice, how often do you chase the tumor into the sinus? And when do you decide to chase and when do you decide to leave?
2 things. One, if the consistency of the tumor. First thing is the age. If the patient is young and if the tumor is like anterior thirds, then I like to chase the tumor because they have a long life ahead of them. And we know that anterior third, we may able to repair the sinus little well without compromising. Even if there's a slight compromise of the lumen, that may not really matter much as long as we restore the lumen. But definitely more than anterior, middle and posterior 2/3, I would like to not to chase the tumor. The soft tumor consistency, if it was a soft tumor and if it is ventral to the anterior third of, and a young patient, these are the indications which I will chase it. This patient where I showed, he fulfilled all those criteria. It was anterior third, and he was a young patient, 28 years. He has a long. So that was, it came out well.
That's always, yeah, that's good. That's always a very difficult decision whether you chase the tumor into the sinus or whether you leave it and let radiosurgery deal with the rest of that. But like you said, yeah, you need to have guidelines, and I think individual surgeons have to have their own preferences as to how they would do it. Yeah, that's important.
So one of the problems what we may face, luckily in his surgery, it was not there, I think. When we occlude the sinus, that to the dominant one, even for a partial time, we can have sudden rise in ICP, which sometimes we may not be able to control. All probably depends on the duration, position, and a lot of things like that. Otherwise, always preserving the sinus will be the best thing to do, I think.
Yeah. The place which I showed, it was a dominant. It was the only sinus, and it was almost close to 80 to 85% occlusion. So we know that. So probably there may be some collateral which has already happened. So we had a grace time. So we thought the closure should not be more than 30 minutes cross clamping. So what we did is we gave a burst suction completely. So we told the anesthetist it's going to be. So we were quite quick, and the cross clamping time was 30 minutes. So we could get quickly the closure and reconstruct the patency. Of course, we need to be very fast in that.
Absolutely. Umesh, can I ask you one?
Yes, sir. Sure.
When you encounter a dural leak, especially when you're doing a MIS procedure, and evidently, as you have shown and have described, the access sometimes is very, very difficult when you have to, you may not be able to see very clearly. You spoke about leaving a gravity drain, a drain in the intermuscular plane to allow your wound to heal. Would you recommend using lumbar CSF drainage or an external CSF drainage along with this to reduce the CSF pressure in the thecal sac?
Sir, as I mentioned, in minimally invasive surgery, it is not necessary because most of the times there is no dead space available. And the moment the muscle falls back into place, the epidural pressure actually increases and prevents any kind of a active leak. Our idea here is to prevent pseudomonigosis. But however, in open surgery, in revision cases, when we have done open, yes, of course, when we encounter a dural tear, we always leave behind a drain. In the first instance, usually it is always submuscular, never a CSF intrathecal drain. But of course, if despite that the leak is not healing and there is a persistent leak, in all those cases, in those cases, we prefer to use a intrathecal drain inserted postoperatively rather than leaving it intraoperatively per se. Thank you.
Is
Thank
there
you
a
so
time
much,
for
sir.
one question to Dr. Dilip Panikkar from me?
Yes, sir. Last one, sir. Thank you, Dr. Rajkumar. Please.
The question is, Dilip, when you do awake surgery, especially for more posterior locations, if you happen to do, how would you manage the positioning of the patient? Would you consider a relative contraindication for more occipital kind of lesions, or would you somehow manage during surgery? What's your
lateral? All these people, the more lateral you get or the more posterior you get, you put your patient in the lateral position. So that's absolutely fine, and that gives you an access to even very difficult lesions. It's not a great issue.
Actually, I find it more difficult in insular gliomas of the temporalis muscle. Usually, you use a fish hook, and temporal there is a real difficulty. You will not be able to evert because we want the drape to be on the head. So how do you manage that?
Yeah,
how do you handle that?
I completely agree. That is a practical difficulty. The lower you get, and the more temporalis you have to reflect. So the key, I think, is rather than trying to reflect your temporalis forwards, you reflect your temporalis backwards, so that you're working from a more anterior trajectory, and you leave your face free. Otherwise, like you said, your fish hooks will come right over your face, and the visualization of the face and the assessment will become difficult. Not only that, I think your patient has a lot more discomfort when you mobilize and retract the temporalis. So that's always a bit of an issue there.
Sir, can I ask a question? Dr. Balamurugan.
Thank you, Dr. Dilip. Thank you, Dr. Rajkumar, Rupesh, Umesh, and Kuntalji. Thank you so much. I think we come to the end of this session, and I hope the young neurosurgeons benefited from all the seniors and the excellent work and the excellent videos. And unbelievable, all the videos worked fantastically. There was no hitch with anyone's video, and I'm sure I put you all through a lot of problems trying to get this video recording with the voice recording. I'm sorry, but then I think we have established a new norm now. I think it's so much more easier to coordinate a meeting where the presentation is already available and then the discussion time is spent in a more constructive way. I would love to have all your feedbacks and hope to do more of this very soon. Thanks to Dr. Sridhar for agreeing to do this kind of a concept. And I think the main session, the inaugural session, will start soon. We'll be having the WFNS president and also the AANS president there along with Dr. Kato. So please join us for the inaugural speeches and talks by world-renowned authorities. Thank you so much. Thank you all.
Thank you.
Thank you.
Thank you.
Thank you, Bala.
Thank you.
Thanks, guys.
Thank you, Bala.
Thanks a lot.
Very much. Good evening, Eka.
Hi, good evening, Chris.
Good evening, Professor Franco.
Good evening. Good evening,
nice to have you
everyone.
here.
Yoko, good evening. Hello.
We will wait for the other speakers of the session to join and start, I hope, exactly in about 8 minutes.
Dr. Kato, good evening. Your microphone, please. Yeah, Professor Kato, so I just wanted your feedback about today's session, and the whole thing was all recorded, pre-recorded, and it was played, and the moderators were there only to interact. So
can you say once again, please?
Yeah, I'm sorry. I just wanted to have your feedback about the session today for young neurosurgeons.
Yeah.
Because the entire module where the surgeons had pre-recorded all their
I see. Okay.
sent it to us.
Yes.
It was played, and the speakers themselves became the moderators, and then they had a discussion. So this is the first time we are trying to do this, and we want your feedback because I think it makes it so much more easier because there is no problem with the audio, video, and everything is already
right.
there.
Yes. So that's a good idea, I think. So maybe no time delay.
Yeah, no time delay. We were on time for everything.
Yes. Great idea. Thank you very much for a nice session.
Thank you.
Thank you.
Yoko, how are you?
Hi, Franco.
Hi.
How are you?
I'm
Nice to
fine.
see you. So what's the situation of the Italy?
Bad, very bad. We
Very
still are
bad.
in the second wave.
Okay.
Correct. But
So in Japan now is maybe we would say the third wave. So, but even though the everyday some infected patient is around 500 in the whole country.
That's nothing. As compared to 20,000 as we have now is nothing.
Yeah.
Nothing.
Looks
But
very cool.
we are decreasing again, so we will see. We hope it
Okay.
will work.
Yes.
We hope it will work.
Do you have a lockdown in the town or some
Nothing else.
cessation?
But in some ways, the restaurants are open only for lunch. Everything is closed after 6 p.m. It's something in between.
Okay.
Let's say soft lockdown.
Okay.
If it works or not, nobody knows.
Okay.
We will start the vaccination January 10. So soon we will start the vaccination.
Okay, okay. So maybe in Japan, maybe 2-3 months after.
Well, the European community is due to approve 28 December. So from January on, we already have the vaccines here. So we are waiting the approval and then we start.
Because we are planning to have an Olympic game.
So you will need the vaccination for everyone.
Olympic yes.
Eka, what about Indonesia? How is it?
Hi, Franco. Indonesia is always uncertain. Always uncertain because we sometimes just stop checking testing because result is always, it's very difficult. You know, here people are very stubborn. So they are, anyway. But this is, I think, is always the same. We are in the third wave. I just watch in our hospital now. COVID patients now becoming full again. ICU COVID become full again. The exact number we do not know because sometimes, yeah, frankly speaking, we don't check too much because check too much or not check too much, the solution is same. Limitation, the movement of the people and master. So sometimes it was so costly.
Like a nice background, the Christmas.
Ah,
very nice, beautiful.
Just
I can
imagine.
see.
People in Italy, Franco.
Yeah, as I told, it's bad. We have we are in the peak of the second wave, so it's not good. We have many patients, not so many in ICU, and we are still working. In the first wave, we stopped doing elective surgery. Now we are still doing elective surgery. So it's a mixture of COVID and elective surgery with all the protection. This time we have all the protections. We have protection for ourselves. We do testing for everyone. So it's different. We hope it works. We don't know.
Do you regulate all the outpatient also?
Outpatient, yes. Everyone is tested twice, not only once and maybe too much. Twice. Before coming to the hospital, you have two testing, a CT of the lung to everyone who is operated, chest CT scan, and then every 5 days that they are in hospital, they are tested. Plus, all the doctors are tested every 2 weeks. So we are testing everyone.
Okay. Good idea.
So welcome to Professor Talat Kiris and Professor Borba.
Hello.
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 Good evening.
Hello.
Hi, Franco. Hi, Yoko.
Hi, how are you, Talat?
Nice to see you.
Fine, fine. It is more or less the same like Italy. We have also very high numbers. The situation is not good. This week, actually, I stopped my surgeries if it is not an emergency. Until last week, I operated, but now the hospital is full, everywhere is full. We are waiting the vaccine. The government purchased this Chinese vaccine, and they will start to do it at the end of this month or beginning January. So hopefully it will happen.
See. So Talat, we need to go to Ethiopia.
Yeah.
It's postponed.
It is like a dream now. I don't know when.
But already
when
Franco
can,
that he went to that hospital already.
Yeah, I know, but it is in the past, yeah.
Yes.
Yeah, unfortunately.
more than a year that we don't move, we don't travel. My last travel was exactly a year ago. 1 year ago, I
Really?
was in India. Yeah, you remember, you were there, Yoko, in Mumbai, in India,
Oh, yes, yes.
a year ago. Then
All
after
all
that,
of us, all of us.
all of
Yeah.
us, yeah, we stopped traveling. At least me, I stopped traveling.
My last
Oh,
one is Bangladesh, the last February.
In February, no. In January and February, I went only to France, and that's all. And
Less
then
than a year.
at the end of February, they stop everything. So
Yes, yes. Yeah.
Sridhar sir, it's time. I think we can start the session. It's 3 o'clock.
Yes, so we are just waiting for Professor Anil Nanda and Professor Qureshi to join.
Mm-hmm.
We just wait for 2 minutes, and then otherwise we start it.
yeah, I wanted to tell you something. After my presentation, I will stay only 5-10 minutes. Then I have to go back to the hospital. So I'm telling you, sorry, but I cannot be with you the whole session. Only sometimes after my presentation. Maybe I can come back, but at that time I have a meeting in the hospital to organize.
Thank you very much. Thank you for being
to
here.
organize the program of the next week.
Thank you.
Good morning.
Hello.
Hi.
Morning.
Hello, Professor. How are you?
How are you?
Good afternoon, everybody. Maybe good night, somebody.
Mulva. Hi, how are
Yeah,
you?
how are you? Fine.
Hi, fine, thanks. Hi. Brazil is the summer now.
It's starting summer.
Can you hear?
Yeah.
Summer.
It starts.
Okay.
Yeah, it starts summer, but the weather looks like winter. Yeah.
Oh.
And the corona doesn't want to leave us. You see,
Yeah.
the second wave is worse than the first wave. Crazy. Much worse. Much
Everywhere.
worse.
Yeah.
A lot of doctors
It's the same.
in the ICU in my hospital. 30% are doctors or nurses as patients, inpatient. Crazy.
Really? Oh.
That's terrible.
Yeah, and the second wave is stronger than the first one. But I don't know.
Professor Kato, can we start now?
Yes.
Yeah, I think. So on behalf of the organizing committee of the Asian Congress of Neurological Surgeons and the Asian Congress of Neuronursing, the first virtual international conference, I'm Chris Sridhar. It gives me great pleasure to invite all of you to this inaugural session. I just have I would, at the outset, pay my regards and thank Professor Yoko Kato, the president of the ACNS, and the members of the executive board.
So thank you so much. So I'm so happy to see some. Sorry.
Who have given us the opportunity for us, the organizing team here in Chennai, India, to organize this virtual meeting. It started off, the thought process started off as a 2-day meeting, basically for education of young neurosurgeons. But now we are 3 days in 3 halls and a program extending over 8 hours every day. And that's because of the support and enthusiasm we found from everybody all over the world. So thank you very much to everybody for having this. And Professor Yoko Kato has been a good friend of all young neurosurgeons, of the nurses. And this is the interaction that we have had over the years in India. In February this year, we had an outstanding Asian Congress of Neuronursing where we had more than 250 nurses join us from different parts of Asia and India. And thank you, Professor Kato, that we are able to take this initiative forwards. And here too, in this virtual platform, despite the problems that the nurses are having, we are able to have a good program. Also, thanks to Professor Tetsuo Kano, who's the founder president of ACNS. Must remember the 1993 meeting, which was organized, where it all started, where young neurosurgeons, 100 of us, attended the meeting in Aichi, in the Toyota campus, and we all benefited from it, and we are still benefiting from this educational drive, which is now the ACNS. So I also would like to thank and place on record my thanks to the entire team which has worked for putting this program together, especially Dr. Balamurugan, who's the secretary of the Asian Congress of Neurological Surgeons, my own colleagues who are the organizing secretaries, the young neurosurgeons, Dr. Sachin and Dr. Harshal, as well as some senior neurosurgeons of the city of Chennai who have helped put the program together. The Asian Congress of Neuronursing has been a drive which is now expanding. We are seeing more and more neuronurses interested. This is Yi Ching, who's the honorary president of the ACNN, and I welcome her. And this is our team in our hospital who not only organized this fantastic meeting in February, the picture of which you're seeing, but also this meeting which we are going to conduct over the next 3 days. It so happens that 2020 is the year of the nurse. And I must say that in this year, because of COVID, not only neuronursing is tough, but COVID has made it even more tough. And hats off to all the nurses. And it is our endeavor to not only educate them to bring up the standards of neuronursing, but also empower them to do more and to do things better for the welfare of the patients. We welcome all the guests, faculty, and delegates from all over the world. We have delegates and faculty from every single continent and a lot of countries. We have more than 600 registered delegates, 250 plus lectures, and 75 plus posters, other than nursing lectures, which will be there in 3 halls. So thank you all very much for being here with us. And I would now request Professor Yoko Kato to say a few words.
So should I start my presentation, Sridhar?
Yes, ma'am. Please start your presentation.
Okay, okay, thanks. So at the beginning, I thank you, Dr. Sridhar, and my big congratulations to your achieve such a certain educational level. And I'm so happy to be invited the first the virtual SNS web conference. Once again, I thank you very much for Dr. Sridhar and your entire team. So this is the picture which you already showed. So there's so many nurses and also Dr. Mishra and so many neurosurgeons are standing in front of us. And so just I'd like to maybe a little bit overlapping with Dr. Eka. So instead of Dr. Kano, just I want to introduce about SNS. It was starting the 1993 already. Dr. Sridhar that he mentioned, Dr. Kano and Dr. Raja, they started this Congress. Of course, another very big name of the senior teachers. Already the supported ACNS, Dr. Balamurugan and also Dr. Maurice Shooks and Dr. Ota and Dr. Hashi. So this is 1919 that there's a funding the conference which was held in the hall in Pakistan. So the Dr. Kano, the plan is the target is not only doctors but also students and nurses. Then he had so many seminars and the medical teaching course, many things. This is very famous pictures among the Asian Congress teams. So here is Dr. Ika and Dr. Mishra and so many Indian doctors are standing in these pictures. I was here and Dr. Kano is here. Everybody was very young at that time. And this was one of the party. And also the structure is every 2 years Congress. And this was every 2 years. It was started 1993 in Toyota City, motor car, famous motor car. And Dr. Eka and Mishra, that of the 6, Jison Tsao, and also the Malaysia and the Chicipin and Turkey and Kazakhstan and also Indonesia second time. And Imad Kanan, that was 2018. Unfortunately, the Danilov from Kazan postponed. And also the 2022, the Chinese Dr. Mao In is supposed to be the president. So Dr. Kano is always surrounded by not only the doctors, but also the nurses. Those are from Sri Lanka, and also the scribing nurse from India. So they supported a lot instead of they learned many things. And this is Dr. Otto's Congress, SNS. And when I was young, Dr. Sami was invited honored guest. And also we invited 2 doctors from North Korea. This is my the Congress, the 2000. And those 2 big names were invited. And also this is doctor from Indonesia, and also I forgot his name, Yashajul, Professor Yashajul. And also this is I forgot, sorry. And this is the 6th Asian Congress. Dr. Mishra was conducted at that time. So that this is simultaneously we had all the time is the female association. We encouraged the female neurosurgeon from the beginning. So this was taken in Hong Kong, and this is Japanese. And this is Malaysia, and this is Turkey, and this is Kazakhstan, and this is Indonesia, and this was last one was held in Dubai by Dr. Imad Kanan. So simultaneously, we encourage the young doctors to write paper. So this is official journal of the AGNS, and this is a board member. And this is a current, some kind of structure of the ACNS. We invite Dr. Hira, he is a society, the resident and the student and resident society, and also the nurse. And also the main purpose is education, and also the YNS, the committee. Those are the main structure of the ACNS. So the training is especially the developing places. So different timing and training in each country. So need for more achievement in neuro-oncology and spine surgery, which was conducted nice workshop this morning, and skull-based surgery and vascular surgery, endovascular surgery. So the important thing is those young doctors come to the outside of the country, but I think most important thing is the study or brush up their skill in their country. So training within the country is the most important. So the lack of the operation rooms and the nurse radiologist and the neurologist and the neuroanesthesiologist, and also the equipment shortage, of course, the microscope, and also the ICU, those system they still need, and also, of course, excellent centers. So still many things is lack for their improvement in the future. So on the other hand is the developed the places already the artificial AI is a lot of AI is come to in the neurosurgery, the robotics, so many so on. And of course, we know how nice or the advantage or disadvantage of the using of the AI. So the weekend prediction have of the future intracranial pressure it's amazing with AI and the robotics, and so now is just this time also we cannot do the live the educational course, so the simulation training is another very important. So it's coming very advancing now. So these very high tech and high advanced the virtual image virtual training is now is coming up. This is a virtual operation theater. So I think these things is maybe we should involve in the future educational program. So this is Dr. Kano. So I asked Dr. Kano come to give us some message, but he said that he engaged to write some books. So he loves to have such a the educational meeting. So at that time, Professor Yasajil was the chief guest, and also the guy from India, and also Dr. Sano. And also, I appreciate Professor Franco Salvadai. So this is foundation. This is a kind of model of the ACNS. And this is a little bit the older one, the Franco, the few years back. His message was very important, very impressive for us at the time. So there's so many the top leaders who lead of the foundation, and this is a latest young doctors teaching course. So just before the teachers, I think they learned a lot from the teachers directly. So that is their dream, I think. Of course, the video learning is another good purpose, but this is a totally different. So this is a live surgery. They joined the operation theater. And this is when we went to the Africa, Zimbabwe. So the African doctors, young doctors are very bright, and they learn a lot. And also another important thing is among young doctors that they can have some discussion among them. So that is another very important. Not only the young doctors, of course, we can invite the medical students. So this is the live. I ask a pentero microscope from Zeiss. They touch such a big, the nice microscope, real first time. And this is hands-on. So I think for education is still ongoing, and also I think a bright future with connection with WFNS or ACNS and ANS or CNS, etc. Thank you very much once again for giving me the chance to talk this inaugural session. Thank you very much.
Thank you.
Thank you.
Thank you, Mr. Kato. That was wonderful and very inspiring for young neurosurgeons. And we know that you have spent a lot of your life on education, especially of young neurosurgeons and also women in neurosurgery. So thank you very much, and it has been a great honor listening to you. I next call upon Professor Eka, who's a good friend of ours. Professor Eka is the Professor and Chairman of Neurosurgery of the Siloam Hospitals, Indonesia, and the Dean of the Pelita Harapan Medical School, past President of the International Conference of Cerebrovascular Surgery, Asian Oceanian Skull-Base Surgery, and the Indonesian Neurosurgical Society. Professor Eka, could you please come forward with your talk?
Thank you very much, Professor Cressida, for inviting me. Really great meeting. Thank you, Yoko Kato, for our chance to work together since the beginning. So let me share with you also a couple of my experiences. Some is a bit doubling with Professor Yoko Kato's slides, but okay, I just want to share with mostly young generation, because young generation need to know the history and the mission. Always there is positive things in the mission, then we need to know, and again we need to apply during our lifetime. So again, history and missions about Asian Congress of Neurosurgery and some part of ACNN, but not much about that. So Professor Tetsuo Kano, as mentioned before, he had a very simple reason, very simple things to say with us at the time. There is an unfair situation between developed and developing countries in Asia. So maybe at the time, developed country is Japan, Taiwan, Korea, Singapore, but other is more in developing and even underdeveloped, which influence also the neurosurgical development. Professor Kano concerned a lot that many young neurosurgeons in developing countries, underdeveloped countries, never got a chance to attend and participate in international seminars. So actually what is beyond that, that in his mission, that neurosurgeons in Asia have to join together to reach global standard by working together hand in hand and helping each to other. So he said also, it was also start to become difficult to seek a help from other developed countries. So Asian countries has to work hand in hand. And again, this mission, even for me, was so simple, but this really influenced a lot. And mostly in the Indonesian development of neurosurgery, I will share to you after that. I believe in other countries in Asia, also a lot of positive things and an impact, even from the simple things from Tetsuo Kano. So this is again, like Professor Yoko Kato said, that 1993, actually the name is Neurosurgery Update for Young Neurosurgeons, so-called the NUINA, right? And then after that, the second NUINA in Sapporo and third NUINA in Osaka. And then among that, we call it Asian Congress of Neurosurgery. So first neurosurgery update in NUINA is in the Toyota Motor Training Center. I remember very clear in my mind, yes, 2 to 7 November. So Professor Kano, he is not just a neurosurgeon with a golden heart. I know that before 93, he visited many times, many countries in Asia, including in Indonesia, and doing something, helping them, motivate them. And then the peak is in 1993. So I called him, really, he is the man with a golden heart. Not many prominent professors from developed country has a golden heart, pay attention to other developing country, but he really has the golden heart. And he also a great entrepreneur. So even he has a golden heart, but without entrepreneurship, maybe he also could not do so many things. So at that time, he told me very clear that he, as an entrepreneurship, he has a very good relation with the Toyota motor car company. And then finally, they sponsor the first Nuina in Toyota. So we remember all together of us, I think it's about 200 something in Toyota Motor Training Center in Toyota City. That's really because he is a golden heart and also he's a good entrepreneur. So without that, I don't think that anybody has that big money, because at that time, you know that I think more than 200 neurosurgeons, I really forgot, came to Toyota City with a full sponsor. You can imagine this is the first time also for me that all ticket, accommodation, meals, everything paid by the committee. It's unbelievable. And that's, I think, the first time, I don't know in the world, but in Asia at least, that a provisor has to pay attention for the young neurosurgeon to be treated like this. He was correct. So without the such kind invitation, that I think that many of them that still stay in the country and they don't know the development of neurosurgery outside of the country, but he invited with a full sponsor. It's unbelievable. I think this is really the first time. It's need a great effort of him and that time with all associates, including Professor Kato, that influenced us until now that the typical things in Asian conferences is that we help a lot in the young neurosurgeons. We never heard that other countries doing this. So I remember that we just came in the airport. Professor Kano came to the airport and welcoming us. It's unbelievable. Such a great man like him. So this is Professor Kano with other young Indonesian delegation and other phenomenon at the time. You remember this is a young guy from Turkey, Baskaya, I remember. Yeah, he is from North Carolina. And that time he was invited as a Sugita scholar. So I remember that Professor Sugita also invited Professor Kano to give lecture in the Nuina, and he bring also the scholar. So that's also another phenomenon. Beside Professor Kano, also Professor Kenichiro Sugita. He has also a lot of money from Mitsuho company because he create many tools and many equipment, and he invite also many young neurosurgeons from all over the world also to sponsor him and develop so-called the Sugita scholar. So I remember these two giants from Japan at the time. So this is the second Nuina in Sapporo. I remember I was observed when Professor Kano approaching Professor Kazuo Hashi and then to get how to find sponsor. Of course, Professor Kano still sponsor from his internship with other to make a second time in Sapporo. And we remember there's also many members coming. This is Professor Kazuo Hashi, and this is also ladies program. Ladies enjoy very much, brought by Mrs. Hashi at the time. So this is the so-called actually the first Asian Congress. It was by Professor Past Iftikhar Ali Raja in Pakistan. I remember this is Balaji, this is Professor Fukui, Professor Ali Raja, also the founder. So in 1997, I moved in the new hospital at the time, the Kot Siloam, and Professor Kano and Kato came to visit us and go to the OT and doing surgery, teach us so many things. It was 19 January 1997. This is the hospital, just a soft opening 2 months. I remember for that. And we start to do operation on AVM, aneurysm, as this is our nurse. And at the time, we thinking also about how nurse also began. Then finally go to Chennai. We remember that many nurses also. So this is So let me share with you about development in Indonesia, because this is the exactly detail. This is also again influenced by the good heart of Professor Kano and Kato at the time. This is in 96 when we have a soft opening so-called Siloam Hospital in Indonesia. So at that time we are also quite simple. And then now, after his interns coming to this my hospital, and was now a day. And again, at the time, many times, Eka, you cannot work by yourself. You have to build a team. Then I trust him. Finally, we built a team, and now we have a 26 neurosurgeon with me in a team serving Siloam Hospital in a whole Indonesia. So they just really inspired by him when he came. So again, this is Indonesia. So huge country with 70,000 island, and we have now 40 hospitals, and we have 26 neurosurgeons. I put all in whole Indonesia, and we work in a team, in a one control. Again, this is like inspired by him a lot. So even he did not tell anything to me, but I know that he really inspired a lot. So when he came the first time in '97 with Yoko Kato, you do believe me that many times he came, I was, Professor Kano, please bring me micro scissor, please bring me spatula. He is the man who cannot say no. He always considered, even he brought us at that time the first nerve monitoring for acoustic tumor. He gave us. So after 3 years, 1997, Professor Kano told me very clearly, Eka, you should not ask me anything since now. So you enough. So you have learned a lot, and you have so many experiences. That it's time for you not asking but giving other. Then since then I joined with Professor Kato in WNS Education Committee and others. So this is the really experience when Professor Kano and Kato came 1997. And after that, we doing everything ourselves. We developed and now becoming a 26 member in whole Asia, whole Indonesia, to serve neurosurgical team. And we fly to have our young team in a rural area when they have a difficult case, because we know that the complicated surgery, we need to work in a team, that we cannot, the young neurosurgeon have to assisted by the senior of us. So this is Osaka by Professor Tomio Oda, and this is Professor Kano with also another delegation. This is in Nagoya Marriott. Professor Yokokato was the president. And again, we are treated so well at that time. That's a really high standard served by her. And then the other president of the Acns had to do the same. This is Hong Kong. So Hong Kong officially President is Samuel. But actually the boss is YS Punwai. Professor Kano and then that the president much younger than 45. And because Professor Poon is older than he put Samuel under Professor Poon. So Professor Kano so consistent, has to be the president. After that, Indonesia, 2004, Professor Kano and Kato, and this is Nelson is there, and this is Sheka, and they are. He is my boss. So this is he is actually banker, and he is the one who built hospital. So young generation, if you want to work greatly in the future, you need to work with somebody, because we are professional neurosurgeon. We cannot do everything ourselves. We need a facilitator. So finally, we built a university with him, a medical school. Then we become a medical school of Pelita Harapan. So again, if you want to fly and you don't have wing, we need to work and write another. So again, I told you that my boss is Mr. Riyadi. I have no wing. If I work only neurosurgeon myself, maybe yeah, just I do it away, I'm fine, but I will never be able to build 40 hospital with 26 neurosurgeon like that. So again, we need to work with others. So Professor Kano is a great entrepreneur. Then I follow his job. I work together with my boss to develop neurosurgery in Indonesia. Again, if I do myself, it's impossible, because we are doctor professional and we need someone to facilitate. So young generation, this is in a COVID situation. We know that I told you before, Indonesia is a bit different, yeah, because in our system we have here like we have a public hospital and private hospital. Public hospital all managed by government, and private hospital like mine We have a different system because here the system, the payment for the doctor is all fee for service. So, you know, in the COVID pandemic, almost many hospital non-COVID are closed down because they serve COVID. So really, that's really very sad because they cannot do blended. Blended is sometimes so dangerous. And then a non-COVID hospital is really suffering because patients don't want to come in this situation. They worry about COVID. So you know that in many countries, number of surgery drop a lot. Not only surgery, but ICU and another surgical processes are dropped. So here in Indonesia, we have a COVID fighters. My colleague, or maybe with a policeman, with a public figure that working to campaign about COVID. And we are non-COVID fighter. So we need to fight because again, private hospital in Indonesia actually about 60% bigger compared with government. But again, we need to fight because non-COVID, if they are not fighting, they will collapse. Because again, normally money coming from the patient contribution. So no patient mean they are collapsed. Many of them already collapsed. So what I do right now, well, you know, we are very busy now having like a webinar, seminar, convincing people that we are okay, we are non-COVID, don't worry to come finally like that. So again, we work very, very hard to make the patient trust us and come again to the hospital. So this is Indonesian situation. And again, without that, we also collapse. So again, what we learn in this COVID situation. So we cannot travel everywhere. And also another foreigner colleague cannot come in Indonesia. I talked with Indonesian neurosurgeon that this is the time for you all to show the people that you can do everything and you show your competence. Because Indonesia also, when the beginning of the COVID pandemic, we cannot fly even intercity. So neurosurgeon in every cities, they have to work professionally with a high competence because they need to be very independent. Should not depend also other people because of the situation COVID. So again, this is what's happening in Indonesia now that even we are very busy here. I cannot come to even webinar many times in international because Indonesia, we do many things to talk with the public, to talk with the doctor that we are okay, non-COVID hospitals still fighting and well, we do our best. We know that we are also in the hospital, don't worry too much. Again, otherwise we also collapse. So again, what the mission of the ACNS for young neurosurgeon, young neuro nurses, that again, what Professor Kano did, again, is really great. Yeah, he is a man with a golden heart, and he is a best entrepreneur. So this is what I have learned from him, and I also practicing following his action. And he, after I think about half of the period, has never appeared again. I asked Professor Yoko Kato, where is Professor Kano? That is him. Once he did, he never go again. He don't want to see again. So he enjoy maybe with the family, with the grandchildren, and very seldom now to see him. That's him. But again, what he did, really that young generation need to learn. This is really with a cold heart. So helping each other is his mission. So again, we are in an Asian country. We should have fun to each other. We can come, we can motivate, whatever. So this is something that we need to learn from Professor Tetsuo Kano. And this is really something that the mission, the vision, the inspiration from Asian Congress, which make us different with other congresses from developed country. So every time we do Asian congresses, we always help one to other. We always ask the committee how many young neurosurgeons you can come, you can sponsor to come. Because again, this is important. This is still happening. The disparation in about income countries in Asia still different. Some still suffering, even cannot go abroad and still sick more than enough, again, we need to work hand in hand. So again, for the young neurosurgeon, young nurses, this is the most important mission of the ACNS. We should keep it until in the future, because Asian Neurosurgery Society, I think, is unique and still need a long, long way to go to all developed countries. So I thank you very much for Professor Cressida. Thank you for your attentions, young generation.
Thank you very much, Professor Eka. Thank you for that wonderful talk on the mission of neurosurgery in Asia. I can see that you really enjoyed the coming to Chennai, and your video showed that. Yeah. So I would now like to invite Professor Franco Sarvadei, who's the president of the World Federation of Neurological Societies. He is professor of neurosurgery at Milan, Italy, and till recently was also the chairman of the Neurotrauma Society Committee of the WFNS. And Professor Franco will be talking to us on COVID-19 and neurosurgeons, a worldwide perspective. Professor Franco, please.
Dear Professor Sridhar, dear Professor Kato, thank you so much for the invitation. The World Federation of Neurosurgical Society has always been working together with the Asian Society of Neurosurgery. I was personally in Surabaya a few years ago, invited by Yoko, and I remember that this was a very important experience, a lot of education for young neurosurgeons. So if I can share my screen now, I will show you. Okay, can you see my screen and my voice? Everything
yes.
okay?
Yes.
Okay.
Perfect.
So I will give you some worldwide perspective of what's going on in the virus time and neurosurgery. This is the screen of yesterday about the COVID diffusion. You see that the most heated countries are US, Brazil, India, then we have Mexico, United Kingdom, France, Italy, and so on. So you see that many countries in the western part of the world are terribly hit, but also India and some part of Asia, Indonesia included, and so on. So, and South America. So we have quite a worldwide diffusion of the virus. How did we react as neurosurgeon? If you look at the articles published in newspapers about COVID, you see that at the end of October, we already have 70,000 papers published with a distribution of the publication not usual. The usual one is that the United States alone will have about half of the publication. As you see, for COVID, this is not the case. Many other countries contributed. And in neurosurgery, this is a paper published by our colleagues at the Journal of Neurosurgery. You see that if you compare the number of papers sent for publication in 2019 with 2020, you see that the publication doubled. So many neurosurgeons felt that they should publish about our experience with COVID. And these are the most publishing countries. Again, the United States have contributed 25%, whereas usually the contribution of the United States, you see it here, is over 50%. So we did have a lot of articles published in the world, about neurosurgery and COVID and about the reaction that we had. If we want to see how do we work in the time of COVID, we have 5 important surveys published. One is coordinated by US, but is including many countries in the world. Another one is a first European collection of data. Then is another worldwide study coordinated by Professor Gandour from Egypt. Another European study, a most recent one, an African study already published just a few weeks ago. So we have 5 studies. Basically, these surveys are telling us the same, unfortunately. Most of our hospital, in spite of the fact that COVID was already in many other countries, were not enough prepared to face COVID. As you see it here, in the vast majority of our hospitals, the elective surgery suffered, and in over 70% of our hospital, 3/4 of elective surgery was stopped because of COVID. So all over the world, the COVID appearance has impacted deeply our activity, and also the surgical indication changed. This is a European study where they faced the same case before and after COVID. And for instance, for glioblastoma, the surgical indication are changed as for spine surgery. And another important fact is the cancellation of scientific and research activities in person. We will see that most of this education was transferred in the web. Then we have another issue, which is that many young neurosurgeons were reconverted to pneumologists. This is the experience in my countries, in one of the most hit hospitals. And you see that very quickly all the neurosurgical staff was reconverted to pneumology, and all the beds in neurosurgery were closed. And this is also the experience of our American colleagues, where it was published a suggestion from the joint section about how to treat the pulmonary problems of COVID patients on the side of neurosurgery. So many colleagues were reconverted. Then we have to consider that in this difficult situation, we kept alive neurosurgery. This is what we have done, is a system of hub and spoke. We closed some hospitals and we transferred neurosurgeons to hub hospitals where they operated more cases. So we have concentrated neurosurgeons and patients into few hospitals and move patients and neurosurgeons. The same happened in India. You see it here. This is a paper from New Delhi, where they have considered using the same structure that we have done. Then we have seen the changes all over the world in training. This is US and Canada. You see that over almost all residents had their education reconverted to electronic platforms, and they have reduced the number of weeks of presence in the hospital. In Italy, you see it here, we have organized a nation-based program for training on the web. So the 24 residence programs that we have in Italy joined together to have a common education on the web. And you see that we had a very good participation of neurosurgeons. The same happened, you see it here in India, where all the education was reconverted via web. Indonesia, Malaysia, Singapore, and Thailand had the same experience, reduction of training hours, and at the same time, increase of web lessons. And you see it here In Africa also, it happened the same, but we started to see a positive message here. The residents in Africa like very much the webinars, because in the webinar, they had the opportunity to be exposed to the best expert in the world, which didn't happen before. So, and if we look at the survey done by Key Park and this group in young neurosurgeons, you see it here, they ask us, the World Federation, what can we do after the post-COVID in education? And they ask a common curriculum, they ask virtual laboratories, and they ask more collaboration, as Yoko Kato and Eka have said before, between countries with more resources and countries with less resources. As the World Federation of Neurosurgical Society, what we have done, we were the first worldwide society to stop in-person meeting in February, at the end of February, beginning of March 2020. So we encourage webinars and we stop in-person meeting as soon as possible for reason of safety. So the basic concept is that what we are doing now, we have been doing before. It's nothing new for the World Federation. You see that this is a webinar done online in 2018, well before the pandemic, and we already have over 1,000 contacts on YouTube. And these are webinars of the Spine Committee already done before the pandemic. So before the pandemic, the World Federation was already using remote education. And these are just examples of what we are doing during the pandemic. There are more than 300 webinars organized all over the world with the support and the sponsorship of the World Federation. So, but what did we miss? What Yoko showed you, that we need in-person education, like surgery, like cadaver lab. As you see it here, cadaver lab are missed. We cannot do any cadaver lab anymore. And we also miss live surgery, because we need, for patient safety, to learn on the site. But as Yoko also has shown, we need to move now in this difficult situation to a sort of 3D simulation, which is important for education. And we published already in 2018 a paper on how can we teach from remote, how can we use digital teaching to replace the usual teaching. You see it here, you see here, this is an anatomic approach done for education via an iPad. And so just to finish my presentation, the future will never be like the past. We have to consider that things are changed. Even when pandemic will finish, we will have to employ what we have learned in this period. First of all, we understand that first we are doctors and then we are neurosurgeons, and this is important. The second thing is web-based education is free and can reach any neurosurgeon in the world. These are some of the messages I received in a recent meeting: Uganda, Libya, Yemen, Khartoum, Congo. So you see that these neurosurgeons will never be able to fly to a meeting far away. So this is important. Education is here to stay. Then our residents learn how to prioritize surgery and to keep emergency surgery alive, and they also learn to work together with other universities. Just to finish, I suggest you all to go to Neurosurgical Focus, where we published recently a full issue about neurosurgery, and COVID. And as you see, the editors were from myself, Miguel Arraez from the WFNS Foundation, Professor Chen from China, Professor Golfinos, and Mahmoud Qureshi who is here with us. So we had a worldwide exposure. So thank you so much for your attention and the comprehension for the difficulties that neurosurgery is now having all over the world.
Thank you. Thank you so much, Professor Franco Sarvade, for that excellent talk and bringing into focus what has happened to neurosurgery and neurosurgical education in these difficult times. Thank you very much. I now would like to invite Professor Anil Nanda, a good friend of ours, to deliver his talk, a very interesting topic for neurosurgeons. He is the professor and chairman, Department of Neurosurgery, Rutgers, New Jersey Medical School, and Robert Wood Johnson Medical School. Professor Anil Nanda, please.
Can you see my screen? Can everybody see that?
Yes, we can see your screen, hear you well.
Well, you know, after Franco gives a talk, I feel like, you know, I'm following Placido Domingo or some superstar like that. So thank you, Franco, for your leadership during this difficult time. Thank you for your equanimitas during this difficult time. I think the world has not seen a time like this since World War II. So it's a very, very serious time for all of us. And we appreciate the leadership of the WFNS and the community of neurosurgeons in a meeting like this that reminds us that we're all family, that the world is flat and we care for everybody. So I thought I'd speak about complications for younger neurosurgeons. And this is actually, the title has been taken by a new movie about difficulties, often, sometimes, rarely, and never. So this is a Japanese proverb that I acknowledged for Yoko Kato, and it says, you know, we learn from victory. We learn little from victory, much from defeat. And much like COVID, I think we had a lot of defeats, and I think we learn from these things. And I think, you know, everything, all the wisdom in the world can be found in Shakespeare or in Dante. And in Shakespeare, he says in Hamlet to Polonius that this above all, to thine own self be true. It must follow as the night day that thou cannot be false to any man. And I think the integrity of our reporting and our complications is very important. I always tell our residents that the DNA of a department is how your M&M is run, how your complications are presented, what's going on. That becomes really, really important. This meeting's being held from the city of Chennai, which I've had very fond memories of being at. The Kural is the great book of wisdom by Tiruvikkular. So thank you so much for organizing this. And I myself trained in Pondicherry. I went to medical school in the South there. So I've been in Jipmer with some wonderful teachers. Professor Chandrasekhar was my mentor, and he actually lives in Chennai. So a great time to acknowledge. And I again want to acknowledge the wonderful work that has been done by the ACNS, and I think it has created educational opportunities across the globe, for which we are very, very grateful. You know, the leadership of Yoko Kato, Professor Kano, Himad, Eka, Aip, all of you, very, very appreciated. And again, this meeting, thank you for doing this, Krish. I know you Sridhar put a lot of time and effort in it. And Bala and the whole group, Rupesh, everyone did a great job. So thank you for doing this. I really appreciate it. And on behalf of the US, you know. So I think you need to talk about COVID, and Professor Sarvade gave a really brilliant talk on this. And you know, the problem persists, but what can we learn? I think in terms of complications, you always learn what went wrong. So this was the New York Times said, you know, where did we go wrong? I mean, we had the highest mortality for any country in the industrialized West. And it was ventilators, testing PPE, hospital coordination. So we didn't do too well. In a sense, that was a complication. And, you know, but I think from any crisis you learn. You know, if you look at the Great Renaissance, it comes after the plague. You look at even these pictures from what happened in the American colonization. Smallpox was genocide for the United States native population. So those are things we learned from, and hopefully from all this, we will get better at what we do. This was just The Economist, where they talk about hope in the vaccine. I know at our hospital next week, the vaccine will be released to the high-risk players. So I've been fortunate to have done close to 18,000 surgeries, about 6,000 craniotomies, and I'm blessed that I can talk about things that go wrong. So that's why I thought I will speak about that. And I think when you have failure, whether it be COVID, whether it be an operating case, whether it be our personal life, there are three kinds of failure. There's a failure to learn, a failure to anticipate, and a failure to adapt. And Icarus from the great Greek legend taught us he flew close to the sun and the wax melted his wings. So I think hubris is something you need to be cautious about. The Sanskrit word ahankar is very important, that we don't take for granted what we can do and how we can get better. So I thought I'll talk about often, sometimes, rarely, never. So when you look at often, this is a young kid I just did 2 months ago, was herniating, blown pupil, an AVM that had been treated in China, then was treated here, was embolized, and she blew this, and we watched her for a week. And you can see the surgery we performed. It went very well, but she had a blown pupil. And I removed the entire AVM. We took the clot out, and the brain looked beautiful when we were done. So we felt, wow, maybe we've saved her. But when people have a blown pupil, be it trauma, be it AVMs, your success rate is not always great. So here it is, even though the surgery went really well, everything went well. Here you can see the last bit of the AVM, a complete resection. Brain actually looked good. But this patient didn't do well because actually a mortality. And you can see the entire lobe of, we had a post-op agram, but then she went to infarct the entire hemisphere and she went on to pass. So when you operate on high-risk patient, blown pupil, there's some patients you're going to lose. So that does happen. But what about sometimes? Sometimes probably you can include things like infections, CSF leak. Here's somebody with a spinal cord tumor with brainstem symptoms. You can see there's a syrinx that goes all the way into the medulla. And this was relatively in the cord itself. And you can see here, we're taking this out from the cord. Nice plain, it's actually a hemangioblastoma in a young student. And in a case like this, so I showed you a mortality, but something like this one fortunately did well. And we got a resection, and let me just move this. And you can see the whole thing was removed. And so I think this one did well, but we looked at all our spinal cord tumors. We had about 250, and we looked at resection rate, and things can go wrong. This was an ependymoma that I removed. I got a complete resection, and the patient postoperatively was now moving her legs. So like for 3 days, she was paraplegic. Anna Akhmatova is the Russian poet. When World War I starts, she says, in a single hour, we aged 100 years. And I want to tell the young neurosurgeons, you will get complications sometimes. In those 3 days, she did nothing. On the 4th day, she started moving her toe, and then she got everything back. But in those 3 days, I aged a lot, and those are the complications that drain a lot out of us. She subsequently did very well, went on to have another child. But, we lived through 3 days when we were like, oh my God, we took out a tumor on somebody that had mild weakness and then was, potentially paraplegic. So these things will happen. It's another case of mine recently, had a C1, C2 fusion done elsewhere. You can see this complete subluxation there, had a fusion which slipped. It got worse. This guy was a personal trainer. And you can see here the cord is completely compressed. He was quadriparetic. So we went in a transoral on him. And I thought we did a great job. We drilled all this out, went in, and you can see we were able to remove this from taking all the odontoid off. You can see it's off the dura completely. The one thing here I was really cautious about, I did not want to have, was a CSF leak. So we were really careful. We left a small piece of bone. Here we're closing the transoral opening. And so he does well. We thought, oh, wonderful. So we get this. He's in the ICU, and he got function back, and then his paresis got worse again. And we rushed him back because he'd slipped from the back. So we went ahead and fused him. This is just to show you the resection. Did an occipital-cervical fusion, and he's back completely normal. So these things will happen, and you have to adapt. So you get a complication, you can say, oh my God, why did this happen? You fix it, you move quickly. Very simple thing, something like CSF leaks. Okay, under a laminectomy, this happens, all right? So people tell you, oh, my CSF leak rate is like 1%, 2%. We did a prospective study when I was at LSU, and we showed that in our training program, it was almost 15%. Now, there was no morbidity from it, didn't have extended stay, they did very well. But it's a legal issue sometimes, and we'll talk about medical legal, like, wait a minute, what is the number? And so I do not think you can say 1%. We feel that it's more significant. How about rare complications? Complications that you say, geez, this does not happen that often, but it's important to address. So this is a dermoid in a young girl. She just had a 6-month-old baby, had bad headaches, and we operated on her. So you can see this, the video, this was about 5-6 years ago. The quality of the video is not great, but we all agree dermoid is a simple operation. This should not have any complications. At least everything should go well. So here it is, we're taking this out. This is not a technically difficult operation because it just comes out, it's very soft. And so here it is, we're on the right side, we're taking out this tumor with no issues at all. And so I'm medial to the carotid and picking out more and more tissue. And then I go a little bit deeper in that area, and you can see the optic nerve there and pulling stuff out. Very simple, no false moves. All this is freed up pretty well. There's no force or anything like that. Carotid on that side. And then you can see I'm going now onto the contralateral side, and you will see here, I go in right away, and we're taking it out. And here it is, you get a rupture. So I don't know what happened. I was like, I can't tell what's happening here. So we put some flow seal. We put a piece of gel foam, tried to get hemostasis, and tamponaded it really well. And then the issue is, what should you do once you control this? It was a fairly large cartilage. So here it is, we put more pressure there. And the problem is this is contralateral, so it's kind of a little more difficult. At least on this side, you could see. I love Flow Seal. It's like a vitamin. I just put it there, and I said my prayers, and I was like, okay, I hope this stops. And it stopped, and the issue was, should we have continued or not? Or got an agram or what? So what I ended up doing was, it stopped completely. I took out the rest of the tumor. I was like, that's what we're here for. We took out the tumor. And she actually did very well, but then came back with a subarachnoid hemorrhage, and she had an aneurysm on the other side. But we coiled it, and you can see her with her baby. She's actually done very well. But again, these are the anticipated. You don't see them, but you need to be conscious of them. My career has been based on skull-based tumors, and I always like to talk about the complications because, I've done several hundred of these, and yet it's easy to claim the glory and not talk about the failure. So this is our petroclival meningioma paper. So this is a young girl that I just did 2 weeks ago with a trochlear schwannoma. I thought it would be a petroclival meningioma. And you can see here, this is the tentorium, and we're dividing that. This is the 7th and 8th cranial nerve. We're going superiorly. This is above the cerebellum. So we're doing almost like a supracerebellar approach. You'll see the trochlear nerve here in a minute. And it's a young girl, there's a trochlear nerve. And I thought going in, this was going to be a petroclival meningioma. But it actually turned out to be a trochlear schwannoma. So again, as you know, even though we get complications, I think the art of microsurgery, that, you know, to be very, very meticulous and careful is still very important. Here you can see the nerve coming on the other side. I'm peeling it off now, the trigeminal nerve. So we got a gross total resection on this girl. But what I think is, for complication avoidance, that technique and the anatomy is extremely important. Yeah. Here now you can see we're coming off the last part. There's the brain stem. And we got a gross total resection on this. She did very well. And so I think, as bad as complications are, the technique of fine microsurgery of anatomy is what prevents us from having disasters. Here's somebody with a large trigeminal schwannoma. Same thing. Again, going in. Here you can see the petrous bone tentorium tumor being resected. Similar type, but what I'm trying to say is that, you know, I don't want you to think that everything is a disaster, but I do think being in that arachnoid plane, learning these things prevents complications. So I do feel being a superb technician does help. I mean, that's why Professor Sami has done 4,000 acoustics with very little morbidity. So I think that practice, that anatomy is extremely important. And this patient did very well. So I like to talk about the art of technical virtuosity, whether you're a musician, a painter, a swimmer, a golfer, or even a cricketer. I think, you know, Sachin Tendulkar was a great cricketer. It was technique. So I do think we must worship the art of technique to avoid complications, to be meticulous about detail, and not leave anything to chance. This is my own series of skull-based surgery, and you can see my complications are significant: visual loss, hemiplegia. This is about 800 cases. So we'd like to talk about this. And I think the one thing, this is an editorial I wrote about the petroclival meningiomas, resisting the siren song. When Odysseus goes through that and he can hear these sirens, he tells, tie me up, because I want to resist this. So that you have to be cautious when to stop, when to proceed. Very, very important to balance the risk to avoid complications. Here's a petroclival meningioma I did on ER physician. So I did about an 80% resection, but he never went back to working in the ER. He had some speech issues, lipopraxia. I mean, he had a meaningful life, but I don't want to have the hubris of saying, oh my God, I did a great job. So I think that balance is very important. I'll now address the last leg of these complications, which is never, the never events that happen. It's like, oh my God, this will never happen. And it does happen. So you need to be mentally prepared. I can handle this. And you can say, oh, this doesn't happen to other people. It can happen to any of us at any time. And I think that humility is of such paramount importance in neurosurgery that you can confront this and say, yes, this can be fixed. Yeah. So wrong side, okay? You do an operation on the wrong side. That's a never event. That should never happen. So here's somebody with a subdural opposite on the other side in another institution. And why does that happen? In my career, I've seen it happen 4 times at the institutions I was. It's a communication breakdown. There's inadequate preoperative checks and technical errors. I remember I was in practice. This is good for the younger nurse. I was in practice about 3 years. Taking out a cerebellar mat, I made an incision on the right side, and the intern comes up to me. He said, Dr. Nader, this tumor is on the left side. How are you going to get it from the right side? I'm like, oh my God, I made a mistake here. So we closed him up, turned around, told the family, patient had a good outcome. But I think that vigilance is something that's very important. Now, when you look at wrong level surgeries, I mean, this happens in terms of cervical and lumbar disc. 45% of neurosurgeons will tell you that we operate on a wrong level. We picked it up. I've done 2,200 ACDs. One time I took off the wrong level, but I picked it up and I fixed it. So in the best of hands, this will happen, and you have to be manic. Now, we do know the conditions that cause these complications: fatigue, time pressure, emergent operations. We make errors. So it's like pilot errors when you're flying. Now you can say, okay, the Mass General, best hospital in the world. This was a case report from the Mass General Hospital where a prominent orthopedic surgeon operated on the wrong hand. This can happen at the Mass General, it can happen anywhere. So I think this vigilance of not operating on the wrong side is very important. Basic things. This is a kid that died in New York getting an MRI with iron cylinder went right through the magnet. And the same thing happened in the city of Mumbai, I think a year and a half ago. Again, these errors need to be cautious. I did a lumbar disc on somebody who was really very heavy, and I had more bleeding than normal. Post-operatively, he was fine, but his hemoglobin kept dropping. I got a CAT scan on him. He's got retroperitoneal hematoma. We get an agram, and you can see he had this large pseudoaneurysm, which we were able to stent. But this ronger is very dangerous for getting lumbar. I've seen 3 lumbars. This is a young girl that had a lumbar disc done at our institution, and she was dead the next day. She had a retroperitoneal hematoma and died from that. And the thing is, when you want to write about this, sometimes, I remember trying to talk about our iliac aneurysm, and they said, we don't want to do this. The plaintiff attorneys love this case. I'm like, this is the truth. This can happen to anybody. So again, it's a never event. Now, I wrote a whole book on complications where we looked at things we could prevent. But this can happen not just with surgery. This happened in Chicago where they had a new radiosurgery machine. 6 patients with trigeminal neuralgia were given 10 times the dose for trigeminal neuralgia. And within 6 months, they were all dead because their brainstem was cooked. Tragic incident, but again, error that is preventable. So I think we need to be vigilant. I look at my vascular series. I've done over 1,000 aneurysms, and this just happened to me. This is a 71-year-old male, an ACOM aneurysm. Beautiful operation. He was 71. We had everything gone. And I can just play this. It's a very straightforward ACOM that they did not feel could be coiled easily. So we went ahead and clipped this. It's a right pterional approach. So here you can see we can putting the clip right across the neck. Very straightforward operation. I clipped this in about an hour and a half, no problem. Everything looks beautiful. Everything was fine. He went home post-op day 2. Post-op day 5, I get a call. Patient has massive chest pain, had a massive heart attack. Goes into the ICU, has cardiac arrest. No real technical error on our part, but this happens. And I think that's where you need to be vigilant, that in the best of hands, things can go wrong. And our goal should be primum non nocere, first do no harm. So I think we need to have that balance, we need to have that humility, and we must confront these complications and say, listen, how can we do better? Now in the US, this is a big issue with malpractice. This is billions of dollars. So I think this is a problem now that's becoming global, but I think we need to be vigilant on that. And how do we prevent complications? I tell the younger nurses, go to the lab, learn your anatomy really well. Anatomy is still the key. You can go to the online atlases of Roton, learn that anatomy because that's what will bail you out. And if you think you're having a really bad day with complications, this is Robert Liston. Robert Liston was a 39-second man. He could do an amputation in 39 seconds. He did an amputation in 39 seconds. The patient died. He cut his assistant's finger. That patient, his assistant died. And there was an onlooker who fainted and passed out and had a heart attack. So 3 people died with 1 operation. You think you're having a bad day? This patient had 300% mortality. So Chuck Yeager was the pilot. I want to end with this. Herman Melville wrote the great the book on Captain Ahab with Moby Dick. And he said it is better to fail in originality than to succeed in imitation. He who has never failed somewhere, that man cannot be great. Failure is a true test of greatness. And I think all of us have complications, and that's how we get better. And safety is important. Chuck Yeager just died, the legendary test pilot. He broke the sound barrier. And he said, I always learned everything that I could about my airplane and my emergency equipment. He tried to prevent a complication. And he always said, I was always afraid of dying, always. So all of us are afraid of complications or mortality, but we have to get better. It's been an honor and privilege to address you. I want to thank the organizing committee, and I wish I could be there in person, but this was the address that Harvey Cushing gave. He said, there's only one thing that can effectively bind people, and that is a common devotion. And all of us are devoted to great outcomes, to outcomes without complications. In the time of COVID, we've really become a flat world. Even though we cannot meet in person, the great Indian parliament has a wonderful saying out there, Vasudevaya Kutumbam, which means the whole world is a family. And in a time like this, I think all of us are family. Thank you so much again for the privilege of allowing me to speak to you. And I wish all of you health, safety, and as my little nephew says, stay positive and test negative. Thank you very much.
Thank you so much, Professor Anindanda. It was, as usual, a wonderful talk. Thank you very much. We now move on to Professor Borba, Professor and Chairman, Department of Neurosurgery from Brazil, who's going to talk to us about the temporal bone. Professor Borba? Yes, please.
Yeah. Hello, everybody. Once again, thank you for the opportunity to be here. For me, it's in the morning. Now it's 8 a.m. A great pleasure to watch and listen all the presentations. Is this opportunity that the pandemic gave to us to bring all the world together. And you can watch and see the masters from the whole world, from the many ways to see the neurosurgery, many ways to see the world, and many ways to see the life. And you are learning in every situation what to do as a doctor, as a neurosurgeon, as a human being. In this time that the whole medicine, the whole world is changing, the neurosurgeon also is changing. And the way that we see the neurosurgery today is different that we are used to see some years ago. But still, the real neurosurgery is alive, and the patient, the whole world are different. I'm going to quote here Professor Cano, had a great mind and wise idea to join all the countries from the Asia. They are so similar, but so different. Not only in economic issues, but the patients are different. The tumors are different. The situation that you face are completely different. Maybe the difficulties that you have to treat a patient in Bangladesh, in Indonesia, in Brazil, in Bolivia, in Mexico, in US are completely different. And our world is just one world, but with completely different way to see and to treat the patient. My passion by temporal bone started in December 24, 1993. I was arriving to Little Rock, Dr. Al-Mufti. That time there was no lab. And Dr. Al-Mufti told me, you should learn temporal bone. If you want to do skull-based surgery, you should learn temporal bone. This is the route that you give you, the direction to the skull base. If from the temporal bone, my dream started in the skull base. This is the small lab that he had in the ENT department. The day was December 24th, just before Christmas. Nobody wanna give me the opportunity. That time, Dr. Omefti in the ENT department didn't have so good relations, but the chairman of the ENT was a great guy. He gave me the opportunity to go to his lab. And after Dr. Omefti organized the lab in the Department of Neurosurgery, and I ran this lab during almost 3 years. To do skull base, you should learn anatomy. To do skull base, you should learn how to reach the area. We just saw a wonderful presentation and very thoughtful presentation by Professor Nanda about the complication that you should avoid. But more you do, more you train, better will be your possibilities. You should go to the lab to learn that the temporal bone, there is a lot of anatomy to go around. If you drill the whole temporal bone, you show structures. The facial nerve, the middle ear structure, the carotid artery, the jugular bulb, the jugular vein, the sigmoid sign, the vertebral artery. In this area, there are some routes that you can use to reach difficult situations, as the petroclival area that I showed to you. We should learn that more you open, more you expose, will be easier to use sometimes, but not always you need. Sometimes you need, sometimes you don't need. We know today that the great majority of the tumors in the petroclival area can be removed by a simple retrosigmoid approach. It's a workhorse that we learn from the first day in the residence. But you should know the way to treat also. We should understand the anatomy of the area. This understanding of anatomy, you understand the pathology. You understand the disease. I listen in watching a lot of people talk about no way to treat jugular foramen tumor. You cannot do this. The patient will wake up with tracheostomy and gastrostomy. It's not true. If you understand the tumor, if you understand the clinical symptoms, if you understand the behavior of the tumor and the way where the tumor goes, your complication will be much less. And sometimes, or several times, the complication will be very, very, very low. Understand the disease. The most important to do, just a neurosurgeon, need to understand the disease, as Harvey Cushing was doing during his life. Today, we're seeing the petroclival area as still a no man lands, every man lands, some man lands. Now, new approaches, new era, endoscope, but the temporal bone from behind, from anterior, from lateral, is the route to be there. Now it's coming the endonasal. By the nose, no incision, minimally invasive, everybody happy, except the patient, because the tumor is still there. I bet you, if you find one case in Indonesia, in Bangladesh, in India, in Brazil, a petroclival symptomatic meningioma that is located just between the 6 nerves. Very small tumor. This is the tumor that can be treated by endonasal approach. Because this, let's stop to say about anterior approach, endoscopic approach to intradural tumor as petroclivomeningioma. You just bite the tumor. See, I call woodpecker surgery, you know, go there, bite, 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 and go home. No complication, of course, you didn't do anything. There are several ways to reach the petroclival area. One was developed, was created by a great mind of Professor Kawase. Professor Kawase found that if you remove the petrous apex, you can open the window to reach the upper clivus and until the level of the internal auditory meatus. And you can mobilize the fifth nerve, and work medial lateral. But you need to liberate the nerve to have all the extension of the tumor. No, do like this, just remove the apex and work for this small hole here. The anterior petrous approach is not only remove the petrous apex. The anterior petrous approach is do the peeling of the middle fossa. It liberates the fifth nerve. Is mobilize the fifth nerve. Is identify the sixth nerve. Is work in the posterior part of the cavernosine. This area is safe. There is nothing here. Oh, there is carotid artery. Yes, there is carotid artery. But if you study the anatomy, if you go careful, you find the carotid artery. Go careful. Go to the lab. Learn some tricks. I tell you a very simple trick for the young neurosurgeon. How to find the sixth in the cavernous sinus. Oh, how to find the sixth. Very easy. Just identify V1, the root of the trigeminal, in this place inferiorly. You find 6, you find the artery. This is fixed point. In skull-based surgery, the trick is not to try to find the structure between the nerves in the subarachnoid space. The trick is to find the structure where the structure are in fixed point that will not move. You find the third nerve there, you find the sixth nerve here, you know where you are. If you know where you are, you can go ahead. Many people, ours, of course, not everybody that talk about skull base should talk about CSF leak. It's a big issue. But before do any skull base surgery, before do any skull base procedure, before do any neurosurgical procedure, you need to think, how are you close this cavity? In the skull base is very important. Because this, you need to create flaps by the temporalis fascia, by the pericranium, by the temporalis muscle. This way you can rotate and close the cavity. Prepare to close. It's very important in skull base surgery. You have a patient like this, chordoma, you can come from the nose. Of course you can come from the nose. You can come here, you can clean. But what's the biggest issue in chordoma? It's not to remove the soft tissue. Soft tissue can remove by any approach. The big issue in chordoma is this here. Remove the bone that is around. Remove the islands of tumor that is inside normal, but it's not normal bone. Because this, you need approach that show you this area. Tumor like this, a small chordoma located totally inside the bone. We should do the surgery. You should do the peeling of the middle fossa. You should remove the bone. You should drill the bone that looks like normal. But if you continue drilling, you find islands of tumor. It's not surgery, it's understanding the disease. This is the most important issue in skull-based surgery. Just parenthesis here. Cavernosinus meningioma, the people always go there and remove everything. It's not the way. Today we know that cavernosinus meningioma, the tumor that is located in the cavernosinus, the natural history is much better than any kind of treatment, much better than the radial surgery, much better than surgery. Small cavernosinus meningioma. It means understand the pathology, understand the disease. Spread and pop off, we do the whole. The anterior petrosal approach is best designed for trigeminal schwannoma that give you the root, that you have the master trigeminal schwannoma here, Professor Go, I just saw him, his picture talking on the phone. Is trigeminal schwannoma the best way? Peeling of the middle fossa and go ahead. You get this and just follow the tumor. Just follow the money, you know? You wanna take the mafia? Don't look for the man, look for the money. And here, don't look for the structure, look for the tumor. Just follow the tumor. Sometimes you become more brave. 90% of the neurosurgeon in the world, you do this case by retro-seek. I think it could be okay, retro-seek. But in this case, I have the same idea. Let's follow the money. That is the trigeminal schwannoma, is from the trigeminal nerve. Let's follow the trigeminal nerve. That comes from the middle fossa. It's peeling left side middle fossa. Here the Meckel's case, there is small tumor in the middle fossa. You remove this part in the middle fossa. Now you drill more the apex to widen the area. See? You identify the root of the trigeminal nerve. You identify, see, the superior petrosal sinus will bleed. You can put Surgicel. You can put a little bit of glue, not too much. Not too much glue, okay? Liberate totally the 5, immobilize the 5, open the dura, and communicate the extradural part in the middle fossa to the intradural part in the posterior fossa. Your idea is follow the tumor from outside to inside. And did the dissection the same way that you do, you know, onion? Onion, see? Peeling, like onion. And the tumor will start to come to you. See? If you go and dissect around of this, I'm sorry. Okay, I go here. If you go around the tumor and liberate the arachnoid, the nerve, the remaining nerve, that not always remain 5, sometimes remain 5, you can keep some fibers, but leave the arachnoid for the structure. In aneurysm surgery, you dissect the vessels, the structure. In tumor surgery, you dissect the arachnoid. Look, the arachnoid and the 4th nerve, protecting the nerve. Leave the arachnoid to the nerves. Here the 5, from the posterior fossa to the middle fossa. What I did, just follow the anatomy. Just follow the tumor. In the end, you have this, the fascia of the temporalis muscle. You go down and close the cavity, and the immediate post-op, the patient is okay. It has a slide 6. See, I just touch the 6. We will come back. And the pre and the post-op. This pure understanding of pathology, understand of the disease, the behavior of the tumor, understanding the anatomy. Now came a big issue. What's the problem in this case here? The patient has few symptoms. Diplopia, slight diplopia, sometimes headache, and they got big tumor like this. And some people today say, no, don't do anything. Wait, do shunt. It's our mission as a neurosurgeon to try to do the best for the patient and to try to save his life. It's a mission as a doctor. This patient will die. He'll not die tomorrow. When they lose the plane here, you have edema in the brainstem, it's game over. It's our mission to go there and use the best way to reach. If you can do right by retro-seek, it's okay, go ahead, take it. If you can do by any kind of approach, okay, take it. But take the tumor. And more you train, less complication you have, more will be, better will be your results. Of course, neurosurgery every day is the day. There is one day that's more important than the other one. Every day is the day. And every patient is the most important patient. Treat your patient like this. The posterior petrosal approach that was developed first by Professor Hakuba in Japan. After came Professor Omefti that popularized and make understandable the approach. After came Professor Sami, a lot of people use. We use to perform a petrosal approach very often. Now I'm doing less and less, but I'm still using. Some patients need, some patients don't need. What cannot happen is I don't use because I don't know how to do it. If you don't use because you don't need, it's completely different. It's completely different. You have a case like this, you can come retro-seek. Okay, you can come, but there is part in the tentorium. And this is our goal, we'll go there, go straight, identify the structure. You see the vertebral artery, the basilar artery here, the fifth nerve here, the brainstem there, the lower cranial nerves here. See the labyrinthine, see the 5, but totally liberate the 5 that you can play around and go in the insertion of the tumor and try to remove not only the soft part, but always the attachment of the tumor. Do the best that you can. And the post-op, the patient had a 6 in the pre. In the post is the post-op. The 6 is worse than was in the pre-op. It's an immediate post-op. See, no hair here. 6. This patient didn't recover the 6. But I want to tell and ask for you, neurosurgeon that you see in your country tumor like this, you in India, Bangladesh, Indonesia, Brazil, every country, that our tumor is not a small ball, it's a big game. Is a very high price to get this MRI, to get this lady in the post-op, a 6th nerve palsy, is a very high price and save her life. You can fix this with ophthalmologic surgery. Is a high price? I don't believe. Oh, I know temporal bone, have to do petrosal approaching everybody. Look at this. Man, look at this. The tumors come down. The tumor is in posterior fossa. The tumor is giving the window here. Transpetrosal approach is the best way to reach it. No, no. The best way to read this is to understand where is the attachment of the tumor. The main attachment of the tumor was totally in the posterior fossa between the lower cranial nerves and 7 and 8. Here's the vertebral artery, lower cranial nerve, 7 and 8 is up. See? The main attachment is here. And this tumor can be removed like this. The patient cup is 7, but it came back. This patient can be removed safely by a retrosigmoid approach. Very simple retrosigmoid approach. Don't need Petroso approach. It's a very important situation. Now it's coming for a new issue to show the importance of the temporal bone. This guy come to me, facial palsy, no hearing, swallowing difficulties, hypoglossal nerve deficit from the 7 to 12, and had this big tumor in the jugular foramen, very large tumor in the carotid body. What you should do? Send to radiation, send home to die, tell I cannot do anything for you. What's our job here? Understand the pathology, understand the anatomy, and follow the tumor. There is one tumor that is here and another tumor that's here. If you understand the anatomy here and follow the anatomy, you can understand the tumor and try to treat. Follow the anatomy in the neck. Follow the tumor inside the vein. Do the petrosectomy. Expose the facial nerve. Then remove the tumor. Here was the tumor in the carotid body, the big one here. External, internal, 12, ANSA, hypoglossal. The vein, tumor out. Tumor inside the vein as a jugular foramen paraganglioma. Tumor in the posterior fossa. Tumor around the petrous apex. Facial nerve exposed. The patient has facial nerve palsy. Carotid artery exposed. If you do and go around understanding the anatomy, you can do. And the pre-op is this and post-op this. How many hours surgery? The hours that the patient needs to be cured. One thing that I learned with Dr. Omefti, and you as a neurosurgeon, and you as a young neurosurgeon should have in your life. Give 1 day of your life to save the life of the patient. It may be the most important issue of this. Sometimes came tumor like this, they did a biopsy, it start to through the ear, it start to bleed, everybody became nervous, the ENT was confused, sent the patient to us, and came patient like this. And we did surgery, we exposed the tumor, we exposed the ICA, we exposed the 12, so the 11. This is the last case. Okay, you expose the area. You remove the tumor, remove the posterior fossa, remove this part, and reconstruct. Different ways to reconstruct. Why this incision? Because our friend ENT decided to do a biopsy just behind the ear. I couldn't do my incision back here. I should change the incision to understand. I believe that neurosurgery is this. I love meat, I love wine, I love food, I love neurosurgery. If you do neurosurgery with passion, you do with pleasure. Neurosurgery is teaching, neurosurgery is understanding, neurosurgery is life. Thank you very much, Professor Cato. Sorry for the long time. See you in Rio now is March 2022. The pandemic changed it to the 22, and everybody will be there in the beautiful city of Rio de Janeiro. Thank you very, very much.
Thank you, Professor Borba, for that excellent talk on the temporal bone and on skull-based surgery. It's indeed a great education for young neurosurgeons. Thank you so much.
Thank you.
I would now like to invite Professor Mohammad Qureshi, who's the president of the Continental Association of African Neurosurgical Societies, chairman of the Neurosurgical Society of Kenya, and treasurer of the Kenya Society of Epilepsy. Professor Qureshi, can we have your lecture, please?
Thank you very much. It's been a pleasure listening to everyone, seeing Anil Nanda, Franco, Yoko. Thank you, Sridhar, for this invitation. And it's an honor and a privilege to speak to everyone. I hope you can see my slide.
Yes, we can, but we can't see you.
Yes, unfortunately, for some reason, my video does not come on. So I was having the same issue before, but maybe that's a good thing, I wonder. That's fine. I'm glad you can hear me. I do apologize. For some reason, my settings may be the problem, but I can't be seen. So, but it's a pleasure seeing everyone. I can see Yoko. I saw Eka's beautiful talk, and Anil Nanda, as usual, master of lectures. And really, Dr. Borba, it's been amazing to see what you can achieve through the temporal bone. I was asked to give some address, and I chose because of our passion in trying to develop neurosurgical services in sub-Saharan Africa. I wanted to use this opportunity not only to share with you what we've been trying to do over the past 2 decades, trying to move neurosurgery from very humble levels to its current, I would say, reasonably respectable levels. And those of you who have been to Africa will proudly be able to say that you were involved in this neurosurgical development, because we could not have done this without collaborative initiatives from across the globe. And a lot of people who are in this have been involved in this development. I can very comfortably say that Professor Yoko Kato, who is listening here, has been instrumental. I would like to thank Talat Kiris, who I know is on the talk, for his role that he is playing, and many other colleagues from the Asian Congress and the World Federation and the Foundation, who have been instrumental in helping us. So without further ado, I'll just share with you the challenges of developing neurosurgery in sub-Saharan Africa. And as you will see from this map, Africa seems to be amongst the slimmest of our continents. And that is slim because of the low number of physicians and medical staff overall. But neurosurgeons for a long time had been exceedingly few in this area. And as a result, we started some kind of initiative back in 2001. I, as the chair of the Neurological Society of Kenya, almost felt it a moral responsibility to try to develop neurosurgery. We were 3 neurosurgeons at that time for a population at that time of 20 million. And for some reason felt that my purpose in life perhaps is to develop neurosurgical services, not only in Kenya, but in our region. So we set up with our Kenyan colleagues a neurosurgical mission, which then began conducting missions across East Africa. And we would do this from our volunteer time once a month, going to the coastal city of Mombasa and other cities around the region. But this cannot be done by a one-man or a one-team show. So we took upon the 17th goal of the Sustainable Development Goals, the so-called global goals, which aims to revitalize a global partnership in order to achieve not only a short-term, but a sustainable development. And I really wish to thank these fine gentlemen who took their time all the way from Brazil. I think, Dr. Goborba, you will recognize Hildo Azevedo, our good friend Yoko Kato, who actually, while I'm on this, might share with you that she's only one of two people who have been given honorary president position for the Continental Association. Professor Majid Sami and Professor Yoko Kato rightly are honorary presidents of Acns. So in 2011, Drs. Peter Black, Armando Basso, Yoko Kato, Hildo, and Eka was there as well, came visiting Nairobi for their WFNS symposium. And as a result of that, that led to a huge amount of support from the WFNS Foundation, and they started visiting us. And this has culminated in the foundation and the WFNS being very much involved in the development of neurosurgical services in the east, central and southern part of sub-Saharan Africa. So really, I do want to use this as an opportunity to thank those who have been involved in developing neurosurgery. The support of the Asian Congress has been remarkable. Here is Professor Yoko Kato on the left, operating in a very small hospital in Dar es Salaam, Tanzania in 2013. And this was with her team that came. We all were there. Professor Robert Dempsey visited at the time from FIANS, from the USA, and she and our colleagues managed to clip the very first aneurysm in Dar es Salaam in 2013. So we've had a long relationship with the ACNS, and we really want to take this opportunity to thank you. You will see a lot of members of the Asian Congress in this picture on the right. This is in collaboration with the WFNS Foundation and the Asian Congress, where we went to support our first neurosurgeon that we had trained through a regional program that came about as a result of collaboration. And this was in the city of Mombasa. And I will not take time, but I wish to acknowledge the presence of Professor Keki Turel, Professor Vladimir, Miguel Arias, Professor Yoko Kato, and many, many of her colleagues, Salman, Imad, all of them, Ramesh Nair, everyone, Aipe Cherian was there, all of them traveled many, many thousands of kilometers to come and support neurosurgical training in that course. And this has been going on for a long time. This is to show that the Asian Congress was again involved in teaching. This was the WFNS microsurgery course that was held in 2013 when the first aneurysm was clipped. But the young neurosurgeons were there. This lady, Zarina, is now an established neurosurgeon. She was trained through the Africa 100 program, which we will hear about. At that time was a young resident interested in neurosurgery. So there was Ling Feng, who also came, and really Apio Antunes was also there from Brazil. These are people who have really helped us in developing neurosurgery. Zeiss company was obviously very much involved, but thanks to Professor Yoko Kato and the WFNS Foundation request, a full Pentero was actually brought all the way to Africa, and for the first time it was being brought to those shores where surgery was then conducted. The WFNS Foundation, the Yoko Kato Foundation, and the Asian Congress have really moved things for us in sub-Saharan Africa. This is a trainee of the College of Surgeons of East Central and Southern Africa, who is in Uganda, and in a very small town called Barara, there is a teaching hospital and a teaching university, but they did not have a neurosurgeon or neurosurgical equipment. This is David Kitia, who, along with aneurysm clips and sets provided generously by the WFNS Foundation and by Professor Yoko Kato, was able to assist this patient who presented there with a third nerve palsy, courtesy of a microscope that was also donated through the WFNS Foundation and through personal support of the Yoko Kato Foundation. So the global partnership of the WFNS Foundation, the Continental Association, and the Asian Congress, with the Yoko Kato Foundation, the Foundation for International Education in Neurosurgery, the government of Kenya, and the College of Surgeons, all contributed to this collaborative initiative that has seen the development of neurosurgery in sub-Saharan Africa. This was the second course that took place where Professor Miguel Arraez and Professor Yoko Kato came to support this young neurosurgeon in the foothills of Mount Kenya. Looks a little bit like Mount Fuji, but it is Mount Kenya. And this is a mission hospital where in modest operating theaters, neurosurgery can now be conducted as a result of the initiatives of very many people across the globe. And this is the first neurosurgeon that was trained through the College of Surgeons of East Central Southern Africa and is now supporting neurosurgery for a population of about 4 million people in the Mount Kenya region. So the key moment in African neurosurgery from 1997 to 2005 cannot be mentioned without mention of two great gentlemen, Professor Kamlishi of Rabat and Professor Majid Sami, who in 1997, when he became president, initiated a push for neurosurgery in lower middle income countries. And when he heard Professor Kamlishi giving his talk on what the numbers at that time, he made his focus for neurosurgery to be supporting Africa. He therefore initiated the Africa 100 initiative in 2012 with the WFNS. Professor Majid Sami spearheaded this initiative with the aim of training within 10 years 100 young African neurosurgeons. Whilst it was an ambitious project focusing on quality assured neurosurgical training, aiming to tackle the workforce crisis in African healthcare, the focus has thus far been on Francophone countries in Africa, which is training Africa 100 candidates through Algeria and Morocco. And the main centers that have accepted candidates for training are currently in Morocco and Algeria, but the Africa 100 also accredited Nairobi in Kenya for acceptance of candidates. So thanks to this, another initiative, huge initiative by Professor Majid Sami, we are seeing further development. A selection committee was formed, and we had Graham Fegan from South Africa, Kazadi from Zimbabwe, Mahmoud Raji from West Africa, Sidi Said from Algeria, and Professor Kamlishi from Rabat as the African committee. That is myself. The video is not being shown, so you might want to see this was then supported further by Professor Ling Feng, also a member of the Asian Congress, and INI China, who then negotiated with 19 universities in China as part of the Africa 100 external program. with the universities providing the stipend and accommodation, meals for candidates. And already we have 29 candidates who have applied for this program in the Africa 100, and they've applied from sub-Saharan Africa, and already there are candidates who are training. Some of them had to stop their training because of the COVID situation, but many are still in China continuing with their education. This resulted from a high-level meeting on the China-Africa Health Cooperation at the third Beijing Forum in 2017, which has resulted in a well-structured plan for partnership as part of the Africa 100 program. A memorandum of understanding was signed on behalf of senior administration, the Continental Association, and the WFNS Foundation, along with the China-Africa Medical Specialists Forum, resulted in this initiative becoming successful. Professor Majid Sami again was here in 2012 with Professor Ling Feng of the Asian Congress and the WFNS Foundation, and the Nairobi Declaration was made at this meeting in Nairobi, where there were representatives from across Africa and the WFNS Foundation, and resulted in the Continental Association of Neurosurgical Societies being launched in 2012. And really, the WFNS Foundation support for Sub-Saharan Africa, the Africa 100 project, was enhanced through these initiatives, both the China-Africa program and the formation of the Continental Association. This resulted in a very successful Continental Association African Neurosurgical Societies Congress in Algiers in 2014, followed by a hugely successful meeting in 2016. And here we see Professor Majid Sami with Ms. Zarina, who is now an established neurosurgeon, the first lady neurosurgeon, the first recipient of the first lady who qualified through the Africa 100 program. Professor Savade was there giving us his support, and so were many members of the South African societies. This I think we've mentioned, the support, as I said, has come from all across Africa, and for some reason it is repeating. We will move on. The support has led to the formation of a neurosurgical training program, which is now being run by the College of Surgeons of East, Central, and Southern Africa. And this is a 6-year program now, which has come as a result of support from all the various groups that we are acknowledging today. And we have had candidates from Uganda, Ethiopia, Kenya, and Tanzania who are offered WFNS Foundation scholarships in order to train. We acknowledge the support of Professor Basant Misra, who accepts these candidates for training in his center. And we've also had the opportunity to send our candidates to Izmir, Professor Zileli, and Valencia in Europe, in Spain, where these candidates get an external rotation. And this is now the 2018 ceremony, where 10 graduates trained had passed their neurosurgical fellowship as a result of training through initiatives that I mentioned abroad. And this has impacted many centers, and many of these young graduates have now had the opportunity to start neurosurgery in their various regions in East Africa. For example, this is the first surgery being conducted in a hospital 400 kilometers away from Nairobi, where the first brain surgery was carried out as a result of one of the COSEXA candidates being posted there as a neurosurgeon. And the program was evaluated by Peter Black and received a very positive review and is published in the journal of the World Neurosurgery Journal, giving a very positive report on the program in East Africa. The Foundation for International Education in Neurosurgery is another key partner that has helped us immensely since 1996, and I do wish to acknowledge. Part of that is Professor Michael Hagland from Duke, who has single-handedly turned around the fortunes of neurosurgery in Uganda through his work in Kampala, the capital, and Mbarara part of that country. It cannot, development of neurosurgery through global initiatives cannot go without mentioning Professor Roger Hartle of Weill Cornell University, who has again developed a very successful program, now offers a global neurosurgery fellowship based in Tanzania. And that really has changed the fortunes of neurosurgery in this part of the world. He conducts regular missions on the shores of Lake Victoria in Tanzania, and this is amongst the teams that have done missions and conduct teaching courses in sub-Saharan Africa. Cure International, through Professor Ben Wolf, is world recognized because of this small hospital. It was a 34-bedded hospital when Ben Wolf started doing work on hydrocephalus in this hospital. And as we all now recognize, very high-level research publications have come out from this small hospital because of this collaborative initiative, now with Harvard and Boston, because now he's a professor there. But at this time, when we started the program in 2004, Ben Wolf was working at this hospital in Bale, Uganda, which has, as I said, produced landmark papers in the management of childhood hydrocephalus. Another key supporter has been the Neurosurgical Education Development Foundation based in Spain. Professor Jose Piquer with Professor Paul Young of St. Louis has been instrumental in developing neurosurgery in this part of the world. And this regional partnership has really been painstakingly developed through Uganda, Tanzania, Rwanda, Kenya, Sudan, Zimbabwe, and Ethiopia to achieve the kind of work that we are now able to do. This is actually the only, first and only humanitarian, purely neurosurgical hospital that was built on the island of Zanzibar as a result of this collaboration with Neurosurgical Education Development. And this was the construction of this unique institute on the shores of the Indian Ocean in Zanzibar. And it is based in the public hospital, but this is a 34-bedded, purely neurosurgical institution that is offering free neurosurgery, high-level neurosurgery to individuals in this region. This collaborative achieved, as I said, the first dedicated neurosurgical hospital in sub-Saharan Africa, and it conducts teaching courses regularly. It stopped because of the pandemic, but it was acknowledged by the government, and this is the president of the Zanzibar, president of Zanzibar, acknowledging the support of the international community in helping develop this hospital, and particularly the NED Foundation that was responsible for this hospital. So from very modest surroundings, where people like Professor Shizuo Oi, scrubbing in an operating room in the Tanzania, has developed into a class hospital offering humanitarian neurosurgery with modern microscopes, neuromonitoring, there is neuronavigation, now available in a place like Zanzibar, where in 2004, the only sophisticated instrument was a shunt introducer when I first went there to operate. So really, we've come a long way because of these initiatives. We do want to acknowledge a very key partner in helping sub-Saharan Africa, and that is the University of Cape Town in South Africa. 10 neurosurgeons from the East Central Southern African region of Sub-Saharan Africa have benefited from training at the University of Cape Town. And this has really developed development of neurosurgery in our region. And I want to acknowledge Graham Fegan and Professor Alan Taylor, who have really, amongst the other faculty based at UCT, been responsible for supporting sub-Saharan African neurosurgical training. As a result of this, apart from Cairo and Morocco, where neuroendovascular intervention was available, we are now proudly able to offer this in sub-Saharan Africa. 2 interventional neurosurgeons were trained in South Africa under Professor Alan Taylor, who's the current president of the World Federation of Neuro Intervention to develop the centers in sub-Saharan Africa in due course. This is Edwin Mogere and Dr. Amir Qureshi, who are now able to coil very complicated aneurysms in sub-Saharan Africa as a result of this initiative. The number of neurosurgeons has increased from 1992, when there was no such collaboration, to the current. At the time, we had this number of neurosurgeons are outlined on the left. The region had a neurosurgeon to population ratio of 1 to 16 million. It has now been brought to 1 to 3 million in 2019 and continues to improve as a result of this initiative. So we really have had the privilege and honor of being impacted across the WFNS, across the sub-Saharan Africa at these various sites through the support that we have received from the WFNS Foundation, the Asian Congress, and FIANS, as well as the others that I have mentioned. And the leadership of the region obviously is very grateful and gratified by this impact of this collaboration. This is the president of Zanzibar really being grateful to Professor Jose Piquer of the NED Foundation for his work in building the unique hospital. We have to mention that as of yesterday, Africa has had its fair share of corona, and whilst the global cases are 68 million, Africa has gotten away reasonably lightly, but given the problems that Africa has, it is still quite a challenge for everyone. The total deaths in Africa by yesterday were 54,543, but that should not suggest that we have gotten away without significant problems. Education was also impacted, as Franco Servadei outlined in his lecture. And more recently, the trainees in the regional program have been allowed back into training after initially being stopped through a circular. The WFNS-sponsored trainees who have no formal remuneration have been required to source their own medical health insurance if they wish to resume. So only 50% have been able to do so. The others are not financially able to do so and therefore are missing out on training. But having said that, as you can see from the presentation, we have a lot to be thankful for to the WFNS Foundation, to FIANS, to NED Foundation, to the Asian Congress, and in the Asian Congress, particularly Professor Yoko Kato, who has tirelessly worked for provision of equipment, microscopes, aneurysm clips, microsurgical instruments, bipolar sets, cranial high-speed drills, all being donated to centers across East, Central, and Southern Africa. So we truly feel blessed that we have such friends across the globe who are helping us develop neurosurgery in sub-Saharan Africa. With that, I would like to thank you very much again, and thank you for the honor and the privilege to share with you the gratitude that we feel all our partners have shown, the efforts they have shown in developing institutes offering neurosurgery in our region. Thank you very much.
Thank you so much, Professor Mohammad Qureshi. That was a really wonderful talk, an eye-opener for many of us to see how sub-Saharan Africa has developed itself in neurosurgery with the support of people from all over the world. Thank you so much.
Thank you.
I would now like to invite Professor Talat Kiris, who's Professor of Neurosurgery from Istanbul, to deliver his lecture, please.
Thank you very much. We listened excellent lectures in this opening session, and I am honored to be invited to this prestigious first virtual Congress of ACNC. I would like to thank to Dr. Chris Sridhar and dear Yoko for inviting me to this Congress. So I am starting to share my screen. I hope you can see my slides.
Yes.
Okay. So my topic is fluorescent guided neurosurgery for today. And as you know, neurosurgery started with headlamps and this huge device, the Bovicoter. I remember from my residency time, we had once in the OR, which was not working, but was there. And then Malis introduced bipolar, and Gazi Yaşargil applied microscope to neurosurgery, and our specialty made a big jump. Now we have a number of tools and devices in our armamentarium, in our OR, and we can use all of these. And I will focus on fluorescent-guided neurosurgery today. For this, we need a microscope with dedicated filters for indocyanine green, 5-ALA, or for sodium fluorescein. The other drugs are reported anecdotally, but these three are the most used fluorescein drugs. When we talk about fluorescent-guided surgery, it is a kind of neurochemical navigation and intraoperative imaging of vessels and blood flow. It is an intraoperative imaging of tumor tissue. We can also talk about photodynamic detection of tumor tissue. ICG is mainly for neurovascular use, though it's also used in tumor cases. It is reported, but the main use is neurovascular. And 5-ALA is mainly used in neuro-oncological cases, but we can use sodium fluorescein both in neuro-oncology and neurovascular. I will show you some cases. When we talk about ICG, it is a water-soluble anionic tricarbocyanine. After injection, ICG is bound within seconds to the globulins and remains intravascular and excreted by the liver. We can use it safely for video angiography. One example is this Acns case. You can see a big, large aneurysm here, A1, A2, Hebner artery, and pre and after clipping. We can control that the aneurysm is closed totally, and maybe more importantly, we can control the vessels in the vicinity. Can you hear me? Is there a problem? No. Okay, I continue. With the software dedicated to ICG, we can also see the blood flow, if there is a compromise in the blood flow or not. After injecting, we can calculate when the blood come to A1 and A2 and see the time for it. Also in AVM, it is very useful. Here a case you see, and when we inject ICG, we can see the arteries first and then the veins, and see which one is the feeding artery, which one is the vein, which one is the arterialized veins. And also with this software, we can see in colors the arteries, the arterialized veins here in yellow. And when we dissect further, we can see that the veins return to blue. And it really helps our surgery. 5-ALA is developed for tumor surgery. It is a natural biochemical precursor of hemoglobin. It evokes synthesis and accumulates in some kind of tumors with fluorescent features. When we have a dedicated filter in our microscope, then we can see these tumors as pink. Many papers show that using 5-ALA and the filter, we can raise our safe, maximal safe resection in high-grade tumors. It's an oral solution. We have to give to the patient 3 hours before surgery. Here, I want to show one example. I used about 20 cases before I left to use the 5-ALA. In the minute, I will tell the reason. In fact, it is a useful tool. When you operate, you can see the tumor tissue in the corner. But what I don't like is when you operate under this blue 400 filter, here you can see the blood vessels are not so clear. And I like to see the blood vessels even in glial tumor surgery. I think it is very important. One disadvantage is it's very expensive. And when you give the drug orally, sometimes patients vomit and then you cannot use it again. But my main concern is actually this dissection of the vessels under blue filter. So I shift to sodium fluorescein and focused mainly to sodium fluorescein. It is a salt of sodium, and it's an organic compound. Our ophthalmologic colleagues are using this now in 5 decades, almost 5 decades. But the first paper in neurosurgery came in 1948. Moore mentioned that it could be useful in neurosurgery. And then neurosurgeons tried to use it. In Japan, a dedicated microscope is developed. The mechanism is sodium fluorescein accumulates in disrupted blood-brain barrier in areas like gadolinium. Whenever we see in MRI gadolinium-enhanced tissue, we will see this in our surgery yellow when we inject sodium fluorescein. The first papers use it, reported its use with white light, but in these papers, the amount of sodium fluorescein is very high, 20 milligram per kilogram. Although there are positive impacts on extent of resection, serious anaphylactic and allergic reactions with this dose are reported. Then lower doses are used because the dedicated filter is developed. We start to use it also and publish our first preliminary experience in 2016 with high-grade glial tumors and metastasis. Here, one example close to motor area. When I do the sulcal dissection, you will see in the minute in the deep part fluorescein enhancement of the tumor, very bright yellow tumor. And when I took the tumor out, you see the normal tissue, and also it is very easy to operate under this yellow filter. Another case, an insular tumor here. After opening the Sylvian fissure, when I turn the filter, you can see the bright yellow tumor tissue here. And after resection, in the cavity, we can see normal tissue. And these are the post-operative pictures of this patient. Even cases considered inoperable before can safely be removed with the help of sodium fluorescein. In 2017, we published our experience with meningioma, and this is the first paper about meningioma surgery and sodium fluorescein filter. I found it useful mainly when I dissect meningiomas from the vessels. I use sodium fluorescein angiography. Here an example, an olfactory groove meningioma is removed, and you see here the anterior communicating artery complex. But when we inject sodium fluorescein, we can see more details here regarding the arteries. One example here is sphenoid ring meningioma. The tumor is largely removed, only one piece attached to the carotid bifurcation is here. I will inject sodium fluorescein to see the lateral, the lenticulostriate arteries originating from carotid bifurcation. Here you can see the perforating artery, and under sodium fluorescein angiography, I see the artery very clearly and dissected from the meningioma. So the postoperative view. Another case, tuberculum cellular meningioma. The tumor is going into the optic canal. I used also very often endoscopy during my surgery to see the relationship of the anatomical structures with endoscopy, here, carotid artery, optic nerve, and the tumor. It's like a sandwich between these anatomical structures. And I used to dissect here the superior hypophyseal artery from the tumor. Time to time, I inject sodium fluorescein, make sodium fluorescein angiography to see these tiny vessels, and I found it useful to dissect these vessels with the help of angiography. Another case, this was a chondrosarcoma case. It's right between the optic nerve and here carotid artery. I removed, I used bone cursor here. You see there are again the lenticular arteries. These are the medial proximal lenticular arteries arising from carotid bifurcation. Drill is here more dangerous. Bone cruiser is more safe, and slowly I dissect it and then remove bony tumor. And during surgery, I inject again sodium fluorescein, and I will show you the end of the surgery. All the vessels originating from bifurcation are intact. So I found it also useful in skull-base surgery. We also used sodium fluorescein in pediatric cases. This is also the first paper about sodium fluorescein guided surgery in pediatric population. One case is this choroid plexus papilloma. I don't want to show the whole surgery, but with sulcal dissection, I reach ventricle, and even under white light, the tumor is very bright. But when we turn the microscope, we can see very bright tissue. And after surgery, this is the beauty of sulcal dissection. It looks like untouched. And these are the postoperative views. We also use this in spinal cord tumors, and these publications are made with our Italian and German colleagues. We do together we publish in World Neurosurgery. One case, this case is diagnosed after a fall from height. And incidentally discovered intramedullary tumor. I skipped the video here. But these are the postoperative views of this particular patient. Particularly in neurovascular surgery, I found this very useful, especially in aneurysm surgery. Here you can see an MCA aneurysm. The whole anatomy is very clear. But especially when we want to see the small lenticular striate arteries, sodium fluorescein angiography is very, very helpful, much more helpful than ICG regarding these lenticular striate arteries. A coiled aneurysm 1 year ago showed coil compaction. Now, these are the lateral distal lenticular striate arteries crossing over the coils of this aneurysm. So I don't want to show the whole surgery, but after clipping, I do another sodium fluorescein angiography, and in the minute you will see that these very important lenticular striate arteries are intact, crossing the clipped dome of this aneurysm. We can use it also in AVM surgery and go back and forth. You can appreciate the feeding arteries and veins with sodium fluorescein angiography. And also in this, like in this cavernoma case, we can use this in cavernomas, practically in all vascular cases. With injecting sodium fluorescein, we can save these unpassage vessels around the cavernoma or around the AVM. When we compare ICG and sodium fluorescein, ICG is better for me in AVM surgery. Certainly we can use it in aneurysm. And with this post-processing Fluor 800 software, we can get extra knowledge about the cerebral circulation. Sodium fluorescein is better for visualization of small perforating arteries. I have very limited surgery, but we can use sodium fluorescein certainly for treating CSF fistula. I have only 2 cases. I use sodium fluorescein in 2 protocols. First is tumor protocol and the other is vascular. In tumor protocol, with the induction of anesthesia, we inject 2 to 3 milliliter, 10% sodium fluorescein. And after finishing our craniotomy, we can see the tumor very nicely fluorescein enhancement, especially when the tumor shows gadolinium enhancement. In low-grade astrocytomas, it is unfortunately not useful. In vascular protocol, we inject 0.5 to 1 milliliter every time to see these perforating arteries, passage arteries, or the arteries around the tumors, around the meningiomas. About 5 to 10 times we can make this injection, but this is not like ICG. We cannot make video angiography and watch this. So during surgery, we have to inject and watch the details. Certainly, this has also pitfalls. After we start our surgery, we do iatrogenic trauma, and after 1 or 2 hours, these areas also enhanced with sodium fluorescein, so we can see these areas also as pathological tissue, but in most cases, after 1 or 2 hours, I'm talking about glial tumors, we will remove these tumors. We have to keep in mind that dura and ventricular ependyma also shows fluorescein staining, and when we do surgery for high-grade gliomas, we have to keep in mind that radionecrosis and scar tissue will also enhance with sodium fluorescein. As a conclusion, a dedicated microscope with yellow 560 nanometer filter, we can use this technique. 10% sodium fluorescein salt is used, 2 to 5 milligram per kilogram body weight. Very important, this use is off-label, although I used it now more than 700 cases, and I didn't see any complication regarding sodium fluorescein use. And we have a European network of fluorescein neurosurgery, and now we have lots of cases in our pool. It is still off-label use, so we have to tell this to our patients. And I found it really very beneficial in neuro-oncologic and neurovascular surgery. I would like to thank again for inviting me to this very important Congress, and hope to see all of you physically in the near future.
Thank you so much, Professor Talat Kiris. That was an excellent lecture on fluorescein and the uses of fluorescein in neurosurgery. Thank you very, very much. I now have great pleasure in inviting Matron Yi Ching, who's the honorary president of the Asian Congress of Neuronursing. Neuronursing is very, very important, as we have heard many of our speakers, especially Professor Yoko Kato, speak. And in our conference, this has been given a very special place, and therefore I would invite Matron Yi Ching to say a few words, please. You need to unmute, Matron. You're muted. You're muted. You have to unmute.
Can everybody
Yes.
hear me?
Yes, yes.
Good evening to all. I'm honored to be given the chance to speak. First of all, I'd like to thank Professor Yoko Kato for the opportunity given to be as one of the honorary president for ACNN. On behalf of the neuro nurses, I wish to thank Professor Sridhar for the continuous support and for the wonderful program that has come up by him and the team for this wonderful meeting. And all of us nurses, so that we can move forward and enable us to be better, knowledgeable, and competent nurses with one common aim to improve ourselves and to deliver good quality care for our patients. Special thanks to Prof. Kato for the continuous support that has been given to all nurses from the first ANNS and ANNC. There is the first Asian Neurosurgical Nursing Congress, which was held in Malaysia, and the second in Turkey. It doesn't stop us from there. We continue to move on to the third ANNC that was held in Kazakhstan, the fourth in Jakarta, and the last one supposed to be this year, May, in Kazan, but was postponed due to COVID pandemic. And I hope that will not stop us from continue our congress, and I hope we nurses will be given more opportunity to be recognized as neuro nurses globally. This is the first ACNN which was held in Jakarta 2019 under the supervision of Prof. Eka and his team. Special thanks to Prof. Eka for his continuous support for the nurses. And the second one, Prof. Shida, just have this year, February 2020, and with such a big crowd of nurses. Thank you very much, Prof. Again, you can see Professor Yoko Kato is always there to support us nurses. Thank you again, Prof. Kato. And now, today, the third ACNN again in Chennai, and I hope all nurses will have a fruitful meeting, and it is really make a real one. This is the first virtual meeting, and it is almost a real one as what Prof. Shida has spoken to us before. And last but not least, I wish all of you a fruitful meeting and looking forward to meeting all of you again in the near future. Thank you very much.
Thank you so much, Matron. It's wonderful having you and all the neuro nurses with us in this virtual meeting. Thank you so much.
Thank you.
We now are coming to the end of the inaugural session. I would request Professor Balamurugan, the Secretary of the ACNS, to propose a formal vote of thanks. Professor Bala?
The host has muted me, stopped my video. Yeah, can you hear me?
Yes, we can hear you.
Yeah, sure. So thank you very much, Dr. Sridhar, and thanks to Professor Kato, who has the faith in us to do the first virtual conference of the Asian Congress of Neurosurgeons. And thanks to the entire team members who put together this excellent program. Thanks to Marandishwara Enterprises, who came up with this excellent facilities to ensure that the conference runs on time, and has been great support right from the beginning, giving us ideas how to go about it and ensuring that it runs without a hitch. Thanks to Professor Franco Servadai, thanks to Professor Anil Nanda, and all the people who participated in the inaugural session. Thanks once again to all the sponsors, including Linux, Leranon, and other companies which really helped us do this. And we hope to see you on all days in all the sessions. And we would request all the seniors to encourage the postgraduates to attend the conference over the weekend. And as Professor Sridhar said, the conference also has CME credit points which have been done. And so whoever is registered will be getting their CME credits also along with the certification. So please feel free to contact the conference secretariat for any of your details which you would request. And thank you so much once again for being part of this first virtual seminar of the Asian Congress of Neurosurgeons. Thank you.
Thank you, and see you all tomorrow morning, 9 a.m., where we have the Young Neurosurgeons session in one hall. In the other hall, we have the award papers, and in the third hall, we have the neuronursing meeting, which will also start. So, Professor Kato, you have any words to say?
Yeah, I thank you so much. It was real nice inaugural session. So which was organized by the Sridhar and your team. I really appreciate the first day. And also the not the hands-on, but also the virtual workshop. That was a great support for the young doctors. Thank you so much. See you tomorrow.
So see you all tomorrow morning.
Thanks. Bye.
Thank you. Bye. Bye.
Bye-bye.
Bye.
Bye-bye.
Thank you, Professor. Thank you.
Thank you.
Yes, doctor. Yeah. Quite comfortable. Tomorrow will be